Kamal Hassan acted in Telugu, Tamil both. So I learned both languages. Yeah. No, 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 no. No, only Janaki. Janaki தான் act பண்ண முடியும். No, actually, I've demonstrated in Hyderabad, in Dr. GVS Rao's hospital, and then Mohan Reddy's hospital, and Meghanath's hospital. I've demonstrated. And Care Hospital, Banjara Hills, Vishnu Reddy, he's my friend as well. So, back கொடுங்க. nostril appears red to me than usual. I think you all agree, isn't it?
Yes, sir.
Yeah. So I personally prefer injection in the axilla, but in this case, I think I'll be able to see the axilla only after I remove the polyps. To actually quote Janki Ram, once I luminize the airway, dressing forceps. இது ட்ரெஸ்ஸிங் ஃபோர்செப்ஸ் கூட இருக்கம்மா டில் யா இல்ல இல்ல ஓகே இத பரவாயில்ல இதை யூஸ் பண்ணலாம் நோ ப்ராப்ளம் the solution I'm going to use is a solution which Dr. Madhavaya taught me long back 35 years back straight Blakeslee yeah 45 degree kuda vechidunga sometimes I use yeah I'll be using. So the solution which I use, I take 10 ml of 2% xylocaine and add 8 drops of adrenaline on a 23 needle. These 8 drops come from 23 gauge needle. And then I use a 26 gauge needle to inject. The polyps are looking a little red. I think it is due to squamous metaplasia. You are getting a good endoscopic picture? Hello? Are you getting a good endoscopic picture?
No, sir.
You're not getting the endoscopic picture yet, huh?
No, sir.
We are getting the picture from the external camera.
Yeah. Wait.
Yes, now we are getting, sir.
Yeah. Local?
Yes, sir. Sir, shall I start with the session? Can I
100%.
introduce the panelists?
Yeah, please go ahead.
Yes, sir. A very good morning, one and all. Welcome to the day 2 of this surgical feast. Yesterday, we started our day with Dr. Keetane sir and Sangeeta ma'am demonstrating his cochlear implant. Then Prathamesh Pai sir did a parotidiectomy, followed by Nupur ma'am showing a wonderful case of laryngeal respiratory papillomatosis. Nearly 5,000 doctors across 90 to 94 institutes attended the workshop. Today, we are kickstarting the session with Dr. Deepak Haldipur sir demonstrating a case of extensive nasal polyposis. I would like to invite the panelists for this session, Dr. Captain Sudarshan Reddy sir, former HOD in Government ENT Hospital, Dr. Sri Prakash sir, Chief ENT Surgeon at Microcare ENT Hospital, Dr. Venkat Ravi Reddy sir, and Dr. Bhargav Yadav sir.
One and a half.
Dr. Archana will be
Back.
Dr. Archana will be introducing Deepak Haldipur sir.
Good morning, all of you. Today, I have a privilege of introducing one more versatile personality, Dr. Deepak Haldipur. Sir is internationally renowned ENT surgeon. He has immense experience spanning across over 3 decades in the field of otolaryngology and head and neck surgery. He is a past president of Association of Otolaryngologists of India. He has performed live surgical demonstration as guest faculty in academic events worldwide. He has contributed various articles in distinguished journals, and he has organized innumerable workshops, CMEs, conferences at regional, national, and international levels. He is an active member of various prestigious otolaryngology associations like the Indian Society of Otology, Indian Society of Rhinology, Sinus Endoscopic Society of India, and the Cochlear Implant Society of India.
Deep Rider Zero Blade put.
And believe me, when we look at him, we feel he is a silent person, but he is very jolly and active, enjoying the person when we have seen him yesterday evening. So with this, I request Dr. Purva to take over further proceedings.
I would like to present the case. OT, can they relay the case? A 28-year-old male resident of Hyderabad presented to ENT OPD with the chief complaints of nasal obstruction right more than left since past 3 years, complaints of smell disturbances since 2 years, history of rhinorrhea present, history of nasal twang present, and patient had frequent sneezing episodes And there was a history of headache and facial heaviness on bending forward, and there was a history of postnasal discharge. There was no history of visual disturbances, no history of COVID, no history of COVID vaccination. Patient attained menopause at the age of 45 years. No known comorbidities, no known previous surgical history. On DNA examination, there was DNS to right. There was, as we can see, there was a pale glistening polypoidal tissue seen occupying both the nasal cavities. Probe test, it was the polyp was insensitive to touch. Probe can be passed all around except superiorly, and there was no bleeding on probing.
Good.
There was decreased misting on the right side compared to the left. Rest of the ENT examination was normal.
Anyone point?
Over to you, sir.
Best. Oh, yeah. Camera, inge CT scan ki camera varanum.
Sir, over to you.
Hello.
Yes, sir.
Yeah,
Please.
who are the moderators for the session?
Sir, I am Dr. Bhargav Jadhav, Associate Professor at Shiusha Medical College, Surendranagar, Gujarat.
Yes, sir. I will call you Dr. Jadhav.
Haji, sir. Yes, sir.
Yeah, who else is there, sir?
Others are coming.
Okay. ठीक है. That's good. See, yeah, just push this glass a little bit. That's it. I think we'll start with reading the CT scan.
Yes, sir.
Yes, sir.
Yeah, I think inge focus pannunga. I think idu edutidunga oru nimisham. Take off the glass because then I will again. Yeah. Shall I start reading the CT scan?
Yes, sir.
See, for all of us, when we read a CT scan, the coronal cuts in a CT scan are like idli vada for us South Indians or Indians, because our morning breakfast, everywhere, wherever we go, we are very comfortable with idli vada. Similarly, for ENT surgeons, whenever we look at sinus, no matter axial, coronal, everything, we are first most comfortable with coronal view. Because the coronal view is the surgeon's view as he goes into the nasal cavity to operate. The parasagittal and the axial, of course, complete the picture. So let me start with the coronal view. In the coronal view, before I start my demo at the outset, first thing is, I would like to thank Dr. Janki Ram and Professor Kirtane, who are the main architects of this course. Now, Janki Ram needs no introduction. He's the most charismatic, big star of ENT in India and the world. And as I keep saying, and which Kirtane sir also puts it, he once told me that Janki Ram and Satish Jain are in a different stratosphere. This is the word he used. And to me, it's a very, very important moment in my career that Janki has called me as a faculty to his workshop, and the man who is a master of his sinus surgery and skull base has given me an opportunity to demonstrate a case of polyps in his theater. Which means, I'm sorry to be saying this, it's like me trying to demonstrate a polyp in his presence anywhere here. He's like man doing something in front of Joke Falls. So I would compare it to that. So anyway, that is one thing. And Kirtane sir, I remember the amount of struggle I had to put in 1996 to attend his course in Hinduja, where he selected me as a delegate at that point of time, where I also met Satyaprakash Dubey, my good friend.
Anna, vanakkam na.
Vanakkam boss, vanakkam.
Morning, na.
So I think thank you to Janki as well as Kirtane sir. I must also confess, though I have been doing FES since 1994, that is 28 years, when you know that Janki Ram is somewhere around and Kirtane sir is somewhere around, it is an unnerving experience for any surgeon to demonstrate endoscopic sinus surgery. With this introduction and a thanks to Sun Pharma, I will start with the reading of the CT scan. And I personally feel most of us, 90% of us, spend about 5 to 7 minutes to read the CT scan. When I start with a coronal cut, the first thing I always look at is the nasal bones. And the moment I see the nasal bones, next thing I look at is the septum in its upper part. Because if in the upper part, if the nasal septum is pretty much in the center as it is in this case, with maybe a slight tilt towards the right nostril, it means my approach towards the frontal sinus is going to be technically comfortable, at least till the frontal beak or the frontal recess. And here I can also see that the two frontal sinuses are roughly equally pneumatized, the right one being bigger than the left, but both are well pneumatized. As I come posteriorly, I can see a couple of agar nasi cells here. The moment I see a couple of agar nasi cells, it means I can be a little comfortable that I will get space in the frontal recess. This is not a narrow frontal recess. And as I go posteriorly again, I keep on following posteriorly. I see the anterior-ethmoid artery here or the Kennedy's nipple here. Again, Janki, knowing my limitations, has selected a very good case where the anterior-ethmoid arteries are running along the skull base. They're not hanging on a mesentery. The frontal recess is also roomy. I expect a couple of agar nasi cells, probably tier to 2 cells, one and one above that. So 2 agar nasi cells on both sides, and probably a medial drainage pathway. Because of this extensive polyposis and a bit of whiteout, we are not able to clearly appreciate the insertion of the uncinate process. But my experience tells me that probably I have a medial drainage on both sides. As we go behind, once we go beyond, the area anterior to this anterior-ethmoid artery is a supraorbital cell. And you can see here also in the axial cuts that we do have supraorbital cells here. And you can appreciate the frontals, both sides, well pneumatized, roomy, and of course filled with polyposis. So one thing now I know is frontal sinus, definitely there is a good amount of space. Number 2, there are 2 agar nasi cells on both sides. Number 3, even the skull base. It's a good skull base. It's not very deep. You see the lateral lamella, you see the W here. The skull base is also pretty much friendly. I think Janki has used all his kindness in selecting a case for me. He knows me well. He knows my limit.
Sir, actually, I should thank Dr. Anand Acharya, sir. Is he here?
Yeah.
Dr. Anand Acharya, sir.
Yes.
Okay. For this wonderful case, thank you very much, sir.
Yeah. And as we go from the W, if you keep going back, you can see that W in this cut actually becomes a gentle U. You see the skull base here, it's a W. It's a gentle U, which means we have entered the posterior ethmoids. The moment we entered the posterior ethmoids, you can see the superior turbinates here. And again, to our good fortune, the posterior ethmoids seem quite spacious. There is no problem. And you can see many factors which tell you are in the posterior ethmoid. Namely, one is the presence of superior turbinate. Second, the skull base becoming a gentle or a flat U. Number 3, the orbits, which were looking round and big in the anterior ethmoids, you can see they got smaller and compressed and they become more square or quadrigonal, whatever you would call it. And number 4, of course, in good cases where there's no whiteout, you can appreciate the middle turbinate inserting into the lamina papricea. But in this case, that would be a little difficult to see. As we keep going back, keep looking at the septum. This point, the septum is gently bifurcating. And here it is bifurcating, and you can now start seeing the shadow of choana, which means here we are transiting from the posterior ethmoid to the sphenoid. And the moment we come into the sphenoid, you can see the right sphenoid is smaller, the left one is bigger. And if you see in the parasagittal cut, you can see that the sphenoid, left one is bigger and more superior, and the right one is smaller and inferior. The left one is overriding the right one. That you can also see. I think this mic is going loose. I think this is just going loose, I think. Huh? 1 minute. So basically, the sphenoid again are pneumatized. I can't say very well pneumatized because you can see the absence of lateral recess. There is no lateral recess here. And if you can also appreciate, there is some amount of thick bone here and osteitis, what I call as neo-osteogenesis. Again, a sign of chronic allergic fungal rhinosinusitis, where you have this neo-osteogenesis, which makes the sinuses a little small, but they're roomy enough to open. And finally, what all I would look at? The intactness of lamina papricia. You can see this is more of an artifact because of the nasolacrimal duct. Otherwise, you can see the lamina papricia is intact. That is number one. Number two, the optic nerve is not dehiscent inside the sphenoid, and neither is the carotid dehiscent inside the sphenoid. So to summarize everything, because ultimately a CT reading in a FES case or in any high volume center anywhere, you should be able to read the basics in about 5 minutes. So to summarize in this case, before I get into the case, number one, please. Number one, both frontal sinuses are fairly well pneumatized. Number two, the frontal recess is spacious. I have 2 agonized cells on both sides. The frontal beak is a little thick, but it's not coming in my way. The anterior-ethmoid artery is running on the skull base. The lamina papricia is intact. The posterior ethmoids are roomy. And the sphenoid, the right one is smaller and inferior. Left one is bigger. Lateral recess not developed at all. There is some amount of neo-osteogenesis. The septum, especially the upper part, overall is fairly central with a gentle tilt in the middle part towards the right. And the anterior-ethmoid artery is on the skull base. Now, sometimes, this is one point I want to add. Occasionally in life, you get into a theater, everything is ready, the patient is under, and then suddenly you are told actually that the patient's relatives have not got the CT film. Sometimes they might have come from a far off distance. Then either you have to abandon the case or try to get at least a X-ray PNS done. A good X-ray PNS will tell you whether the sphenoid is pneumatized or not, and the frontal sinus is developed or pneumatized or not. Once you have these two informations, you go ahead thinking that this patient has a dehiscent lamina papricia, patient has an anterior ethmoid artery hanging on a mesentery, think that the optic nerve is dehiscent, think that the carotid is dehiscent, and think that there's an onodi situation on both sides. If you go with those techniques correctly, you can still save that day. I'm not saying that please do FES without a CT scan. No. On a rare day, when you have the CT but not at access, majburi, then at least you need an X-ray PNS. Because if the frontal is not at all developed and there's agenesis, you can't be poking in an area where there's nothing available. So with this take and taking, I
Wonderful
call it,
wonderful reading of the CT scan, Deepak ji.
Yeah.
Excellent, excellent. So the main carry home points you were emphasizing,
yes,
look at the frontal sinus,
yes,
look for laminar
Yes.
dehiscence, anterior ethmoidal artery,
yes.
and then
Carotid optic,
optic.
carotid optic and access to the frontal recess looking at the septum
Excellent.
and the thickness of the frontal beak. If you have this much information, usually I think you should be able to then traverse through further. So taking Sita Rama's name, Janki Ram, we also call him Sita Ram. So yeah,
Excellent, excellent, sir.
yeah, we start. Yeah. And one more thing which I found, Janki, in the case
Yeah.
is that the polyps are a little red, but luckily bilaterally red, which
Ah,
means it could be squamous metaplasia because of the projecting polyp outside the nose.
yeah,
But in any case, it's worthwhile taking a biopsy
yeah.
and always to keep any malignant change or occasionally inverted papilloma in mind, though inverted papilloma is very, very rarely bilateral. I have not seen.
Yeah.
I don't know whether you have seen in your vast experience any bilateral
Yeah, yeah.
inverted
We have
papilloma.
seen, but very rare, as you said, very, very rare.
Yeah, yeah. Is the
Picture
focus
quality is
okay,
very good,
Janki?
sir. Excellent
Yeah.
quality.
Yeah.
Excellent. What have you used for packing, sir?
Packing, I've used undiluted adrenaline.
Oh, excellent, excellent.
Yeah.
Sir, a lot of medical colleges are watching it because I think this is the commonest case everybody does FES for.
Yes, yes.
So I think this will be a very good teaching
Yeah.
case?
Yeah.
Because it's the commonest indication.
Yes. Here it's kind of decongested a little bit. Beside it's still a red. I'll take a bit of biopsy here, Janki,
Okay,
before
sir.
I start. Small
Excellent.
forceps, ma. Straight forceps. And keep 2 packs ready, huh? I'll take a bit of biopsy from the red area. I feel it is squamous metaplasia, but still. One more bite. Yeah. Give me the pack now. This was the redder area, and also that this nostril I'm going to approach second. So I thought I'll take a biopsy, keep a pack. My bilingual skills are coming to use here, Janki, of
Sir?
knowing Tamil and Telugu both reasonably well. All because I wanted to understand Kamal Haasan movies and Brahmanandam's comedy.
Matladu,
Yes.
matladu.
Yes. And one more thing, no, Janki.
Yes, sir.
Hyderabad is a
Cheppandi.
combination between Indian cricket team
Yeah.
and Masai Mara. You know how?
Ah.
Hyderabad all along we talk of Fab Four. You remember Indian team had Fab Four?
Yeah, yeah.
Saurav Ganguly, Rahul
Ah.
Dravid,
Yeah.
Sachin Tendulkar,
Mm.
and VVS Lakshman.
Yes.
So like that we have the Fab Four here. Dr. Mohan Reddy, Dr. Deen Dayal, Dr. GVS Rao,
Super,
and Dr.
super.
Meghanad.
I
Now
hope
it
they are
has
winning
become
here.
Masai Mara because in Masai Mara when you go, if you
Excellent,
have
excellent.
I first ask you, have you seen the Big Five?
Super.
That is a group of cheetahs, you know, a family
Yeah,
of 5.
Yes,
And
sir.
the 5th one now is Sitaram or Janki Ram.
No, sir, I am tiny
So
tot.
from Fab for Hyderabad has become Masai Mara now.
Sir, but Bangalore has produced a lot of good cricketers, no, sir?
Yeah. My role model is there, Rahul Dravid.
Rahul Dravid is yours,
yeah.
no? Royal Dravid.
Yeah, he is my role model.
You
You
can
know,
never make
uh,
him out, sir. You can never. If he stand on the stump, that's all.
whenever actually, Janki,
Yes, sir.
my behavior in public is totally on admiration of 2 guys.
Ah,
One is that man from Allahabad, they call him Amitabh Bachchan.
ah,
And the second one is Rahul Dravid.
ah.
I somehow like the way they carry themselves.
Yeah.
And
Very, very
you know, I'm a
gentle and
huge,
subtle
huge,
people.
yeah.
Mm.
So let me start.
So you're decongesting with pressure and the chemical
Yeah.
action.
Yeah. But the pressure is gentle pressure.
Gentle pressure.
Yeah, because you don't want to increase the venous
Yeah.
congestion. You know, debrider. So, Bolo Sitaram, and we start. Yes.
Sir, Sudarshan Reddy garu, I would like you to chair the session, please.
Let me start. Dr. Jadhav is moderating. I think.
Dr.
Yeah.
Sudarshan Reddy garu has been
Yes.
invited to chair the session. He is the
Yes.
president of AY Hyderabad branch, very dynamic.
Yeah.
And over to you, sir.
Good morning, Deepak sir.
Yes. Good morning, Sudarshan Reddy Garu.
Thank you.
See, first I always start with the debrider looking up. You can also do with a little medial tilt like the way Janki shows it. This is the Janki way.
Yeah.
He always shows a little medial tilt. You can also do what is called as, you know, you go to the center of the polyp with a blade looking up
Yes.
and keep on removing the polyp. So basically, again, what Janki calls as luminization of the airway.
Yes.
Yeah. This whole movement is all about trying to avoid any injury to the mucosa. Stay within the polyp, stay close to the polyp. That way you will have less bleeding, you know.
Yes.
And allow the polyp to fall into the gate of your debrider.
Sir.
Don't snatch at it.
Yes.
See, because ultimately for all the talk we do, patient has come to us for nasal obstruction.
Yes.
So if you can remove the polyp, still you see the coina,
Ah,
Post surgically, patient will say, yes, I am breathing well. For him, it is his paisa vasool.
yeah.
Yeah. I am sticking to the polyp only as much as possible. And as I keep saying, it always pays to be humble in life. Even with polyps, you always stay inferior.
Sir. Are you expecting allergic fungal rhinosinusitis in this case with polyp?
Right now, no, because in the CT, I didn't see a lot of double density.
Okay.
But let us see, as we go in, we will probably make it out better. At least in the CT, I didn't see as of now.
Oh.
And so far, it doesn't appear like that. So far, isn't it?
Yes. And there was absence of mucin also.
Yes. Lots of polyps.
Ah, sir.
Lots of polyps. I told you there's a gentle deviation towards the maxillary ostium on the
Yes.
right side.
Yes.
You can appreciate that.
And what is the preparation you do before the surgery?
As usual, no, if I get time, give some steroids, give some antibiotics. And I request the anesthetist to keep the heart rate at 60. You know,
Okay.
see now, our paisa vasool.
Yes.
Now we can see the eustachian orifice.
Yes.
We can see the choana. Now we can see the inferior turbinate a bit better.
Yes.
And the ribbon gauze.
So 50% paisa vasool,
Yes, correct.
right side.
Correct.
So you said you'll use a steroid. Is it spray, tablets, or
No.
injection?
Tablet.
What is routinely used?
Deflozocort 30 milligrams. One OD for about a week or so. One more ribbon gosma. Yeah.
Sir, I just want to add only one thing.
Yes.
Sir, we are being seen right now by 48 medical colleges, starting from Madras Medical College,
Wow.
Hubli, Kim's Hospital. I cannot name everything. Sri Ram Murthy Medical College, Bellary, JSS, Mysore.
Yes.
So many, MS Ramaya.
Yes.
And 97 centers are seeing it. And
Yes.
yesterday's stall was 7,300, not 4,300. I posted wrongly.
Wow.
7,300 people have seen the live webcast yesterday. And today we are expecting more. That is what Sun is telling us. And your surgery right now is being seen by a huge number of audience.
See, you are like my wife. Yesterday, when I was traveling towards the airport, Bangalore airport, my wife told me that one plane actually did emergency landing in Hyderabad day before yesterday. I told her I am going to catch a flight and why are you telling me this? Now you are telling me about the crowd and I am suddenly becoming more nervous. Debrider. Now see, once we did this step of going and luminizing the airway,
Yes.
now what Janki keeps telling, see, keep the debrider like this,
Yes.
with the back resting on the inferior turbinate,
Yes.
with a gentle tilt towards the septum, and then you remove this.
That will also prevent
that you can
damage to
define
the
the-
mucosa.
Middle turbinate. Oh, no problem. Take this. Can somebody switch off my mobile, ma? Just put it to silent mode. I think that distracted me. Yeah.
In your experience,
Yes.
in this type of multiple polyposis,
Yes.
what is the recurrence you saw?
Almost 70-80% over a period of time.
So
It's-
we are inviting Dr. Nageshwar Rao Garu also as one of the chairpersons, Dr. Shyam Garu as one of the chairpersons. Please, sir,
Yes.
please moderate the session.
Thank you, sir.
See, the answer to your question, in this case, I am yet to find allergic fungal mucin or something.
Yes.
So the recurrence rate may be much lower, at
Okay.
least from what we see so far. I'm trying to define the middle turbinate.
Yes. Sir, I'm Dr. Nageshwar, sir.
Namaskaram, Andi.
Sir, namaste, sir. What's your experience with the sinonasal pulse in children with cystic fibrosis?
What? Oh my God! It
Yes.
is really depressing because
Yes, sir.
you have to do a wide opening of the sinuses.
Sir.
You have to literally exteriorize all the sinuses so that it drains more by gravity dependence,
Yes.
because the mucociliary activity is totally severely compromised. No,
Yes, sir.
and you need to do the sweat chloride test to confirm your diagnosis as well. Yeah, but it is really depressing, sir,
Yes, sir.
because they keep on going into their pulmonary symptoms later. So yeah,
And
suction.
in this type of cases, to
Yes.
prevent recurrence,
Yes.
what precautions you take during the surgery, and what is the post-operative management so that the recurrence rate?
One thing is to, of course, do intact mucosa technique as much as possible. And number two, to basically keep all the sinuses wide open so that the steroid irrigation or spray tries to reach there.
Okay.
Ribbon gauze.
And what is the post-operative follow-up visits?
Follow-up visit, 7th day. Of course, the pack removal is usually after 24 hours. I keep a pack in all the patients. I pack all my polyp noses at least for 24 hours. If I have done a turbinectomy along with it, like inferior turbinectomy, or I have removed the middle turbinate, which I do rarely, then I keep the pack for 48 hours, remove the pack after 48 hours, endoscopic cleaning on the 9th post-operative day, the 19th day and the 29th day. That is 7th and 17th and 27th day after the removal of the pack.
And the pack is ribbon gauze pack or Merocel?
No, I use Mirocell. Ribbon gauze, when I feel I've had a lot of oozing on the table and patient is on blood thinners and things like that, then ribbon gauze is definitely a better packing material. Because Merocell has pores, sometimes it may not be applying adequate tamponade. But around 98% of my patients, I use Mirocell.
Sir, do you give antifungals before starting?
Before, if I'm sure in the CT scan that it looks like AFRS or something, I give. In fact, I have got kind of very high regards for itraconazole and all that, because I have seen in recurrent cases, in some cases when I have given itraconazole, the polyps have vanished, in a certain subset of patients. Only thing you have to take care is do a good proper liver function test and keep doing it if you give it for a long time.
How long you give,
Otherwise,
sir? 'How long you give?
you can give it for at least 3 months. 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 3 month Only thing is keep monitoring the liver function test.
So what do you look into when you send the specimen for histopathological examination?
1 minute. In this, is it? Either
Yeah,
a malignancy either a malignancy or a inverted papilloma. That is one. And if you are looking at allergic polyposis, you can even look for fungus. You can look for eosinophils. So these are the things. The
in
bride-
post-op, how long you give the steroids?
Maybe about 1 week. If it is a diabetic, if it's a non-diabetic, 2 weeks. And the ethmoidal polyp cases, I think that is the uncinate. What we are seeing there now. That is the uncinate, I think. And this is the middle turbinate, probably.
Sir, in most of the cases post-operatively, 7th day or 10th day, the
Yes.
sinus mucosa looking like cobblestone appearance.
Yes.
Cobblestone appearance is little disappointing. And when the patient comes with cobblestone appearance, what is the cause and how do you manage such cases?
See, cobblestone, again, why don't you first give good amount of steroid irrigation?
Yes, sir.
The 7th day is not the correct time to assess things.
Yes.
Just keep on doing cleaning. Of course, some polyps are so bad, you may find some recurrence. But if you have done a good job,
Yes.
I feel I have seen it in these patients with bronchial asthma and aspirin exacerbated, polyposis. In those people, the pictures are a little disappointing. But by and large, if you do a good job,
Sir.
here the cartilaginous deviation is there. The turbinate has really become polypoidal, I am still not able to find the bony element in this turbinate. The best part in Janaki Center now I'm realizing is the irrigation. It is allowing me to continually remove the polyps without worrying much about the field. I have not taken out the scope much at all to, touch the Savlon, which I usually keep doing in my demos. I think I'll leave this area right now for a while because we are going closer to the cribriform plate here. So let me see. Yeah.
So what is the
Ex-
role of itraconazole in AFRS?
I don't know. In some subset of patients, it really works very well, sir. Especially some patients come to me obviously with being operated 4 times, 5 times, and they come back again with a heavy mind, whether operated by me or elsewhere. They say, sir, again the nose block has come. I have tried, and in some people it really works wonderfully. Wonderfully, the polyps just disappear.
And you send these polypi for fungal culture also?
Yes, yes, yes.
And in AFRS, routinely what report you will get?
Again, sometimes they say it could be some, many times you get mycetomas. So one more.
And KOH?
KOH is only relevant if you are suspecting an invasive fungus,
Yes.
in mucormycosis. Otherwise, in AFRS, KOH really does not give you much information other than getting the routine fungi anyway. So basically, I think you look more for eosinophils because that will manage your allergy management and further management of the polyps. But now my friends in the US are telling me that once this Dupimont or Dupilizumab has come in, the recurrence rates have dropped drastically. Yeah, one more pack. So right now we have removed about 80 to 85% of the polyposis. I'll pack for a while. I'm feeling a little more confident because I can see the landmarks now, especially the inferior turbinate, the septum, and the choana. These three are very, very important landmarks. If you have these three, I think you should be able to manage well. Anyway, the packs have to stay there for about 8 minutes. I will use that to take away the polyps on this side. See, this area, for example, this is more of an appearance sometimes of inverted papilloma also, which is why I took a biopsy. Okay,
Sir,
debrider.
Janki, a question for you.
Yes,
Have
sir.
you tried in the recurrent cases
Oh, loading.
double antihistamine,
No problem.
2 antihistamines, 2 antihistamines in recurrent polyps?
2 antihistamines.
7,500 RPM.
No. Oh, no.
Because some people have tried that and it has worked.
Really?
Yeah.
Okay, I've never tried. But you try Bilashur.
Sir, Deepak sir,
Yes,
this maximum medical therapy,
yes, yes. See, for me, in any polyps, the decision is when to operate. I always say this. In diabetic patients, I say 14 days of total steroid therapy per year,
yeah,
for the whole year.
yes, sir.
And in non-diabetics, it is 28 days. You can break it into segments of 2 days pulse therapy, 3 days, 7 days, whatever. If the patient's symptoms are not coming down with a 28-day course in a year, in a non-diabetic, go ahead with surgery. And in a diabetic, it is 14 days. You can't keep on giving oral steroids forever. This is my
Sir,
take. Yeah.
Sir, I am going to take questions, if you don't mind, from
Yeah,
the
why should I mind?
lot
why
of
should I mind?
questions to you. In fact, this is the only session where we have had the maximum number of questions. Reason
Yes.
is because this is the commonest case which we are going to encounter. Now,
Yes.
Dr. Tanmoy Deb, I am sure you know him.
Yeah.
He has asked 2 questions. Number 1, can you please show middle turbinate in the case you are operating? Number
Yes.
2, he has asked AFRS is an allergic
He
disease.
can see it. He can see it now
Ah.
here, which has become polypoid. Yeah. Tell me, sir.
Second question is AFRS is an allergic disease. How come itraconazole is working?
The itraconazole works on the fungus, certain set of fungus, not all AFRS.
I think I can
No.
answer this question if you
Yeah,
don't mind.
please. Yeah.
Actually, the Dr. Tanmay Videb, I know you're watching. AFRS, now there are a lot of studies. If you read the latest Scott Brown also, lot of studies of itraconazole being used pre-op and post-op, and it works wonders, as Dr. Haldipur also said. And I am sure even Meghnad sir has been using it for a long time, and also Agila
Yes.
Sami, so many people. And
No,
I was
even Madhusudan Rao.
initially a little reluctant, and nowadays I have started using itraconazole and got excellent results. And so I give 200 milligram, that is 100 milligram BD. Once I see the FRS, I start giving itraconazole, and you see most of the fungus vanishes, and in fact the bleeding also is less. You try it and see. Now the latest Scott Brown also says preoperative itraconazole, lot of studies have been done, and post-operative itraconazole also is very, very valuable. I give it for 2 months. Excellent result. If you want to add something, sir, Deepak sir, you can.
No. I think totally agree. I had that even my friend Madhusudan Rao, our common friend.
Madhusudan Rao garu. Yeah.
Yes.
He also is using a lot of
Yes,
this
yes,
for long
yes,
time and
yes.
very good results.
Yes.
Pre-operatively, we use it for 1 month. 1 month I use, and steroid for 1 week, last 1 week. Steroid is more for preparation during surgery. And itraconazole, if you use for 1 month, most of the fungus vanishes.
Yes.
So I think one of, like you are in a Koti Medical College, we can do some dissertation on this topic, pre-operative use of itraconazole. And you can, the reference is there in Scott Brown, latest edition on AFRS, written by Amin Jawar.
Yes.
I think this, what is his name? Medicari's son.
Gaurav.
Gaurav has worked with him. So he
Yes.
might have first-hand opinion.
Yes. Suction.
Sir, one question, sir.
Yeah.
See, almost in allergic rhinitis patients, the first entry of allergens through the nasal cavity and inferior turbinate.
Yes.
From there, it goes to the remaining nasal cavity.
Yes.
But as the allergens are causative factors for the polyposis,
Yes.
why the inferior turbinate is not changed polypus? Why there are no polyps for the inferior
Yeah.
turbinate?
Yeah.
Remaining all the nasal cavity are having multiple polyps.
I
Boss,
think
if you
Janki
answer
should
this
answer
question,
that
no.
question.
You will
Sir,
get a Nobel Prize. Don't worry.
sir,
Nobody can answer this question so far.
No,
Even
I think this
Stamberger couldn't
question
answer.
I'll pass it to Janki.
sir.
Even Stamberger couldn't answer. What we will answer?
Yes.
The inferior turbinate is absolutely normal, sir.
But it is like, sir, it is like, I'll give a comparison. The maximum spicy food is consumed in Andhra, but acidity is maximum in America and UK, where they take bland food. I really don't have an answer to that question, sir.
Sir,
But in some extensive revision cases, maybe Janki must have seen a few polyps attached to the inferior turbinate. Na, Janki, what is your take?
So true polyps, honestly, very,
Very
I have not seen, but polypoidal I have seen.
Because
But
you
not
and
true
Satish
polyps,
have-
I don't know. I have not
Yeah.
seen, I think one or maybe one case in my 25 years, but it's
Yes.
still enigma and also a sort of very spurious thing why inferior turbinate doesn't develop polyp. Nobody has given a proper answer so far in the world.
Yeah.
And Nageshwar Rao Garu wants an answer from us means then he's a very clever person.
So there is one question from Dr. Ankit, who is from Bhopal. Itraconazole continuous therapy for 3 months or pulse therapy as in 1 week in 1 month for 3 months. What exactly we are suggesting?
Okay, there are two
Depends-
kinds of protocols. I
Yes.
don't know. Deepak ji, you want to answer or I can answer this?
No,
question?
you can answer. Please answer.
So
Then
there
I'll
are
add
two
if
kinds
there's
of protocol. One is called the continuous therapy protocol and second is called the pulse therapy. Professor Stamberger, in fact, he used to say, I used to do the pulse therapy. That's called the 2x2 regime. 2x2 regime means
first ball probe.
first 2 weeks of every
Regular
2
ball
months
probe, not the long one.
of itraconazole, and then stop, again follow up, then next 2 weeks.
Ball
So this is
probe,
called the
ball
pulse regime. And continuous regime, we give it
that's
for 1
correct.
month straight away, and then see the post-operative. And whenever you have a little
Can you irrigate?
fungus or polyposis, you again start. So that's a continuous regime.
Okay.
So this is, but only thing, as Dr. Deepak said, you have to monitor all the other liver parameters, everything. You have to,
Safety conditions,
yeah, safety parameters you have to monitor.
And
But having said that, voriconazole, the itraconazole is a very safe drug. It's safer than
Yeah.
most of the antifungal drugs.
and
In fact,
you
to be very
mentioned about
honest
1
with
week
you,
steroid also.
Oblator irka.
Yes, sir. Yes, sir. Carry on.
In fact, I have not found many people really showing any hepatotoxicity with itraconazole.
Yeah. It's a
And
very
if they
safe.
show, they show it in the beginning itself.
Very safe.
Oblator.
What is
Yeah.
the BP now? What madam is giving? Madam is there? Pulse
what-
rate?
Madam?
Over 68.
100/68, sir.
Okay. Are you happy,
And the
sir?
heart rate?
Pulse rate?
Heart rate?
79.
Heart rate is 79.
Okay, okay. So I'm very happy with Vasavi anesthetist, sir. Madam is very, very
Yes.
nice, kind person, sir. I
Yes,
think we
yes.
should see her face once, if you don't mind. Very charming lady.
Yeah, I think the external camera. I think they can-
Only once we want to see the anesthetic team of Vasavi. If you don't mind, you can show her.
Yeah.
Sometimes,
Please have an
sir,
external
I've been
camera.
promoting my
External
anesthetist
camera on her because
Balamurugan.
anyway they are connecting the coblation.
So much Balamurugan I've been promoting. People say Balamurugan is
Ready,
more
huh?
famous than you. Like that. Here also I am going to start.
Janki, this is something I want to ask you.
Yeah.
You said you are using some new company coblation. Yesterday, delegates wanted to know.
Sir.
It's not on your power connection. So, which is the wand that you are using nowadays?
Bonds,
Bonds.
BONS. Sir, I don't have any vested interest. You try yourself and see, then you do. Or else don't scold me.
Okay. No, which company you are using now?
It is cheaper. It is, madam, 102.68. No, we don't want to see the monitor. Monitor we have seen in all theaters. We want to see your face. This is my Anandi. You know what?
Yeah.
This lady came from Trichy. Hello, madam. Hello.
Suction, please.
So nice, madam.
Suction.
Thank you so much. You have been so helpful, pleasant, and thank you, madam. Thank you. Yeah. So all my sisters who are assisting have come from Trichy, and this lady developed benign intracranial hypertension in Hyderabad. I airlifted her to Trichy last week, and she underwent a shunt. Last week she underwent a VP shunt, and she has come back for work. This is the dedication of this kind of sister.
Yes.
And I asked her yesterday also, she had a little headache. I said, wait, but I need you to assist Dr. Deepak Haldiku.
No, they are fabulous. They are fabulous, Janki. There's no doubt at all. I couldn't have asked for a better case or a better setup,
Sir, before Corona, we are operating all, but not that much fungal. In post-Corona, there is fungal is much more. Sir, Aldipur, sir.
Yes.
It is my observation that
See
before
the glue now. Can you see this?
Yes, sir.
I think this is AFRS, boss.
Yes.
See this?
Yosin.
Yes. Suction slightly stronger. Or can you give me the curved suction? Let me see. I think these are the cases where hydrodebrider could be very useful. Janki has a hydrodebrider, is it? Janki?
Sir, I am poor man, sir. I get only refurbished. That camera you are operating refurbished.
Oh, no, refurbished is good enough. Good enough. We are
Spice,
getting
original,
See,
sorry if there is anybody here. I am just trying to help my colleagues, that's all.
yeah.
Original is 25, 27 lakhs. This will cost me around 13 lakhs or maybe 12 lakhs. But it serves the purpose for around 3-4 years. Then again we'll get one.
Yes,
But
yes.
I can get 2 or 3 cameras in that. And the cobblator instrument I get is for 2.5 lakhs. So all this I can give you the number if you want. Only poor people should come to me, like me.
No, the audience yesterday were very keen to know, especially about the cobblator.
Yeah, cobblator, that
No,
wand is far cheaper and very effective also. Tonsil and all, not even one RBC will be seen.
Yes, yes,
Very
yes.
effective.
Yes. Nagashima backbiter.
Sanjay from Mumbai, Maharashtra. He is asking that what is your experience?
Slightly stronger section. Yeah.
Hello, sir.
Portal elevator.
Can I ask question?
Yeah, absolutely.
There is a question from Sanjay from Mumbai.
Yeah.
What is your experience with families with most members suffering from recurrent multiple ethmoid polyposis and how you
Yes.
tackle it?
See, this is our uncinate family with multiple.
Families with multiple recurrent ethmoid polyposis.
Yes. Genetic
And how?
studies. Genetic studies.
No, Chennai, it's a post-corona.
Yeah. Yeah. The
Hmm.
treatment is the same.
Yeah.
I mean, again, I'll pass this question to Janki. Maybe he can answer this. Curved suction, ma.
What is your experience with families with most members suffering from recurrent multiple ethmoidal polyposis? How do you tackle it? We will do the same. We'll ask all of them to come for surgery. What is the big deal?
Maybe I offer a family package.
But maybe I'll
Right.
give maybe I'll
Right.
give 100 rupees concession for what is the big deal? Okay, anyway, there is nothing like you know, reducing charges and all. Sir, there are many people who are messaging me that they would like to have been in Hyderabad. One is my brother, Dr. Prakash Munkaji, who is seeing from Bokaro. And so many people. Dr. Nishit Shah, we are missing. He is message. Sir, I want to tell you that we are all like Deepak ji, we are all academicians and we don't have anything against anybody. And in fact, I'm missing Dr. Meghnath
Wash
here.
50
And
ml
we
syringe.
are all friends. We are all friends. I just want to say that we are one family in India, and
Yes.
we will work for this country to upgrade the country. And we are not here to show off or anything like that. We want the juniors to learn. It is very simple. We want to teach. This is all. Whether Deepak is operating, I am operating, it doesn't make a
Yeah.
difference.
Yes.
I hope I'm right, Dr. Deepak ji.
Yes, yes, absolutely. Absolutely.
Of course, I am missing Satish Jain because I love him. He's like my
Yes.
brother. So
Yes.
what is the big deal? He is also teaching, I am also teaching. Only people
Yes.
in between, they create something, but we are very close friends.
Yes, 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 yes. Absolutely. Absolutely.
Sir, at this moment,
Yes.
can you comment the opening of the maxillary sinus in chronic sinusitis and sinonasal polyposis?
Yes.
The size of the maxillary sinus.
Yes, it has to be made bigger. You know, the ostium has to be made really big. Wash. Push with all the force. Rendu kaila kuda push பண்ணுங்க. Yes. 1 minute. Huh? Give me the section again. Now give me a thicker section.
Deepak,
Yes.
Manju here.
Yeah, tell me, Manju.
What is the ideal middle metal antrostomy?
See,
This is
it
the
depends.
question.
Yeah, this depends on what disease you're tackling.
No,
If there's simple
What should be the
empi-
extension of the
yeah, from the
anterior
nasal,
border, posterior border?
the widest should
superior?
be from the nasolacrimal duct's posterior border up to
Hello?
flush with the posterior wall of the maxillary sinus. If you are doing a wide antrostomy. See here.
Is it needed for even chronic
still
sinusitis
polished to
also,
go.
sir?
Huh?
Wide antrostomy is needed or indicated in chronic sinusitis also?
No, no,
Or-
no.
Ah.
In cases of AFRS,
Yes, sir.
extensive polyposis, cystic fibrosis.
Yes, sir.
In acute, I mean, in just sinusitis, you don't need to. You need to be just effective.
Yes.
Maybe about a centimeter or so. What I've done right now may be kind of enough. In case of acute sinusitis, you can always widen it posteriorly, which is safer. You know? Caesar, please.
Hello, sir.
Yes.
There is a question from Dr. Ankit Mishra from Bhopal, Madhya Pradesh.
Yes.
How to decide the candidate for itraconazole as said it works on certain set of acute fungal rhinosinusitis cases?
Yes. Yeah, I mean, give it in everybody. If the person is very elderly or who has got fatty liver or who has got some non-alcoholic cirrhosis, then you have to be careful. Otherwise, you can give a trial first. And usually within 2 weeks or 1 month, you see the difference. And if the difference, you continue. Monitor the liver function. I spoke about the neo-osteogenesis when I read the CT scan. You can appreciate it here. Yeah, please.
Manju again.
Yeah.
Deepak, for the benefit of the postgraduates, how much, I mean, which part of the uncinectomy should be done?
The lower part, the junction of the horizontal part and the vertical part, this part, see here. The upper part, later on, you go ahead and remove completely. It again depends. If you are treating only an isolated empyema antri, the lower part is more than enough. Huh? But suppose you are doing it on AFRS or an extensive polyp like this, then you will have to remove the entire uncinate. There is no question at all. But if it is only a case of antroconal polyp or empyema antri or a dental sinusitis involving only the maxillary sinus, removing the entire uncinate may be an overkill. Don't remove the upper part because anyway that is giving a nice way to the frontal recess which is not affected. Straight grasper, straight Blakeslee, yeah.
There are several types of doing uncinectomy. Which instrument do you prefer?
See, it is better to have this retrograde technique of uncinectomy. Nowadays, I think almost all of us, we don't use the sickle knife. We use the Nagashima backbiter.
Backbite before.
Yeah, in this case, I didn't. No, not in this case. Give me the curved section, ma. So, in this case, I didn't use the Nagashima backbiter because the polyps were so extensive. The uncinate was not clearly defined to that extent. So, I used my SMR elevator or the Freer elevator and created a plane. Okay.
Okay.
And maybe in case you feel you are a little incomplete, you can always use a ball probe later and complete it, you know, which I'm going to do now. I'll just show you that.
Okay.
Ball probe.
Okay.
I will show you now. I think you can see this. Look at this here. For example, see, this was the actual ostium.
Okay. And if it's an accessory ostium, it's always better to join the natural ostium with the accessory ostium.
Yes, you should. You should. Otherwise, there will be a circular flow.
Okay.
Debrider. And always take care to see that you are not doing the nasolacrimal duct removal.
Okay.
But not that it matters nowadays. You can always finish it with a sharp cut or complete it with a DCR.
Looks like there is a polyp inside.
100% because my uncinate removal was not
complete.
no, because of the neo-osteogenesis, the bones were very thick. So now you can see this is a very good case because you know the whole tissue is fibrotic.
Can you use the cautery for this uncinectomy?
Yeah, 1 minute.
But some people, they say that it may undergo fibrosis later.
1 minute, huh? See this now, Manju?
Yeah.
It is a little more wider than usual. I had to eat into the inferior turbinate a little bit, but that's okay. Curved section.
Still you are using 0 degree?
Yeah, still I'm using 0 degree. I believe that you should use 70 only at a particular point because it can distort the anatomy, you know?
Yes, yes.
Yes. The eyes are covered, huh? Okay, 1 minute. I'm trying the Stankiewicz sign. See, can you see the movement there?
Yes,
Can you see the NLD moving here?
yes, yes, yes,
We have
very
not
much.
gone and damaged that.
yes,
We have remained anterior to that. That is
yes,
the Stankiewicz sign. Yeah.
yes.
Suction, please. So in this case, I'm more than happy to give a little wider antrostomy, basically because of the extensiveness of the polyposis.
What is the anterior limit?
Anterior limit is the nasolacrimal duct. Obviously.
Rather posterior.
Yes. No, the anterior limit of the antrostomy. See, this is the anterior limit. This
No,
is the
no, I'm asking about the posterior limit.
posterior limit flush with the posterior wall. See here. See this?
Yes, sir.
Yeah.
Sir, one thing I want to tell for all the
Yes.
audience, the
45
most
degree.
important instrument in the whole of ENT
45 degree.
theater.
Please. 45 degree.
Anybody can say which is the most important instrument?
Curved suction, sir.
The suction.
Curved suction, yeah.
And if you can't invest in a good suction, I think nothing works. The
Yes.
debrider doesn't work. Nothing works. So this suction I have bought from one guy called Bhushan, and that guy, Bhushan.
40 degree blade. Ma.
This is ultimate suction. I have tried everything. Of course, Medtronic is too good, but it's a little expensive. But this fellow is from Sholapur or somewhere, I think. Dr. Vikas Kulkarni, he is my brother, he's brother only from
What's the
Sholapur.
time?
He only introduced
Time,
this guy.
time.
And after that,
Time.
I've been repeatedly purchasing. I've got more than now 20 suctions from him.
Okay.
All the suctions are working so beautifully. And debrider never gets blocked. See, it's not at all blocked. It's
Ribbon
not
gauze?
because of the blade gate and all. It is purely because of suction.
Ribbon gauze, please. Yeah. No, what you said is absolutely right, Janki. If you have a good suction, it saves the life of your blades also. Isn't it? But Janki, you use sometimes the blades in the rotation mode, no? What happens to the life of the blade? Hello?
1 minute, sir.
Yeah.
Yeah, please.
Coblation. Suction, please. Or give me the coblation only. Okay. Yeah, coblation kuduga. Yeah. Yeah. Seven and 3 irka coblation, huh? 9-5. Oh, 9-5 correct. Yes. Okay. Suction.
No, straight.
Okay. This will help more than anything because they are taking us for a ride. Everybody is for a ride. If you are doing something good to the AOI, this is
Yeah.
they want, they are going on increasing.
Debrider.
Ask the AOI to slash the price of all the instruments. They are getting 10,000% margin. All these fellows, scopes, everybody. Coblation number.
Debrider.
This is by Kolhapur guy, boss. That this fellow, no, Rahul. You know Rahul? Which coblation? No, this is the fellow who is applying information. No.
There's one thing in Hyderabad only.
Huh?
There's one thing in Hyderabad only.
I don't get from him, no.
Central section is one. Central section is one. Okay.
I get from the back. The number is good. Just know, Tanmay asked.
So how about your experience with that Gujarat-based Narendra Fine? They also are having that.
When I tried, not I.
You tried it?
I threw it off.
No.
I threw it on his face.
Last time I got angry and shouted at him. You don't bring it near me.
Shah. What is his name?
Sorry.
Gujarat?
I don't like means I straight away I shout. Ah, yes.
After family.
Yes, Rahul.
Rahul, right after.
94220 41001. But please confirm he will come for service or not. Tomorrow don't blame me. For
Either.
me, he comes for service. That's all I can say. Because after
the
this,
section
service
now.
is more important than getting an correct. Nowadays, these fellows, they
Crowd.
they are not
Crowd.
94220 41001.
Rahul Deshpande.
Rahul, you don't know?
Rahul Deshpande.
He is a very big guy, but
Debrider.
service you have
40-degree blade, ma.
all my instruments are equal. Nothing which is original. I can't afford more. One more joke.
Good one, next.
I just.
Whenever you are angry, you want to throw the debrider. Throw it in my house.
You tell the patient I'm going to charge you, but the patient you. So from patient point of view, we are forward, we have to reduce the ourselves so that the patient.
Yes.
Afford.
Now irrigation you can stop. Huh?
That is
Yeah.
Then we are going.
Yeah. Hello.
I'm giving the vendor.
So if you are angry and want to throw it in my house.
We'll bury it.
Right?
Now I have really done a wide antrostomy.
Yes, sir.
You can appreciate this.
Sir.
It was a difficult case, but I am happy with the antrostomy because I want to see the junction of the roof and the medial wall because a very important landmark for me as I proceed further. I'll try to go now for the bulla and the frontal recess area. Okay?
Yes.
Ribbon gosma?
Deepak,
Yeah.
is it required to do anti-ethmoidectomy whenever you do middle metal antrostomy? That's what some people advise.
Anti-ethmoidectomy when you do middle meatal antrostomy.
Is it a must?
Not necessarily.
But the
But
people
you are
say that
removing
there will be
Ah.
some amount of reactionary edema.
No. Nothing like that. You can in limited diseases do a good middle meatal antrostomy and leave it at that. If there's a reaction edema, you can always give a steroid spray. Na? What is there? Give me one more ribbon gosma.
Refurbished. Dr. Benji is Rahul Deshpande. Rahul Deshpande. And what is the price for that? 4 lakhs.
Yes.
Okay.
Suction, please. Yeah.
Out.
Now we'll go ahead. These are the small portions of the uncinate here.
Yes, sir.
45-degree forceps. I'm going towards the frontal recess now and try to see what I can see of the bulla as well. So 40-degree blade will come. Ready, huh? Yeah, good. Debrider, please.
Zeiss microscope.
Yeah.
Not after me. He's got Zeiss. You get Zeiss for 1/3, 1/10 the price.
And refurbished debriders also.
Yeah, he does it.
हाँ?
He does it.
5 लाख के लिए मैंने खरीदा है
Very
और
nice.
M4 है ना 2 लाख के लिए
Wow.
हाँ 2 लाख नहीं पर ये सब नहीं कहना मैंने नहीं कहा आपसे
We didn't listen anything. हमने कुछ नहीं सुना.
More. He gives it for
मुझे
2 lakhs.
टिप्स दीजिए
राहुल देता हूँ। ये है 9492
इसलिए मैं कह रहा हूँ एक ग्रुप को बनाना है। ये बता रहे हैं ना 4 लाख इनसे मेरे से 3 लाख आपसे 2 लाख ऐसा नहीं करना। AOI में पूरा ट्रांसपेरेंट कर देना।
यस
Number is there. 95189. All this one.
95189
41026.
और ये रहता कहाँ है?
Kolhapur.
कोल्हापुर।
Yes.
41026.
Yes.
इस
45
सर्विस
degree for 6.
अगर हम 2-3 लोग लेंगे मिलके तुम ड्राइव सही करो, है ना? और give your number here and I'll give you my number.
sir 95189.
अपन 3 लोग को आपस में
Yeah.
26. साइज तो हेड करता ना जर्मनी का we'll give it at a throwaway cost and he's good in service.
Yeah.
please. Thank you.
Hello.
Yes, sir. Here with you, sir.
See, I'm slowly making my space above the entry wall of the bulla.
Yeah. We can see,
You can
sir.
see the bulla, and you
Very
know,
nice.
it is a
Beautiful.
little difficult case.
Yeah.
Spacious, but only thing is the tissue with a bit of fibrosis.
Yeah.
I'm just inching my way.
Beautiful.
Yeah. My debrider is directed a little laterally
Yeah.
and away from the. Yeah.
On this occasion, sir, 1 minute, I want to thank the professors, HOD of Koti Hospital, Koti ENT Hospital and Osmania
Ribbon Gosma.
Hospital, Dr. Sudarshan Reddy Garu, Dr. Anand Acharya, Dr. Sampath ji, all of them who have helped me in doing this conference. Really big thanks, sir. Really big thanks, Dr. Anand Acharya, everybody.
Yeah. I think Dr. Durga Prasad is also in Koti only, I think, no? Yeah.
He is there, sir.
Yeah. Yes. See, in this case, I may find it difficult to do the intact bulla technique. So probably I'll be able to find the frontal much better if I take away the bulla. You agree with me, Janki?
Yes, sir, definitely.
Because with the polyps in the cribriform area,
Yeah.
above the middle turbinate, and the middle turbinate, I'm yet to find a bone in that. Whatever I've removed so far is all polypoid.
Yeah.
If you can see.
Sir, for surface anesthesia, what are the maximum amount of adrenal ampules we can use, sir?
Which one?
Any effect on the heart rate?
No, I think whatever Janki and Satish are using is the maximum only,
Sir.
undiluted. Unless the company comes up with 1 in 500 adrenaline, they're using 1 in 1000 now, isn't it?
Yes, sir.
Sir, there are certain questions.
Yes.
At which point we can decide regarding surgery in case of acute sinusitis?
Yes.
Days after what duration of the medical treatment shall we regard the surgery?
Non-diabetic patients, 6 to 8 weeks. Diabetics, 4 weeks.
Okay.
Yeah.
Sir, second question, do we use deflazacort in a full dose?
1 minute. Yes, please. Deflazacort in full dose. Yes. Non-diabetics, full dose. Why not?
Okay.
See, steroids, again, there's no half measures in that. Whether it's steroids or antibiotic, if you give a good dose.
Okay, sir.
Otherwise, you don't.
Okay.
Straight grasper. Straight Blake asleep, please.
Sir, one question is there. How
Yeah.
helpful is posterior nasal neurectomy,
Yeah.
PNN, and inferior turbinectomy in
Straight
relieving
grasper.
allergic or vasomotor rhinitic symptoms?
How useful?
How helpful is posterior nasal neurectomy, PNN,
Yeah.
and inferior turbinectomy in relieving allergic or vasomotor rhinitic symptoms?
See, inferior turbinectomy initially gives you good space. But if you have left the middle turbinate there, after some time you will find that the middle turbinate gets hypertrophied. This has been my experience. I think now we have cut the merocella. I'll use the merocell here. 1 minute. Get me one merocell. Because Janaki,
Sir.
I am taking a lot of time. So what I'll do, I'll finish one side. Then we can go to Dr. Madhuri Mehta.
Okay.
And the other side, I will do it. Maybe you can put on PIP or something.
Yeah.
Because generally, I end up doing case in a bloodless way, but today is not my day. It's going reasonably.
No, sir. We are able to see all the anatomy.
No,
Why
it
are
is
you
going.
telling
It
like
is
that?
going reasonably well. It is going reasonably well, not bad. But still, what I feel after I finish one side, we'll go on to Madhuri and please put me on PIP and cut off my audio.
Okay.
Yes.
Right.
Because we can't be losing time. 11:30 exactly, you let me know, Janki. Because we
Now
started
it's
a little.
10:30. We have
Yeah.
1 more hour, sir. 1 more.
Yeah, whatever. Even 11:15 is okay.
Okay, sir.
I am now happy with my middle meatal antrostomy, really. Because in this case, I wanted to do a wide one. And I'm also happy with the access I've got to frontal recess.
Okay.
I should be able to move fast from this point onwards. But even then, definitely we can't compromise on the patient's treatment.
Okay.
I will go a little slow. Because the polyps and the field is like that. And I can't blame the anesthetist. She has given me very good heart rate, very good BP.
Excellent.
It's all my making only.
No, sir. Actually, patient has not been prepared. You see, yesterday only we saw the patient. So we should prepare the patient. Any polyp patient, use steroids for a week, antibiotics for a week. It will definitely reduce bleeding. That is very, very important in a workshop. But sometimes, when we get one day before, it always like this. We cannot blame the surgeon nor the anesthetist.
But you should always blame the surgeon.
You have to blame the organizer.
I am very sure that Janki would have finished this in 20 minutes.
You should blame the organizer.
Sir, in the preparation phase, we suggest steroids, na? What is minimal dose, moderate dose, and high dose?
There are 3 kinds of doses. One is called the low dose, second is moderate dose, and third is high dose.
Yes, sir.
We usually prefer the moderate dose, which is actually 0.5 per milligram per kg body weight. 0.5 milligram per kg body weight. Which comes to 30 milligram per day, non-tapered dose for 1 week to 10 days. Non-tapered dose. Preoperatively. And prednisolone. Tablet prednisolone.
Correct. Perfect.
And then high dose is 1 milligram per kg body weight, which is 60 milligram divided doses 1 week. Usually I don't do that. Or a low dose, which is 5 milligram totally. 5 milligram per day for a period of 1 week to 10 days. Generally, I like to give 30 milligram per day for a period of 1 week to 10 days.
Suction?
Of course, yes. Of course. Also, the post-operative period, we cover the patient. It depends. Usually a week to 10 days, but there it is tapered. Not.
இப்போ ஆச்சு ஒரு நிமிஷம் பார்த்துடுறேன். It is. Yes. Okay, ma. Give me the sponges now. Mirocell, yeah. Ball probe. And in this area, I appreciate the way Janki uses the ribbon gauze very nicely. I am used to the Mirocell. So I'll use the Mirocell a little bit to do the Mirocell dissection in the frontal recess area. Give me the other Mirocells, please, now. Suction. Ah, இன்னும் ஒன்று Mirocell கொடுங்க. Ready, very good.
Dr. Deepak ji,
Yes.
we have with us the father of FES watching your
Okay.
surgery. I'm giving the mic to him.
Alright.
This is Mike Tyson here.
Sir, I had a drink of water from the Kent purifier today morning.
Okay.
I was wondering which dialogue you would say yesterday, and that was so much true.
But that's the latest dialogue from her, no?
Yeah. Absolutely. And see, generally people expect you to tell something from Sholay or something. So you really caught everybody off guard. As Janki said yesterday when you entered the hall, he said the magic begins now. Janaki,
Deepak,
Yes, sir ji. Yes.
Deepak,
as such, I had tremors in my left hand when you were talking. Now I have tremors in both hands now that Kirtane sir has come. Ball probe?
Deepak,
Yes.
will you put gel foam soaked in antibiotic and steroid ear drops into the maxillary antrum at the end of the surgery?
No, not at all. Not at all. In fact, there are surgeons who don't even pack. I don't know whether Janki and all they do the packing or whatever. Give me the Mirocell, one Mirocell.
Prednisolone solution
Now-
was, sir.
A post-operative.
One Mirocell. Oh, all are finished, huh? Yeah. Oh.
Is it-
Wash of the solution. Wash of
No,
the
we don't,
sciences of
we don't.
surgery with the steroids, sir.
But one thing I can definitely tell is that for sinusitis, for acute sinusitis, patients presenting with even sometimes chronic sinusitis with acute exacerbation. Nowadays, what I do is I take a long LP
Ball
needle
probe kudunga.
and
Now we'll
load
go
it
for
with
the bulla,
antibiotic and
straight blade
steroid,
podanga.
like for example, amikacin or something like that. I like a LP needle and then slightly bend it like a sphenoparatine block, and then go through the fontanelle
Suction.
and just inject it
Yeah.
inside
Now you
the
keep the
cavity,
straight,
maxillary sinus cavity.
straight blade
See the
podanga.
magic. See the magic. I'm telling you. I don't know if you have done it. If you have not done it, do it. Amikacin with
Straight
Decatron.
blade.
This no. In a patient who is come for medical
Rider.
treatment, and you are giving one-time antibiotic, and
Accordingly.
we had a discussion about this with Amin Jawar. Everybody does that. And in fact, when I said that, they said, "Oh, this is what we also do." So it works magic. Next day, patient is completely gone. So try it out and you tell. Previously, antral puncture and all that was done, but that was very painful because it went through the inferior meatus and you're going to prick it. But now we know there's a fontanelle, you have an endoscope, and sometimes there's an axillary ostium as well. So you just go through that, just infiltrate. Topical antibiotic with steroid works wonders. I mean, that's not quantified. Just take quarter cc of both. But he doesn't aspirate anyway. He's also already conscious. Just instill it inside the sinuses. It works wonders. Try it yourself and tell me. But it's recognized, it's published. It's not mine, my experience.
Okay. Janaki,
Yes, sir.
that could be the turbinate which is entirely polypoidal.
Yes, sir.
The middle turbinate. Now maybe I'm able to see that.
Yeah.
And see this that could be the middle turbinate. I have defined the bulla now.
Yeah.
And finally, nature is also a little kind to me.
Yeah.
Maybe I can open up the bulla now.
Okay.
And these are the polyps, probably polypoidal edge of the turbinate only,
Yeah.
and the polyps medial to that middle turbinate.
Yeah.
Now, you know,
So I think
yeah,
every one of you, sir, we'll have 1 minute of yours, Dr. Deepak ji. We'll not have your audio, but then
yes,
I just want to have a small announcement in the
yeah, why not?
in
Why
the
not?
hall.
Yeah,
So actually, I have a great relationship with Professor Kirtane sir, and it's not easy to find a gentleman, a thorough, affable human being like him. And I just
Ripple
contacted him for this workshop. He readily said yes, and he just asked me where, because he's also now confused where I'm in Trichy, Hyderabad, somewhere. But when I said Hyderabad, yes, we have a direct flight. So I am really, really thankful to my teacher, my mentor, the first chance who gave me to take a facial atta. That was the time I knew where the facial atta was, and he did it for me in 1998. So he's come all the way. You saw him brilliantly demonstrate. I learned implant from him. He every day in my theater, he doesn't know. He'll cough. They will say in Tamil, when I say the name in his absence, they will cough.
bone punch.
I don't know if it's there in other languages also.
punch or bone punch.
So every day I talk two things because I do a fest every day. Kirtane knife. Get me the Kirtane knife. If I don't say Kirtane knife, Shilpi will say, a reminder, Kirtane knife. So, sorry, I am not using Professor Kirtane, but I say Amin's, diathermy. Like that, Kirtane knife is one of the best instruments for unsunectomy. There's no question about it. Lakshmi knows it. All my residents know it. So, that is one. Whenever I do an implant, Kirtane retractor. This is the only thing that's a trump instrument for me. So, every day, I mean, people leave behind memories like Haddad. Every day we talk about Haddad. He's there somewhere. He'll be coughing every day from the whole world. Like that, we remember him every day. And this is what he has given to the world. And we should be thankful. Let us give him a standing ovation, please.
Thank you. Thank you very much.
The brother, yeah.
I came here just at his invitation because I have a very high regard for this man, his passion to teach, the passion to share with everybody. And knowledge is not strength, but sharing knowledge. Yes, and knowledge is not knowledge unless it is shared. So congratulations for what you do. We don't say cough, we say hiccups. People get hiccups. And I get so many hiccups, then my wife tells me, why did you drink so much last night?
So it is mainly because of the
Anyway, God bless you, Janki, and please carry on doing what you're doing. We love you. And guys, thank you very much. I think what impressed me most yesterday was till the late evening, till the last program was over, the auditorium was completely full. So you guys are here to learn, make the best of it. Thank you and God bless you. When is the next one?
This is what I really want. I mean, great, sir. Thank you very much, sir. Thank you. Nothing will go without you, anyways.
Bone punch. Hello.
Yes, sir.
Yeah, can you hear me?
Yes, sir. We are with you, sir.
If you noticed in this case, I used the Carrison's punch
Yes, sir.
to take away the entry wall of enter the entry wall of the bulla.
Yes.
Whenever I find the field is more bloody or a little messy,
Sir.
I always take my time and I don't use the debrider straight on to
Yes,
enter
sir.
the bulla. Okay. So I take my time. So this is of course the bulla. I just opened it up. Debrider.
Is it
Hello,
middle
sir.
turbinate, sir?
Yes.
That's one. That one.
Yes.
Yes, sir.
Sir, can I take some questions?
Yes.
Sir, it's a question from Dr. Navroz Mehta from Government Medical College, Guwahati.
Yes,
Signs of intraoperative lamina paparacea breach.
yes, yes.
Starkvik sign, shall I tell him?
Stankiewicz sign, just now I showed.
Hmm.
See, this is again, I'm going here, the Jula technique which Janki says.
Ah.
Yeah.
Yeah.
Jula.
Sir, what is that? Can you tell us?
Sir?
What is that Zula technique? Can you tell us?
Yes, sir. Jula technique is the moment you go near the bulla and then towards the posterior ethmoid, you go medial. See, here I'm a little unsure basically because of my middle turbinate location.
Mm-hmm.
So in this, you keep moving the debrider like a swing, medially and inferiorly, so that you stay close to the septum and you go closer to the sphenoidal ostium.
Okay.
Here, because the middle turbinate is eaten away by the polyps,
Yeah.
I'm not, really getting a stable, steady landmark.
Sir, there is one question.
Yes.
Will you remove polyps arising from olfactory area also?
No, ideally, no. Ideally, no. One of my favorite books is, but if it is destroyed beyond a point, then maybe you may have to. You have to take a decision on the table whether those polyps are going to reverse with your steroid spray or whatever. If you feel it is irreversible, then you better take it out. See this polyp here again. Debrider. Anyway, whatever little I'm doing in front of the father of endoscopic sinus surgery in India is really a great feeling, sir. Ball probe. Give me maybe a small, you have a sponge? You can give me a sponge. Straight grasper, yeah, Mirocell, yes. First, I think let me take out this. And this. Give me the curved suction. Curved section, no problem. Nidananga kodu parvayilla. I'm showing one side, so that's not a problem. Now the oozing is also reduced a fair bit. Again, I think this is a new osteogenesis here.
Yes, sir.
And I would like to use, see, whenever I see a field like this, I will use the Carrison sponge more often. Okay?
Okay.
Bone punch, yeah. After I've done the Jula, yeah. You can see now the lamina also we can see nicely. We can see the maxillary sinus and I'm going medial to lateral. Suction. And remember on this side, debrider. Yeah, give me the debrider, please. Yes. So that is the maxillary line suction. See, this landmark is most important, the junction of the roof and the medial wall. Now, when I'm seeking the sphenoid as well as the posterior ethmoid, I need to stay at this level, not to cross this line.
Okay.
Yeah, not to cross this line. This is a very important landmark. This will be my site there. And I wouldn't like to go above this if I'm working in the posterior ethmoid as well as the sphenoid. And on this side, the sphenoid is very, very small. I expect to get it somewhere here in this area, the ostium, and a very small sphenoid sinus.
Okay.
Yeah. Straight Blakeslee, please. Straight Blakeslee, please. Debrider.
Sir.
Yeah. 40-degree blade. You can ask questions to Professor Kirtane, sir.
Sir.
You need not get stuck to the formality that you have to ask me only. The Bhishmacharya is here. We should utilize his time.
Difficulty on the bag anatomy. Ante anatomy on the distributed on the bag.
Debrider. See here, this bony ledge, this one,
Yes. Yes.
which is very thick, you can either use a Kerrison sponge or you can do the Janki's technique where he uses the debrider in the rotation mode. Only problem with that, your blades will not last. Okay? They get
Yes, sir.
blunt faster. Right?
Yes, sir.
Bone punch.
Deepak sir, there is one question from virtual platform from Dr.
Yes.
Nikita from Jammu. Can I take the question, please?
Yes, yes. Why not?
Sir, hypertrophy of middle turbinate is because of the allergic type 2 inflammation.
Yes.
For allergic patients, desensitization of patient is required. For
Yes.
AR which are not responding to medical management, we should think about desensitization before neurectomy. And
See,
this
I
is
have
a request,
absolutely,
from
I
her.
have absolutely no experience with posterior nasal neurectomy. I have seen Ahila Swami advocating it, and I don't know if Janki or Kirtane sir is practicing it. I think I'll ask Dr. Kirtane sir to take this question if he's there in the hall. I have virtually no experience with posterior nasal neurectomy.
Right. So I actually, Kirtane sir just left for the airport, and
Okay.
Janki sir also just went for a
Left.
minute to see him.
Yeah. Okay.
So I think after he comes back,
I have zero experience
Sure, sir.
post-nasal neurectomy actually. You
So
know?
till then, my request to the delegate experts in the hall, do you have any experience with the particular question? Any expert? Desensitization before neurectomy.
Neurectomy, I don't believe. I believe in desensitization.
Okay.
I have not done neurectomy. So if you ask me, I am any day for desensitization.
Sure, sir.
Yeah.
So then we'll take it when Janki sir is back, and we will ask Dr. Nikita whether
Yes.
sir has any personal experience with the particular case.
Yes.
And if you have any advice, because you are allergy specialist, request to put up your suggestions, how the delegates and
One
the
punch.
students across India should handle it. Because I feel you are the right expert, being an allergy specialist. And we will take even Dr. Janki sir's opinion once he's back in the hall.
Yes. One punch. Yes. Give me the mirror cells now. I'll go for the frontal sinus now. Curved section. Hello?
Yes, sir.
Dr. Jadhav,
Yes, sir.
you are very much there. You can see we have made some headway
Yes.
now.
Yes, sir.
Yeah, and we have removed most of the polyps.
Yes,
Probably
sir.
this could be the remnant middle turbinate. I am not, this thin one. And I think I'll look for the frontal sinus now. So before that, I'm just taking a final look and maybe I'll move towards a 70-degree scope. 40-degree blade will come, huh? Yes. Give me the 40-degree blade. I think we are working towards the frontal sinus.
Yes, sir.
Finally, we are left with the sphenoidal sinus,
So there is one surgical question.
Yes.
When to go in intact bulla technique and where you should not follow that technique?
Acha, generally, you can go for intact bulla technique. It works in most of the cases. Sometimes the bulla is so prominent and the frontal recess is very, very narrow. Then you can always take away the bulla to get yourself more space, as I did in this case. Usually I practice intact bulla technique. Very rarely I do this technique. In this case, if you notice, the field was anything but bloodless. And I struggled quite a bit, because of which I took away the bulla. You can see the amount of space I have with which I can visualize.
And as far as I have understood, sir, in the initial time before surgery, you had gone through the scan report.
Yes.
That is the first thing, as Dr. Janki also said yesterday, planning
Yes.
is very important. So you
Yes.
also have shown the same, demonstrated the same thing in the morning, how you
Yes.
have planned the case well
Yes,
in
yes,
advance.
yes,
Have you have thought about everything
Yes.
prior only? But
Everything,
in case,
everything except the oozing. Oozing I didn't plan.
true.
Yeah. But even then you
Because
can
that-
appreciate now the field is looking far better than before. Sponge.
Very true.
Mirror cell,
So,
yeah. So
pre
I
op
had,
all
planned,
the-
I had planned intact bulla only. Because that time, if you remember when I presented the CT scan findings, I said the frontal recess is going to be roomy and I'm going to find 2 agar-nasal cells. It was because of the oozing and lot of polyps which were very ropey. I decided, to go for removing the bulla first before I take a look at the frontal sinus. This is not the usual way that I operate. 95 to 98% of the cases, I do the surgery with intact bulla technique actually. But in this case, I could not successfully define the middle turbinate completely. Because of which, I took some time. Now that I have my landmarks, like I keep telling about the maxillary line here, now I have all these areas. So I'm quite happy now with whatever landmarks I have. So I decided in this case, I'll remove the bulla.
Thank you, sir.
Yeah. Straight grasper, 70-degree scope kodunga mappa. Give me a little saline irrigation, ma.
Dr. Pradeep Chaure here, sir.
Wash, yeah.
Good packing with
Slow,
a good packing with adrenaline before surgery would have helped in reducing the bleeding. Number 1.
Yes.
And number 2 is we would like you to refresh the landmarks. I mean,
Yes.
tell us about the
Yes,
landmarks.
yes.
Thank you.
I will. Now we'll go for the frontal sinus. And finally, that small sphenoid. Time evlamma? 11:30.
This saline is simple saline or hot saline?
11:21.
ஐயோ 11:20 ஆச்சியா? சே. ரொம்ப லேட் ஆச்சு. ரொம்ப ஸ்லோ ஆச்சு.
Hello, sir.
Yes.
This saline is normal saline or normal saline in hot saline?
This is hot saline, amma.
Okay.
This is warm saline.
Okay.
45 degree forceps. Ah, 70 degree scope kudungamma.
Sir, can you show the axial of the middle turbinate, sir?
Actually, this could be the axilla of the middle turbinate here.
Sir.
Can you see that?
Yes, sir.
This is the anterior wall of the bulla, the upper border.
Yes, sir.
Okay.
Ready, sir.
70 degree scope kudungamma.
Ready, sir.
Yeah. Let me see. Romba time much. Actually, I think we are at 11:20. Another 10 minutes, please put me on PIP. Is Dr. Madhuri madam ready in the other OT?
Yes, sir.
She's ready now? Okay. Please tell me the moment we touch 11:30, madam. Yes. Yes. Or
Sir, I'm back. I just left Dr. Professor Kirtane
Suction.
sir and came back.
Yes, Janaki.
Yeah, it looks a wonderful cavity. Excellent.
Yeah, but to be frank, I could have been faster. I could have been more neater. Somehow today it's a medium demonstration only, but it's okay.
But the end result is more important and it looks wonderful.
Yes. Okay. I think the frontal is here, Janki. I'll go there now.
Yeah, that's the frontal. Yeah.
Yeah. 40 or 60 degree blade kudungamma. See,
Dr. Nikita, we will be taking your question again. As
and
Dr.
Janki,
is back.
Janki, let me
Yes,
know
sir.
the moment we touch 11:30, I go on PIP.
Sir,
And we let Madhuri madam start. The moment we touch 11:30,
no, we have 20 minutes more.
okay.
Carry on. The time right now is 11:10. So we have 20 minutes. And I don't know if Dr. Madhuri Mehta madam is ready with the case, the other OT.
They're checking.
Dr. Shilpi, can you check?
Ready. We have checked. Ready. Just now, cross check it 40%. Ready.
Okay, I think she's ready. But you tell me when we have to shift, we can shift.
Yes.
It's all your day, your call.
No. Exactly at 20 minutes we shift. No question at all.
Okay. That looks like the frontal.
Yeah, that is the frontal.
Yeah. This suction tip you bought, did you get?
Which one? No.
Oh.
Idu ivare kudthirkar.
Huh? My suction tip.
Suction tip is your suction tip, Janki.
I've never seen this.
Not mine.
They are giving only to the good surgeon, not to me. Yes, I
Suction.
catch hold of my sister.
Suction. Yanamma. தலைவர் கொள்ளி குள்ளே நீங்க
Sir, can you keep suction over the cribriform, sir, to get to overall orientation?
Yeah, 1 minute. You asked me something.
Please keep suction over the cribriform, sir. We'll get to
Ibrahim
overall.
Kudunga. Did I keep suction over the cribriform? No.
Yeah, just there. Please keep suction, sir. Their blood clots are there, and yeah,
Okay.
so that we can orient, sir, as a whole.
Okay. There are actually polyps over the cribriform,
Yes, sir.
actually.
So, Janki sir, there is one question
Yeah.
about desensitization before neurectomy. Your opinion.
That is a
Before
frontal.
Neurectomy.
Neurectomy.
No problem.
Median
Sponge
neurectomy.
Yes.
Usually,
Kodunga.
this is for vasomotor rhinitis or for allergic rhinitis?
Allergic rhinitis.
Allergic rhinitis,
Kodunga.
why you want to do video neurectomy?
No role.
Video neurectomy is for vasomotor rhinitis. So actually, desensitization is a good procedure. Actually, we do it. See, for very, very
Also
resistant
Kodunga.
patients presenting with allergy, and we are giving all the kinds of antihistamine, sometimes steroids also, steroid sprays, douching, all this. And some patients don't respond. Then
Suction
we send
Kodunga.
the patient for desensitization. It's a good
Or Nalla irrigation Kodunga.
immunotherapy is coming up in a big way. Yes.
Oh,
Thank you,
yes.
sir,
Kodunga,
for this
Kodunga,
answer.
Kodunga. Vidunga.
I think there is one guy, my classmate called Agila Sami. He is doing a
Yes.
lot of posterior nasal neurectomy. Instead
Yeah,
of
I
giving-
wanted to ask you that question, Janki. What is your experience of post-nasal?
I don't have experience, but I think he has been talking about it for a long time. I don't have any personal experience, but when I see him, then next time I think I want to do, then I forget. I don't do. That's all.
It means you are not still convinced, isn't it?
Sir, he is my classmate, sir.
ಅದು ಸರಿಯಪ್ಪ ಫ್ರೆಂಡ್ಶಿಪ್ ಬೇರೆ ಟ್ರೀಟ್ಮೆಂಟ್ ಬೇರೆ ಅಲ್ಲ. That's the maxillary sinus, Janki. First time.
Wonderful, wonderful, sir. What is the scope you are using, sir? 70
Now,
degree.
now I am using 70.
70 degree.
Yeah, now. Yes.
Okay.
Now for the first time, I do most of my surgery with 0.
Okay.
Yeah, only to visualize the frontal and then the deep part of the maxillary, I use 70.
Okay.
These are suction which they didn't give you and they gave me.
Yeah, it is actually
Probably.
nicely.
No, probably I am like Shabari. They wanted me to try first and then give it to Sitaraman.
No, it's very good actually. See,
Now
that's
the
a
oozing is
sharper
out.
tip.
Yeah.
That's a nice one. Actually, it can elevate also.
Yeah. 0 degree. Or maybe 70 kudunga, Varvati, I think frontal pattern, and then.
Aksha Oha is waiting for a long time. Who is this Aksha Oha? Akshay Oha. Oja. Why is waiting in the waiting room? Where is the waiting room? Oh,
What degree forceps?
oh, okay. I thought he's waiting outside our room.
Yeah, Janki, that's the frontal.
Yeah, nice, sir. Nice.
Suction.
Lovely. Just a little
I-
suction.
Yes. I'll put your favorite suction,
Yeah. No. Hereafter it will become favorite.
which they gave me,
Yeah.
not you.
Oh, okay.
Yeah,
Nice.
yeah.
Oh, yeah, sir.
And that is a supraorbital cell as well.
Yeah,
Yeah.
we can see the frontal.
Yes. See, this is a frontal. You can see a partition here. Can you see that?
Yeah.
You can see the cell here.
Yeah.
Yeah.
Shilpi is
Yes.
there. Sir, would you like to do the other side also, sir?
No. I will, you transfer it to Madhuri.
No.
I'll
Without
come-
transmission, would you like to do or
Yeah. I'll finish it.
you will finish off? No.
Yeah. I'll finish it and come.
Okay.
I'll just take a couple of minutes to look at the small sphenoid if I can. What's
Yeah,
the time now, Janki?
No, you have another
10 minutes?
15 minutes more.
10 minutes is
You,
enough.
you would like to show the anatomy, complete anatomy.
Yes.
And I think the cribriform area, there's a little polyp also.
Yeah. 1 minute. Now. Yeah, 0 degree. Straight forceps, please.
Whenever we look at the scan, CT scan, in a case of polyposis,
Yes.
always look, this I always tell my fellows, always look at the middle turbinate. If the middle turbinate is pushed, usually in polyps, it is pushed towards the septum.
Yes.
So you will find it almost abutting the septum. But in
Yes.
some cases, you will find it in the center or sometimes pushed towards the lateral wall. In that
Yes.
case, you should already tell, and these patients very particularly will complain of anosmia or hyposmia. It is
Yes.
purely because the patient is having polyposis in the cribriform olfactory cleft. So
Yes.
preoperatively itself, we can tell the patient that
Straight forceps, ma?
the problem is these polyps actually damage the nerve endings of the olfactory cleft. So
Yes.
we cannot guarantee that they will develop very good smell after. They will keep on asking, sir, will the smell improve? We will try to
Yes.
remove the polyp, but we cannot say because there is both mechanical and chemical damage to the
Goblet
olfactory neurons.
Gobleter, yes. Yeah.
Sir,
Yes.
there is a request from one of the delegates, anterior ethmoidal artery.
Yes.
Can you please show us?
Yes, yes, yes. First, let me open up the sphenoid
sir.
because that is one sinus and it is small on this side. So I'm trying to get in there. Let me see.
Hello, sir.
Yes.
There is a question from Pandyala Abhishek.
Yes.
He has asked if we have to give the antifungal drugs preoperatively, how long we have to give it before surgery and
Yes.
post surgery.
Wow.
Okay.
Antifungal drug, we go before surgery, is it? If the patient gives you time, why not? You can give it for quite some time. Nothing wrong at all.
And there is a one question for discussion
Yes.
from Joel Matthew.
You have that sphenoid probe, Amma, which Janki uses? Sphenoid probe, Urkala. Black color, yes. Because that is the sphenoid. I've just gone in there right now. I want to. Because I told you, this is a very small sphenoid. Irkamas probe. Because this is a very small sphenoid, I think I will get it here now. Ilia probe. Slow கொடுங்க பரவாயில்லை. See, I would give it for 2 to 4 weeks.
Probe இருக்குமா பாருமா அந்த probe malleable probe நம்ம யூஸ் பண்ணுவோம்ல.
No, they are searching. They'll give Janki.
Bronze colorல இருக்கும் பாரு. That instrument is a magic instrument for
no, especially this case, Janki.
It's there.
This case, see, ball probe. They're giving.
No, the sphenoid probe.
Yeah, they're giving.
No, not this.
No. They are giving a black probe. What I was trying to use was I'm pushing the turbinate bone, whatever is left there.
Okay.
See, this bone is all neo-osteogenesis.
Okay.
The walls are very thick. But I can find the sphenoid here. I am trying to use your probe to demonstrate. Because the walls are very thick. But I'll find it. I'm just waiting for your probe to come. Because
hey, Anandi, என்னமாச்சு? Each sinus has got one trump instrument. We should always.
Yes.
Yeah, frontal sinus means there is Kunz seeker, the best instrument.
Sphenoid you can also use the Cottle's elevator.
Yeah.
But sometimes people say Freer elevator.
Yeah.
But Freer is a little big. But in this case, I find number one, the sinus is very small.
Yeah.
Number two, the walls of sinus is very thick. because of the new osteogenesis. So I feel your probe is a very safe instrument. Ilya?
You got it or not?
No, not yet. Not yet. They are trying to search. Nidanama
it?
paranga.
You just show
Nidanama
that
paranga.
probe to the audience.
Yeah. Can you give me the cob letter, ma, in the meantime? No, they are searching for it, Janki. Give
Searching.
me the cob letter, ma.
Hello. Hello.
Ah.
Yeah.
Dr. Janaki.
Yes, yes, madam.
Good morning, Dr. Janaki. We are ready there. What we can do is we'll share the details of the patient and CT and this investigation and starting steps, and then you can go back to this so that the time is saved in between.
Yeah, Dr. Deepak ji, can we?
Yeah.
Did you hear Dr. Madhuri, madam?
Yeah, yeah. You can transfer. Absolutely.
So 1 minute, madam. So
Okay.
Dr. Purva is going to introduce you.
Okay.
Sir, in this case, to enter into the sphenoid, is trans-ethmoid route is better or trans-nasal route is better? Because this is hypoplastic.
Always through the superior meatal window.
Janki, is that the sphenoid?
Intermediate. Yes, sir. Yes, sir. That's the sphenoid. There's no doubt.
See, here, see.
That's the sphenoid.
Probe, yeah.
Use the
please.
sphenoid probe.
Yeah, now the probe has come, Janki.
Ah, that one. That is magic instrument. Yeah, see that?
Yes, sir.
Yeah. Beautiful. That is it. That is it. See, that should be a give.
Yes, but actually,
Are you feeling the give?
no, not yet, Janki.
Then just you have to screw it down, up. It'll just slide
No,
inside.
I don't want to, I don't want to go up also, too up. Because I'm really worried in this case. Very small sphenoid, na?
Yeah.
Very small sphenoid. Suction, please, because already I'm at the maxillary line. It should be exactly at this point only. Bend it a little downwards, ma. Let me see.
Can you just slide it down a little bit and then it'll move inside?
Maybe, yeah, I want to bend it down or whatever. But see the amount of oozing, Janki.
Yeah.
This is because the neo-osteogenesis.
Yeah. Neosteogenesis.
Yeah. Can you bend it a little bit downwards, ma, and give me? My worry is because of small sinus, na.
Very small.
I want to be hitting the skull base.
We can use a down biting sphenoid punch also.
Yeah. No, I think I'm into the sphenoid now.
Yeah, that is it. No doubt.
Yeah, but this bone is very, very thick, Janki.
Down biting, Kuduma.
Yeah, no, she has given. She has given. Suction, please.
Yeah.
Yeah, I think we are there.
Yeah, we are there. We are there.
Yeah.
Excellent.
Yeah.
Little
Give me the probe
polypodal.
again. And the air bubbles coming in there.
Yeah.
Yeah, I think your hints were very helpful actually.
Yeah.
Let me
Wonderful.
Yeah. Yes. Janki, I think over to Madhuri madam. I'll come back to you in the end, probably.
Excellent, sir. Excellent.
Yeah.
Let us give him a big round of applause.
It was a difficult case.
Excellent, sir. Did you hear that?
Yeah.
Wonderful.
Debrider, ma.
Wonderful.
Debrider.
So we'll come back to you if you are finished.
Yeah,
please
later.
On both sides. Okay,
Yeah.
now over to Purva. Thank you very much, sir.
Thank you, sir. Now, next, we are starting with the next case by Madhuri Mehta, ma'am, on mastoidectomy. Doctor.
थोड़ा सा ऊपर करना.
Screen.
Oh, sorry.
So today I'm here again to introduce a lovely lady, Dr. Madhuri Mehta. She is extremely proficient in the following areas of specialties such as otolaryngology and head and neck surgery. Huge experience, more than 3 decades. Fellowship in lateral skull base surgery at Gruppo Otology under Professor Mario Sanna in Italy. Director and HOD ENT at NC Jindal Institute of Medical Sciences, Hisar. And she's a hardcore teacher. Her way of teaching is additionally multiple books. She has authored multiple books in the therapy area, and special skills are skull base surgery. And this is her recent book, Atlas of Facial Nerve Surgeries and Reanimation Procedures. So I request Dr. Madhuru Mehta, madam, to take over the case details, and Dr. Purvi will be giving details on the case.
OT, can you relay the case history?
Dr. Madhuri Mehta, madam, over to you.
Good morning, Dr. Janaki, and good morning, the audience. Good morning, the audience. I think you are really having great time watching great surgeries by great surgeons. All thanks to our great teacher, Dr. M.V. Kirtane, and our mega star, Dr. Janaki, under this collaboration of, Indian Elite ENT Club with Sun Pharma. So I am just being a part of it, and I hope I am able to impart something new to the audience, the learned audience. So we'll start with this case. This is a 11 years male with a complaint of left ear discharge since, she's telling?
Since 10 years, ma'am.
Who's doing?
Ma'am, should I
10 years, madam.
Yes,
10
you
years.
you give the history.
Yes, ma'am. I will do that, ma'am.
Okay, okay.
11-year male presented to the OPD with the complaints of left ear discharge since 10 years. History of the ear discharge was purulent, continuous, scanty, foul smelling, and occasionally bloodstained, and was not aggravated by URTI or not relieved on any medication. The child also complaints of left ear reduced hearing since 2 years. There was no complaints or history of fever, headache, diplopia, giddiness, and facial weakness. On examination, can you show the picture? Otoscopic picture. Yeah. On left side TM, as we can see, there is
so back. Yes.
Left posterior EAC destruction has been seen, and we can see posterior superior retraction pocket, fundus not seen. The pocket was filled with cholesteatoma flakes and discharge. And right ear was normal. Rini's right side was normal, left side 512 and 256 were negative, 1024 being positive. Weber's was lateralized to left, and absolute bone conduction was normal. Siegalization, there was no tympanic membrane movement. Fistula test was bilateral negative, and facial nerve was normal. Rest of the nose and throat examination was normal. Over to you, ma'am, for the radiological findings.
Oh, okay, thank you, Purva. Then we are going to the CT scan. Can I have a needle, please? A sharp instrument or needle?
Yes, madam.
Needle. Okay. So basically, for this is supposedly cholesteatoma case, and because it is a 11 years old child, it can be congenital or acquired pediatric cholesteatoma. This does not seem to be a congenital cholesteatoma, as usually the patient presents with a cholesteatoma behind an intact tympanic membrane, and he usually presents with hearing loss, dizziness, vertigo, facial weakness, etc. But here the endoscopic picture is showing that there is a perforation, marginal invagination of epithelium through the perforation. So it seems an acquired cholesteatoma and not a congenital cholesteatoma, one thing. And audiometry, there is a conductive, mild to moderate conductive hearing loss with a dip of SN loss at 4K. So we'll try to explain it through our CT and the operative findings. Only two investigations we do in such cases. Mostly it is audiometry and the CT scan. And CT we do axial is more helping, and coronal we take certain points in that also. So for going to axial cuts, we start from superior to inferior because we have to follow the disease from superior to inferior. So we are starting with the superior cuts, and the first thing that appears is the...
Can you zoom in, please? Camera person, can you zoom in?
My voice is audible?
Yeah,
Voice
audible.
is audible, ma'am. We want some zoom in.
Zooming slightly.
Yeah.
More on this.
Okay.
Make it sharp.
Little sharp, very, perfect.
Okay.
Yeah.
So now this is posterior cranial fossa, middle cranial fossa, mastoid, and this is dome of superior semicircular canal. This is petrous apex. Now this is dome. This is ampulated end of superior semicircular canal. This is crus commune, and there is a subarcuate artery appearing in the next cut. And this is the appearance of the posterior semicircular canal, very well seen. So superior and posterior seem absolutely okay. So now there is the appearance of, now coming from outside to in lateral to medial. This is the epitympanum and antrum. This is all seems to be filled with this soft tissue mass, which seems to be cholesteatoma only. But the air cells of the mastoid are maintained, which shows that maybe the disease may be restricted to antrum or going slightly forward. We'll have to decide whether we do intact canal wall or canal wall down. That totally depends on our operative finding. So in this cut, you can see as we go down, interauditory meatus has appeared. Now this is beautiful appearance of the labyrinthine portion of the facial nerve. There is the superior vestibular nerve going to the vestibule. Now it will make a first genu here. We go further. This you can see beautifully, base of cochlea, lateral semicircular canal, vestibule. This is the labyrinthine portion making first genu, turning back posteriorly as the tympanic or horizontal segment. The beautiful part is that the labyrinth is intact, lateral semicircular canal is intact. In pediatric cholesteatoma, because it is an invasive cholesteatoma in kids, due to extra inflammatory changes in proteolytic enzymes, they tend to erode the bone. So many a times we find a fistula there. And so CT becomes very important in pediatric cholesteatoma. Now moving further, this is becoming a horizontal portion. Important thing is the ossicles are missing. This seems a hazy picture of the head of malleus or body of the incus. Seems the ossicles are badly missing and the cholesteatoma is concentrated in that area only. This is the horizontal part of facial nerve coming there. Coming further, now this is sinus tympani, this is facial recess. There we should have found some appearance of the long process of incus or the stapes suprastructure, which is not there. So if we go further, we can see there is a handle of malleus, cochlea, vestibule, vestibular aqueduct, and this is sinus tympani. This is the pyramidal eminence with stapedial muscle there, with a tendon going there. Had there been a stapes, it would have been the suprastructure of stapes should have been like this, just anterior to the pyramid, and behind that is the facial nerve. If we keep following the facial nerve seems intact, covered with bone. In horizontal portion, at one place, in a bigger image, we could see there is some part of dehiscence in the tympanic segment. We'll see in the operative finding. Cochlea, vestibule, and this is the long process. This is handle of malleus. Stapes seems absent. Facial nerve covered. This is facial nerve going down. Another important finding is
focus. Change. Yeah.
Change wherever my needle is going. So this, can you see, Janki? The tympanic membrane is getting retracted, or there is a big perforation there. And this disease is localizing at the round window, which can be the reason toxins might have gone through the round window in the inner ear, causing the dip of SN loss at 4K. Okay. And this is the base of the cochlea. And this was tensor tympani tendon muscle. And now we can see the eustachian tube appearing. And this is the facial nerve. Another important step we have to keep in mind is this was all sigmoid sinus, but here the jugular bulb is coming very high. Can you see?
Yeah.
It is almost touching the promontory. It is not dehiscent jugular bulb. It is high-lying jugular bulb with a covering of bone over it. So we'll have to be careful there. Yeah. On the other side, it is not that prominent. It is prominent here. Now, just few cuts in the coronal. In axial, we go from superior to inferior, and coronal, we go from anterior to posterior. So we'll focus on the left side, anteriorly, carotid and TM joint. 3 C's are there, anterior to the interauditory meatus, carotid, condyle, and the cochlea. All 3 we will focus on that. Carotid, condyle, and the cochlea. Cochlea is appearing there. Focus on the left side only. This is the facial nerve. In the next cut, we will be able to appreciate this cochlea is completely clear. There are two holes, snake eye holes. These are the parallel presentation of facial nerve in 2 cuts, labyrinthine and tympanic. Both come in the same picture. Important thing to note here in this one, we can see there's a clear-cut scutum, sharp scutum, this malleus, but here you will see the scutum is getting eroded due to the retraction of the tympanic membrane, and the ossicles are badly, eroded. Almost thin malleus or incus is there, whereas this you can see completely present malleus, and if we go posteriorly, it becomes incus. Again, you will see that in the next cuts, you can see the stapes is there in the normal side. It is absent there. So I am hoping absent suprastructure of stapes, long process of incus. We may find malleus and body of incus there, but rest of the structures might be gone. You want? Okay, two more points we see in the coronal cuts. One is the thickness of the tegmen bone. Here we can see if whenever there is a defect or the disease going up, we can see there thinning of the tympanic tegmen tympani. And the other thing is all the three semicircular canals are intact. This coronal cut, we can see the vertical portion of the facial. You can very beautifully see that. We can see if there is any erosion of the bone around. So vertical is absolutely normal. So fine. If I summarize the case, I think we are going to get a cholesteatoma sac involving the mesotympanum, epitympanum, and antrum. Maybe the mastoid is spared. Facial nerve seems intact. Maybe slight dehiscence in the inferior part of the tympanic segment of the facial nerve. Inner ear is normal, tegmen is normal, and we are going to find a high jugular bulb. Any questions on that?
Wonderful, wonderful, madam.
Okay,
Excellent.
so can we go ahead?
Yeah,
I'll
we can
show
carry
the
on,
chart.
but give me 1 minute. We're going to announce the panelists, please.
Okay.
Thank you, panelists, for chairing the previous session. I would like to introduce Dr. Navneet Agrawal, Senior Professor, MDM Medical College and Hospital, Jodhpur. Dr. Rajesh Vepuri, ENT surgeon,
water.
holds cochlear implant
Some
fellowship
water.
and trained under PG Wormhole in rhinology. Dr. Krishna Kishore, sir, former professor and HOD of Government ENT Hospital and ex-superintendent
Your
in
name.
Visakhapatnam, holds interest in anterior skull base and cochlear implant. Dr. Srinivas, sir,
Put this
professor,
off.
unit head,
Put this
St.
off.
John's Medical College and Hospital, Bangalore. Dr. Swaroop Kumar, sir, ENT consultant in Kamareddy since past 30 years. Please chair this session. And the moderator for this session will be Dr. Krishna Kishore, sir, and Dr.
We're
Rajesh
starting
Vepuri, sir. Ma'am, over to you.
Okay. Now put it on again. Put it on.
Just want to one more minute. Shilpi Bhatia Sharma is there. Shilpi, the next case, I think we are prepared for the pericranial flap also.
Mask.
3 pints of blood
Hello.
arranged. I'm starting from
Microphone.
here. Shilpi?
Yes. Microphone on.
Okay. I'm starting from here now. It'll take 1 hour for
On.
me to come.
On. It needs to be up. Quite up. This table down, and chair up. So, okay. Dr. Janaki.
Good morning, madam. I'm Dr.
Okay.
Navneet Agrawal. And,
Okay. Hello, Dr. Navneet.
madam, there's a question that will you get a CT scan done for all your cases in which unsafe area
yes.
is suspected?
Yes. Lately, what has happened is 3 mandatory investigations I have now started doing. For cholesteatoma surgery, I am always doing a CT scan. Previously, it was only when there were complications or it was a pediatric cholesteatoma. Lately, what I've done is, CT is very, very informative. First thing is, it gives us the detailed anatomy, anterior placement of sigmoid sinus, low-lying Milken fossa, and the status of the ossicles and rest extent of the disease. That is very important. And, cholesteatoma, you can start planning before surgery only. And the second is audiometry, which is mandatory, as you all know. The third mandatory important investigation is I always get a culture sensitivity done. Believe me, patient already has multiple antibiotics. Usually you get a pseudomonas infection resistant to many of the bacteria. And I take time with my patient, sit with him, tell him that we need to give certain antibiotics. before starting the surgery, because it has remarkably increased my, this outcome of the surgeries. We give specific antibiotics for certain days. Ask the patient to clean the head by washing it with betadine scrub 3 days before the surgery. And the antibiotics have been given, specific antibiotics based on culture sensitivity. And we always examine the nose, throat of the patient, because in this child, it could have been eustachian tube dysfunction leading to such disease at such a young age. So though in this case we found normal, and still we gave some decongestants and nasal drops to the patients. And these are the preliminary exercise I do. So CT is a must for me in every case of cholesteatoma. Now, may it be localized disease or extensive disease. Okay?
Thank you, madam. Madam, what kind of consent or preoperative sensitization do you have with the patient regarding the post-operative results?
Okay, it is very important. I have got 2 stamps made permanently. On one stamp, it says that such a case where there is a chronically discharging ear, it will take multiple days or months for the ear to get dried. Second, hearing may not improve to the 200%. There will be improvement, because hearing improvement is also one of the part of doing surgery, and rest routine in consent, telling about the complications that can happen, but in a milder tone. Not, we don't go overboard to keep telling that okay, you will have facial nerve and whatever complications we read in books. But okay, we definitely take consent from our patient for every details. We have made a detailed consent form there. Okay. So
Thank
2
you.
things you must tell: that the ear may take some time to dry. It will not be a magic that after surgery suddenly, because in such cases there is a purulent discharge, pseudomonas infection is there. So preoperative management in the form of culture specific antibiotics, post-operative specific antibiotics, and believe me, all the most resistant cases have been improved remarkably. We get good results because we take all these steps before surgery. Okay.
Madam, I have one question for you.
Okay.
Before you proceed with the surgery, hello.
Yes.
Yeah, I'm Dr. Krishna Kishore from Visakhapatnam. One question. This is about the diagnosis, specific diagnosis of this case, because it's a child of 11 years old with a history of ear discharge of 10 years duration. Means he started the complaints 1 year is. So here about the diagnosis, whether it is a congenital cholesteatoma getting infected and manifesting, or to start with the tubotympanic disease and with the secondary acquired cholesteatoma, or a primary. What would be your specific diagnosis for this benefit of the PGs and youngsters watching this?
Yes, definitely. I did my homework by going into details about this patient. It congenital or acquired cholesteatoma, or the way it has spread, like in 1 year so much destruction is there, though remote possibility of a granulomatous disease associated like tuberculosis. I don't know. That is the remotest possible, but main diagnosis remains the congenital cholesteatoma or pediatric. As I told you before starting to show the CT, congenital cholesteatoma is a epithelial rest entrapped in middle ear or anywhere in the temporal bone. The entrapped cells don't show so easily on the surface. They usually present as a white this mass, cholesteatoma mass behind the tympanic membrane. Congenital is usually involving either middle ear, mastoid, petrous bone, or all the 3. And it really takes a long time for it to come on the surface and present like this. This seems more like a perforation with invaginating epithelial margins going inside and causing cholesteatoma and restricting to this area of ossicles. Usually congenital cholesteatoma is classified into 4 classifications. First is when cholesteatoma is restricted to 1 quadrant. Type 2 is when it is involving more than 1 quadrant. It is around 2 quadrant. Third is when it involves ossicles. And fourth is when it involves all of the mastoid and going beyond. So it has to really expand a lot, then only come on the surface. So though I cannot be clear, but this seems a perforation and retraction pocket cholesteatoma, acquired cholesteatoma, rather than a congenital. Any input from the audience is welcome.
Yeah, what my question is whether it's primary acquired or secondary acquired, because 10 years
Okay,
duration.
okay.
10
That
years
is
duration.
acquired is primary or secondary, because it is mostly involving the posterior part. And I will see inside, look at whether it is a atic retraction pocket has gone inside, or it is a posterior superior retraction, which is secondary retraction pocket, because whole lot of the tympanic membrane and the bone is gone from the posterior part. You can see it is a aggressive cholesteatoma. So at this stage, I may not be able to move. Maybe it is a first thing I'm keeping is a primary cholesteatoma. Okay, maybe it is from atic. Disease has spread and gone and eaten up all the scutum and the ossicles. And
Thank you.
let
Good
us
morning.
see.
Good
Okay?
morning, ma'am. Good morning, ma'am.
Good morning.
In this case, whether you prefer to go for endoscopic approach or a microscopic approach, ma'am?
Okay, okay. For endoscope and microscope, you know, we all through nose, we have got so much acclimatized to endoscope. I love endoscope, but as I love laser, as I love coagulation, but every instrument has a space, has a right place to be done. Endoscopes I use only for visualization, or we can do stapes or in the lateral skull base surgery or anterior nose and skull base surgery. Endoscope I use only for visualization. I don't do cholesteatoma surgery with endoscope, because I, again, whenever I do the surgery, I take the name of my guru, Dr. KP Morwani, who has been mentoring me, who mentored me for this year's surgery. He taught me and we have learnt it. We remove every bony ledge lateral to the cholesteatoma. We start following the cholesteatoma in all directions, keep it intact, remove it in toto. We remove all the lateral bony ledge, so we don't need endoscopes actually. And cholesteatoma surgery with endoscope becomes quite tedious. The endoscopic surgeons must be knowing it. Cholesteatoma surgery is purely by microscope by me. Okay?
Yes, ma'am.
Ma'am, very good morning.
Very good morning.
Ma'am, do you do nasopharyngeal evaluation, ma'am, before this?
Yes, we did a nasopharyngeal evaluation. The doctors here have done nose, and this is clean. There is no adenoid or tonsil there. I
In
mean,
case-
not hypertrophied.
In case there is an grossly enlarged adenoids,
Oh, definitely we should, because this that means eustachian tube is blocked, and that's why I am keeping it as primary cholesteatoma, because secondary cholesteatoma happens due to the eustachian tube blockage, which leads to multiple mucosal fold and fibrous strand formation in the mesotympanum. That can lead to retraction pocket and cholesteatoma. Here the nose and throat are absolutely within normal limit. So eustachian tube blockage doesn't seem to be the first reason. That's why I'm keeping primary cholesteatoma is the diagnosis here.
in case it is grossly enlarged, when will you address it, ma'am?
Definitely, I will address it before doing any surgery on cholesteatoma. I'll start the antibiotics for ear, prepare the ear nicely. Already, I give 4 to 6 weeks for a cholesteatoma case. If it is quite wet and fulminating infection is there, we will do the surgery for adenoids first and remove the adenoid close to the eustachian tube, make the eustachian tube quite patent and happy, and then we'll go and do giving a gap of at least 2 to 3 weeks in between.
Okay, thank you.
Madam, give me just 45 seconds. Can I talk?
Yes, yes.
Okay.
Give
So,
me 2
ladies and
minutes, Janki. Janki, give me 2 minutes. I just want to show the steps I have already done so that we move forward, and then you can pursue, and then I'll show. Okay?
Okay, done.
2 minutes only. Okay? So we've already harvested the temporalis fascia graft, given a post-oral incision. Can you focus it there? I don't know whether. How to focus that? I don't know.
What microscope are you using? Labomed, right?
Is it clear?
No, not yet clear.
So focus it for.
No. First, you adjust your focus, then you
I want
adjust
to
the
focus
camera
it.
focus.
Okay. I have focused mine. Now you can focus it. for
Now
the
you
audience.
focus the camera.
Camera. Okay, okay.
Shilpi, do it with the centering.
Okay.
Slowly. No. Some more. Some more. Good. Thank you.
Okay.
Okay, ma'am.
So now we're in a surgical position. I'll just show the middle ear finding, suction and auto.
A little tilt is
speculum.
there. If you can move it clockwise, it'll be great. That's nice. Thank you.
Suction. Slightly smaller. As she has already shown you on the this presentation. Suction.
And do you take corners flap in all the cases as a routine, or you don't do that?
Microscope is not found. This you tighten this up. I hope this picture is clear with you.
A bit glare is there.
Little glare is there.
Glare, very much. Not able to see the structures.
Paper. There is paper there.
Too much glare.
Glare is too much.
Glare is too much. I don't know. Now it is getting focus. We can see the plaques there, deep in.
No, we will focus it for you.
Started
Focus it from here.
Pardon?
Yeah, now it's clear, madam.
Now it's clear.
Middle ear is clear. Now only it's glare.
Again
Why?
clear.
Some change in the speculum
I
direction.
think the reflection
of
coming
the
from
speculum direction.
The rim of the speculum.
That is better. Yes. Now change
Again
the speculum. Thing.
And definitely is the
No, that
speculum.
way. The anti-clockwise. Yes.
At a particular.
Madam, you've seen the finding. No problem. Carry on. Now it's fine. Now it's fine.
It's
Now it's fine.
perfect now.
Yeah, the reflection of the speculum.
Focus कैसे करना?
That's why you should have a well coated black speculum without any reflection.
This is black only.
Yeah.
This is coated black only.
Oh, still it is giving
तो
that.
ये देखो इसको focus करो. So this is all cholesteatoma flakes there involving whole of the mesotympanum.
Yeah, a lot of cholesteatoma. Yeah.
Lot of cholesteatoma.
Yes.
It's quite bad. Huh?
Yeah.
This is all cholesteatoma, and what we have done is we have already gone through post-oral route. Okay.
Post-oral. That's
Yes.
routine preference.
This is my
post-oral.
routine. Yes. Hold it. Give me God's
Because
grace.
some people do it endoral approach.
Yes.
It's an individual preference.
Post-oral is one which I really love because it does not show. If we do subcuticular suturing, it doesn't show after a few days, and that endoral route, it shows this incision line is visible anteriorly. Okay, now it is a good wide approach. What I've done is I've already harvested the give me right angle retractor. I've already harvested the temporalis flap there, the temporalis fascia.
Yeah.
You can see almost 3 into 3 centimeter size fascia should be harvested, because the moment we take it out, it shrinks by 1/3 its size, and we really need big fascia to cover. If it is a canal wall down, we'll need to cover the middle ear and mastoid cavity with the fascia. So fascia should be as big as possible. Now, because this is a cholesteatoma surgery, I will need the obliteration of mastoid cavity if needed. So the musculoperiosteal flap is, we give 2 incisions. Give me a sharp instrument.
Yeah, fashioning of the flap in the very beginning.
This is musculoperiosteal flap.
Yeah.
This is one horizontal incision between the temporalis and postoral muscle, and other is along the curvilinear incision along the bony canal wall. Can you see there?
Yeah,
This
very
is
near to the
spinopelvic.
bony canal.
So I have lifted it, and it is posterior inferiorly based flap. We have exposed, we can expose as much as possible. This is a child. We'll be careful because we may reach, if we extend more emissary vein there. And had it been a younger child, we'd be very careful down there, because the facial nerve mastoid tip is not developed and the facial nerve is quite superficial there. Though this is a 11-year-old child. Now this is spinophenolae. I'll hand it over to Dr. Janki. This is the posterior. This is the skin of the external canal. Can you see?
Yes, ma'am.
Cartilaginous external canal, then the skin of the posterior canal wall. I am not going to give any myotomy incision here. I'll just lift whole of the skin
Okay.
anteriorly and keeping a strip of skin attached anteriorly. Rest of it goes anteriorly in the self-retaining mastoid retractor. And I'll be giving this incision at the level of annulus. Deep
Okay.
down there. So whole of this skin will be used for myotoplasty, which is the most important step of the surgery. So now I'll hand it over, and this is floor cartilage. Can you see there?
Yes.
The lower part of the conchal cartilage. This is very important cartilage. We can use it for multiple purpose, for ossiculoplasty, for obliteration, for clearing this part as myotoplasty. So this is important. We are saving it presently. We'll see how much of it is needed later on. So now over
Okay.
to Janki.
Yeah.
I'll be lifting.
Thank you, madam. Just 45 seconds
Oh,
again.
yes.
So, my dear friends, I just want to thank you for coming here all the way from your places all over India. And may not be able to meet you again because I'm going back to the theater. From the theater, it takes around 1.5 hours for me to come here. And by the time I finish, maybe it'll be 3 o'clock, and some of you might be taking your flights. I really consider it as a very big honor because this is my first workshop in Hyderabad, but you will be seeing many more purely academic workshops. And thank you very much. I take a big bow from you.
Circular knife. You're doing very fine. Perfectly
I
fine.
thank
team.
each and every one from my
Good
heart.
team.
Without you,
Okay.
this is not possible.
You're
Number
doing
one.
very fine.
Number two, I thank all the faculty members for coming all the way, some doing there, and then their cases they have shown, like Dr. Madhuri Mehta ji, Dr. Deepak Haldipur ji, and Professor Kirtane ji. So many people have come here, really thank them. And I especially want to thank the Sun Pharma. In fact, they have done an incredibly good job. Purely academic. I generally associate with people who mean academics. I don't go come for a trip to Armenia, Goa, and say, boss, there are so many other. I don't want to do that. So they were purely professional, academic, and that's exactly what we want. And in case in future also, we will be carrying on with academics. So with this, I take leave of you. Maybe I may not be able to personally thank you and send you. I would love to open the doors of every car which you go.
Knife.
I may not be able to do that. Thank you very much and thanks. Yeah.
PP ठीक रखने का.
Okay.
थोड़ा
Sure.
बढ़ रहा है.
So please stay for the next case. Don't go away. That's really an incredible case. I've done it. I'm doing it for the first time. Thank you.
Thank you. Wash. Give me wash.
Well,
Take a smaller
on behalf of
section,
the
please.
candidates,
Take a
I would like to
smaller-
thank
this
Dr.
is-
Janki.
But give me
all of
once.
us.
You can take another one.
And thank you so much. And we look forward for further in the future. Thank you so much. Thank you.
Too big. You take a smaller one, okay?
And Dr. Madhuri, we are back to you.
Okay, thank you. Thank you very much.
One question from me. Before
Is the picture clear? Do we need to make any further fine tuning?
picture is clear. We get a good microscopic view here. Picture
Okay.
is good, clear, well focused. Okay.
So now once I lift the flap, I will tell you what my planning is. Okay?
Now,
Scissors,
before that,
micros-
can I ask you one question?
Yes, why not?
Yeah. You have made all your strategy for a canal wall technique and obliteration because it is a small child. Can you consider it canal wall up technique in this case by any chance?
Yes, I will just let me lift this flap and then I'll talk about that. Okay? Give me 2 minutes.
You have not yet
What
decided.
I have
on-
done, yes. What I have done is I have lifted this flap.
Yeah.
You see, I have given myotomy at the level of annulus.
Oh, still you are
Okay.
open with whether canal wall down or canal wall up.
Well, I'm going to
open.
talk about that. I'm going
Oh.
to talk about that in 2 minutes. Let me first lift it up.
Yeah.
This is the whole skin I have lifted. I have not given any cut here because I want to use it as a total skin tube for the myotoplasty. So I have given incision at the level of annulus. Can you see? Now I have not disturbed the integrity of the cholesteatoma sac. Okay.
Okay.
And just lifted it. I'll put it into the self-retaining mastoid retractor. Okay. And then I'll talk about canal wall up or down. Okay.
Fine. That's fine.
Just 2 minutes. Okay.
Yeah.
I'm lifting it so that the
A
visibility
bit
is
fine
clear.
focus may be needed. A bit fine focus. I think
Okay.
you may be
Fine focus.
seeing a good picture there, but we need a little bit of fine focusing.
No, fine. I also need a better picture. Okay. Is it focused?
Yeah, no, not
Wash.
yet.
Wash. Focus it, please. First thing is focus. Is it focused? I'll take in a bigger magnification. Now is it okay?
A little bit of fine focusing is definitely needed, I believe.
Okay, we'll not move further. First, we'll do the fine focus, please.
Okay. If I'm doing that, I will tell you.
How to do the fine focus here? For me first. No, this is not over.
We
Now
are
you
seeing
do.
the picture a bit blurred. Otherwise, it's there on the field. The tympanic membrane.
There seems to be a glare there, no? Scissor though, micro scissor.
Yeah, a bit clear. At the same
Micro scissors.
At the same time, the surgeon's view point, you need to rotate the microscope a bit towards the left side.
It is okay now? Perfect?
It's okay. But we have to orient in surgeon's viewpoint, no? You have to rotate the...
Okay, this is slightly okay.
Yeah, you have to clockwise. You have to rotate still. Yeah,
Now
still.
this is okay?
A little bit more. A little bit. You have to rotate.
Okay?
Still.
No. I think that will become too much. You see,
Okay,
this is
then it's okay then. We can make it.
this is the mid of the posterior. This is mid of the anterior. This is superior. This is
12
inferior.
o'clock, 6 o'clock.
Okay.
It's okay. Fine.
The depth is focused there. Can you see? Because I am going to talk about that only.
Yeah.
The handle of now the importance.
Yeah, it's
Finding,
focused.
you know what? Somebody was asking whether it is a congenital cholesteatoma or acquired. Now I'll show you. Give me a sickle knife. Are you satisfied with the picture, sir? Yet not satisfied? Hello?
Yes, please.
The picture is okay?
It's okay. Okay, you can go ahead.
Okay. So now what? There is a anterior perforation. Can you see there? If you are not being able to appreciate, maybe the picture is, this is the anterior perforation. Can you see there?
Yes, ma'am.
The perforation in anterior quadrant.
Yes, ma'am. Yes, ma'am.
That is a perforation.
There is so this is not a case of congenital cholesteatoma,
Yes.
cotton ball, because there was a perforation there. And this is the attic region. I'll show you. This handle of malleus, lateral process. Can you see?
Yes, ma'am.
And this is
Yeah.
the Prusik space.
Yeah.
Okay.
Yeah, ma'am.
Yes.
Prusik space is between the neck of malleus medially, laterally the pars flaccida, and superiorly the lateral malleolar ligament or fold. Okay.
Yeah.
This is the
Yes, ma'am.
smallest part of the epitympanium, which gets very, this ventilation to this part is very less. Okay.
Okay.
But this seems a big perforation there. And this has almost eaten up the whole of the tympanic membrane, and the cholesteatoma has gone. Can you see the cholesteatoma going from the margin of the perforation? Can
Yes,
you see
ma'am.
there?
Yes,
Is it
ma'am.
visible? So
Yeah.
this seems to be a secondary cholesteatoma. Okay. Because attic, it is not going from the attic. You see,
Little bit
attic is there.
focus.
This is attic. Okay, focus is bad. I
Yes,
can
ma'am.
understand. Now please make the focus better, please. For me, it is okay. When it is okay, do let me know. We are focusing here.
I think that is the best focus we can get.
I think so. Sorry, sir, for this. I'll try to cover up with my imaginary imaginary conversation. Okay, so I'm taking this becomes too big for you, you know?
Anyway, you are orienting us very well nicely. So go ahead with your surgery.
So I mean to say the atic region and this scutum wall is not gone that badly, which would have happened in a case of atic cholesteatoma. Okay.
Yes,
Yeah.
ma'am.
It seems this is a big perforation anterior and posterior to the handle of malleus. I hope handle of malleus is visible. You utar do, take it off. I don't know. This is all coming in the way. This is all. Just give us 1 minute. We'll try to focus it more. Easy. This is clean now.
If the lens of the microscope be
I think.
a bit clean,
Give me one thing for to cleaning the
lens,
microscope.
how is the lens of the microscope? Any dust over there? Please find out.
Give me this light is maximum.
Yeah.
Okay, give me one gauze piece to clean the lens. So till we do that, as we were talking, dry. As we were talking about inside, this two things are there: inside out or outside in.
Yeah.
Canal wall up or canal wall down. Okay.
Yes,
ma'am.
yes.
Is it better?
Ma'am, it is
Yeah.
not, ma'am. Now it is okay.
Okay. So okay.
Madam, first point is whether it is the canal wall down or canal wall up. If it is
Yes.
canal wall down, inside out or outside in.
Okay. Okay. First important thing is how we go about it. It is always inside out for me. Only in case where there is a postoral fistula or abscess that has eaten up the cortex of mastoid, then I can follow that track. Otherwise, I'll not open up the mastoid unnecessarily. It is always in other disease, as in other diseases, we always start from where the disease has started. So for us, it is always the atic or the posterior or the mesotympanum area from where the drilling starts in an inside out manner. Inside out mastoidectomy has many advantages. One of it is we are always on the disease. We are following the disease from where it starts and we keep following it till the end in all directions. We don't disturb the continuity of cholesteatoma sac. That way we are able to remove the whole of it without leaving a suspicion of leaving behind the cholesteatoma. Third thing is we start with a single cavity and finish with a single cavity. We never create a facial ridge or bridge if we have to do a canal wall down mastoidectomy. And in case there is a low-lying tegmen bone or anteriorly placed sigmoid sinus, we are able to know it before reaching there. So inside out is always a safe and the right technique. So for me, it is inside out unless until there is a fistula or abscess in the mastoid bone. And then coming to canal wall up or canal wall down, this operative finding will lead me to the technique. If it is restricted to antrum only, I will do reconstruct the posterior canal wall with the help of a cartilage. And if it is going beyond antrum, then I'll not take the risk because it is a child. I don't want a revision surgery for him. I'll go ahead and do the canal wall down mastoidectomy and do the obliteration of the mastoid cavity in 3 layers so that the cavity becomes a wide canal. So we'll not be finishing with the cavity there. Okay. So cavity never exists for us. We'll always reduce it by doing the mastoid obliteration. And if it is a canal wall down, I'll show you today only, or I'll do the posterior canal wall reconstruction if it is restricted to the antrum. Okay.
Okay.
Okay, very clear. The concept is very clear.
Ma'am, while doing inside out technique, how to safeguard the facial nerve near the second geno area?
Okay. For that, the important thing is there are 4 major steps of the mastoid cholesteatoma surgery. If we keep them in mind, we are never going to have any difficulty in a single case. One thing is it should start with a canalplasty. First,
Yes.
we do the widening of canal in all dimensions till the annulus of tympanic membrane is visible in all directions, all dimensions. Okay. So
Okay, ma'am.
canalplasty is the first step, always, always, always. And canalplasty is done from outside in, which means from lateral to medial. Laterally, we will use a cutting burr, and medially, we'll take a diamond burr. Then comes inside out. Now, when I start the inside out, second step is inside out mastoidectomy or atticoenterostomy, whatever is the procedure. So when I'm doing the inside out, I will not disturb the ossicles if they are there. And I always drill the lateral scutal wall. I am not going medially. I am not touching the cholesteatoma medial wall in any way. And we start from anterior attic in a C-shaped manner. We always keep coming out. So there is no risk of causing any trauma to facial now. We are always moving away from the important structures, as you will be able to see in this case. Okay?
Okay, ma'am.
So
Ma'am,
now
near
I'll
the-
start.
Ma'am, one doubt, ma'am. Near the second genu area, ma'am.
Second genu area.
While doing inside out.
Okay. I'll show you. This fear should go out of your mind forever.
Okay, ma'am.
This is you can see the head of malleus there.
Yes,
Can you
ma'am.
see the head of malleus moving?
Yes. Yes, ma'am.
Okay. So
Yeah,
there
ma'am.
must be the stapes beneath it. So
Yes,
what
ma'am.
I'm doing is I'm going to drill this wall. Na?
Yes, ma'am.
I'm not
Yes,
going
ma'am.
medially. I'm
Okay.
drilling around and coming out.
Yeah, ma'am.
Drilling around and coming out. Second genu is just anterior medial to the ampulla of lateral semicircular canal, which is deep, which
Yes, ma'am.
forms the medial wall of the antrum. We
Yes,
are
ma'am.
only working on the lateral wall of the attic and antrum. So
Okay,
if we
ma'am.
know our anatomy, we are never going to disturb the continuity of facial nerve. So it
Okay,
is
ma'am.
always the lateral wall we are working on. We don't touch the medial wall. Okay. So
Yes,
I
ma'am.
will show you today so that you will know second genu does not come in the way when we are doing inside out in the start. And then we can always see it when the rest of the structures appear. Okay.
Okay, ma'am. Okay.
Now for canalplasty circular knife. So how we know how much drilling is to be done for the canalplasty? There's an interesting instrument. We all know this is circular knife. Can you see?
Yes, ma'am.
So this is very good instrument for cholesteatoma surgery. I'll put it there. Can you see?
Yes, ma'am.
This is the area. This is the area of sinus tympani. This much is this retraction pocket is going there. And almost 4 to 5 millimeter of posterior canal wall can be drilled very safely without coming across the anterior margin of the fallopian canal. Okay? So
Okay,
there
ma'am.
is a bone thickness of 4 to 5 millimeters, which can be easily drilled. And there is always this prominence of pyramidal eminence that the facial nerve lies behind that. So there are
Okay.
so many roadmaps, there are so many landmarks which will guide us. So this much depth of the this canal is to be done. Here also, here all around I'll be drilling the canal, and you will see how wide the thing becomes. And then the inside out mastoidectomy becomes very clear.
Okay,
Give
ma'am.
me drill.
Ma'am, how do you avoid flap injury during inside out?
How do I avoid?
Flap injuries, ma'am. Flap.
Yes. That is how. That's what. Give me sickle knife. This was in the start I showed you. This is a beautiful way of doing it. This also I learned from Morvani sir only. This is the skin of the extraoratory canal. Can you see? I
Yes,
did
ma'am.
not
Yes,
give
ma'am.
incision here at the I did not give incision, meatotomy incision here. I gave incision there just lateral to the annulus. Okay.
Okay,
So the
ma'am.
whole skin has gone anteriorly. It is not coming in the way. Can you see?
Yes, ma'am. Yes, ma'am.
The whole middle ear is visible, and this is away from us and
Yes, ma'am.
beautifully lying. I'll not be tearing it because it is not coming in the way. So
Yes,
this is a good technique of not giving incision at the bony margin. So giving incision at the smaller. So it is always inside out. Now I'll show you step by step how to make it a safe surgery.
Okay, ma'am.
Okay.
Ma'am, size of the parts, please mention about the size of
Yes,
parts which you are
Tell
using.
me the size what you're giving. Okay. We don't take the biggest. We'll take around 4 to 5 mm. Around 4 mm.
Okay, okay,
This
ma'am.
is again bigger. Give me one smaller. Yes. One size smaller. I think this is give me one size smaller than this. We will start with cutting burr and always start in a circular manner. parallel to the wall. It should not. These are mine. Okay. So this is the size. Okay. Can you see?
Yes, ma'am. Yes,
Skin
ma'am.
is so much anteriorly. I'll start in a C-shaped manner.
Size,
Just
ma'am.
trimming
Size,
down the.
size of the burr, ma'am.
Is it okay? The thoda focus kare bahar. No, we will focus it outside and then go inside.
Maybe 3 mm bar.
Ma'am,
perhaps.
size of the burr?
It is, I think, 3 mm.
3 mm. Perhaps 3
Okay.
mm.
Okay.
Okay, ma'am.
Now just see. First trimming down the spine of Henley a bit. Okay.
Yes, ma'am.
Now this is bony ledge.
Like performing a little bit canalplasty.
Like, bahut
Can I
thoda.
call it a canalplasty?
This is canalplasty. What is asking me? Can you see? One size smaller. As I go medially, I'll change this size. Focus फिर से करेंगे. Focus it there. This blue one is. So you do. I'm one hand. Okay, too fast. Acha, okay. Is it focused now?
Yes, ma'am. Yes, ma'am.
Okay, so this is canalplasty in progress. One thing we have to keep in mind, the jugular bulb may be highly placed. So we'll have always an eye over there, that area. Okay.
Ma'am, by keeping the round knife, how can you say that we can go up to 3 mm below?
Oh, round knife. That is the depth of the fallopian, the anterior wall of the fallopian canal comes after that. This is the depth of the sinus tympani. Give me circular knife.
No, no, ma'am. How can you assess it is 3 mm?
No, I did not say 3 mm. It is the usual depth of the bone up to 4 to 5 mm. Acha, okay, about the burr size?
No, ma'am. By keeping the round knife in the
Round
middle
knife
area-
is, just see. This is almost a 4 to 5 depth circular knife. Okay?
Okay, ma'am. Okay, ma'am.
It is going almost. Now, when I do drilling, it will start becoming visible. Now it is dipping inside. Can you see?
Yes, ma'am. Yes, ma'am.
It is dipping inside.
Yes, ma'am.
Superiorly, so it is going into attic. It will go very deep down.
Okay, ma'am.
Here, just see. It is not going that deep.
Yes,
Okay?
ma'am. Yes,
So
ma'am.
that much bone needs to be removed. I'll keep
Okay.
showing you in between.
Okay, ma'am.
The residual tympanic membrane will become very clear after canalplasty.
Okay, ma'am.
Now that I am going close to the medial part, I'll shift over to a diamond burr. I don't want to disturb this skin is 24 karat for us.
Yes,
We have to save every bit of it because the normal skin is needed when we are doing the repair. Side knife or flag knife. Okay, give me that. Sir, this is diamond burr. Okay. So as I go medially, I shift over to diamond burr. Can you see?
Yes, we can see it very clearly. Shifted to diamond burr. That's actually safer, a diamond burr.
Yes,
here.
always.
Ma'am, now which area you are drilling?
I am drilling the lateral, I am close to lateral scutal wall. Can you see this? This is
Yes,
the head
ma'am.
of malleus.
Yes, ma'am.
Okay.
Yes, ma'am.
Beneath it, that will be the incus. So I am just doing canalplasty. I'll start my inside out mastoidectomy in this area.
Okay, ma'am.
Okay.
Okay,
So
ma'am.
but before that, I'm doing a good canalplasty because when I'm doing the repair, I should be able to see the whole lot of. Can you now see the normal tympanic membrane appearing?
Yes, ma'am. Yes, ma'am.
Yeah. Can see a nice canalplasty there, and the visibility has improved a lot after doing this.
Yes. So canalplasty is the most important step to start the surgery. Now I'll put the round window and I'll show you how it looks around this circular knife and show you how it looks now.
Okay, ma'am.
Can you see the margin is appearing?
Yes, ma'am. Yes, ma'am.
Give me round window, this round knife, circular knife. Now you see, we have almost reached there. Okay?
Yes, ma'am.
Yes.
It is not dipping anymore.
Okay.
Here also,
Sometimes if the TM joint gets exposed through this.
yes, yes, yes. For that, two things are important. One thing is always shift to a diamond bar. Always. Anteriorly, the tympanic plate is very, very thin.
Very thin. Yeah.
Very thin. And second thing is, by accident, if it gets exposed,
Yeah.
so ligament is very strong and you don't find any difficulty leaving it there. You don't have to do any repair there. Okay?
Yeah.
Drill
There won't be much
No.
problem even if it gets exposed.
Yes, yes, yes.
Yeah, that's good.
So I'm doing widening because this ear has to sustain. It has to be self-sustaining ear. I don't want a very narrow cavity there, narrow external canal, which is not able to cleanse itself. Okay, so this is a wide canalplasty I'm doing.
That is the area of TM joint, ma'am. Is that is the area of TM joint?
Yes, this is the area for TM joint. Okay, this.
Okay.
And
Okay.
further medially is station.
And then you do what you do in a very gentle feather touch manner. We always try to avoid unnecessary injuring the important structures. Okay.
Yes, yes.
So it does not really give any harm to the patient, but we shall avoid. Our
Yeah.
surgical, give us one. Our surgical aim should be to achieve perfection, which we may not achieve, but we will achieve excellence at least. Okay. So
Yes,
every
yes.
time try to save the important structures.
You have to take the precautions not to do too much
Yes.
of thing.
Yes. So anteriorly, I am exposing the annulus. Can you see there?
Okay.
Yes.
Yes, ma'am.
Anteriorly, the annulus is visible there.
Yes. Yes.
Yes, very much visible now. Good exposure we got after this canalplasty, you can
Yes.
say.
Otherwise, you work in small areas and unnecessarily you compromise on surgical steps.
Yes, yes. This makes a lot of difference.
Yes.
Yes, ma'am. Yes.
Good exposure. The annulus is very nicely seen now.
Now it is seen and makes easy for me
Yeah.
because when I am doing surgery, I am planning till the last point when I'll be doing the reconstruction. And just removing the disease is not good. We have to do the good reconstruction as well. Can you see the whole annulus visible anteriorly now?
Yes, ma'am.
Okay. Is it visible?
It is visible, ma'am, but lot of glare.
Yeah, it's visible. We can make out.
Sorry, I cannot help much with the microscope, but I'll try to show this on some magnifications. Okay. So anteriorly, the canalplasty has been achieved. Now coming posteriorly, how much is left? I'll see the patient is getting light, I think.
Ma'am, are you operating in GA or LA?
GA, this is a small child. But
Okay,
you
ma'am.
know, in my hospital lately, what I've done is, I've started doing all cases in GA because this becomes our prerogative because patient when cries later on that I could feel you operating on me, it's not a good feeling, no?
Yes, ma'am. Yes, ma'am. Yeah.
So you give the best to the patient so that he remembers it as a pleasant experience, not a such terrifying experience. Okay, now the canalplasty is over.
Yeah, please orient us once again with 12 o'clock, 6 o'clock, 9 o'clock, and 3 o'clock.
Okay,
with a pointer.
definitely.
This is
I'll
a
do
bit
that.
Tilted picture we are seeing here.
I'll do that. Okay. Wash. Give me wash. So I'll show you smaller. It's too jumbo sized. Now I made it clear. Okay.
Yeah, clear.
Final वो कर दो उनको focus. Circular knife. Now see, this is 12 o'clock or 6 o'clock.
Yes, ma'am. 6 o'clock. No,
That
no,
is
no,
6
no.
o'clock.
Okay, yes, this is
We are
rotated.
seeing a
I
very
know. Now
tilted
you are
picture
right.
here. Yeah, that's no, no,
Now
no.
I think this is better. This is 6 o'clock. Okay.
That is 6 o'clock. Okay. Well,
Ma-
it's not
This
well
is
oriented
12.
here.
Now it is better oriented, I think. Huh? This is 6 o'clock, 3 o'clock, 9 o'clock, and 12 o'clock. At
Okay.
12 o'clock, you can see the
Yeah, yeah.
malleus.
Yeah, is it possible to tilt the picture clockwise, at least
Slightly clockwise. Okay.
yeah, clockwise.
Okay.
Is be a bit more. Yeah, that would be better, I think. Yeah.
Okay.
Yeah.
Give me
Okay, ma'am.
Okay.
diamond birthday. So I will show you with the circular knife that the whole canal has been widened. Don't put water. Now this is to stop the bleeding. We just run the dry diamond burr without putting any saline. So this will control the bleeding there. Can you see?
Yes, ma'am.
Yeah. Drilling with a diamond bar without irrigation. That is the key
Without
point.
irrigation, you will get the dry. This bleeding will be controlled. Okay.
Yeah.
Now
Ma'am, while drilling inferiorly near the annulus area, sometimes the facial nerve can lie anterior to the annulus in the inferior part. Is it right?
No. Facial nerve is never that anterior unless until it is abnormally placed, which should have been visible on CT scan.
Okay.
So in a normal position, facial nerve, it is never going to come. Give me one instrument. You were asking me this area?
Yes, ma'am. Yes, ma'am.
No. It is going to be, I tell you, many millimeters behind. I'll show you. This facial nerve doesn't come like this. It goes there at this tip of the mastoid. Can you see there?
Yes, ma'am.
The temporal mastoid suture should be a
Yes.
landmark here.
Yes.
Okay.
So it does not come that anteriorly. If it is anteriorly placed abnormally, then shall be able to see it on the CT scan. Okay. So
Ma'am,
this was
in Mariosana itself, it is given that while you are going inferiorly, be careful. The facial nerve sometimes lie anterior to the plane of the annulus. Is it right or wrong?
no. That normal facial nerve never lies anterior to the plane of annulus.
Okay,
You
ma'am.
can very easily do the drilling there. You can do nicely. This is hypotympanic area, and if I do canal wall down, I'll show you. This is safe.
Okay, ma'am.
This is safe. This is hypotympanic area. Facial nerve
ma'am.
doesn't come that far. Okay.
Okay, ma'am.
Now I will start with inside. This is the second step of the surgery. Inside out episiotomy. Okay.
Okay, ma'am. Okay.
Now
ma'am.
give
Super.
me a smaller burr diamond. I will start because now this was canalplasty from lateral to medial side. Now I'll do the inside out from medial to lateral side. Okay.
Okay, ma'am.
So now many people don't even address the anterior attic area. Can you see the anterior attic area there?
Yes, ma'am. Yes.
And can you see the disease is starting from there? And people tend to leave that area. Can you see now it is focused?
Yes, ma'am.
So what I'll do is, my planning is to remove the lateral attic wall in a C-shaped manner,
Okay, ma'am.
exposing the cholesteatoma in all directions. Okay?
Okay, ma'am.
Yes. I will uncover it till I am reaching the outermost extent of the VP. ठीक है?
Drilling the scrotum.
So it always the inside out starts from the anterior attic in a C-shaped manner. Can you see?
Ma'am, inferior part of the C.
Anterior most part is the anterior most wall of the attic. Can you see there?
Yes, ma'am.
Give me, this is, I think BP is slightly, table थोड़ा ऊंचा करेंगे? Is the picture clear?
Yes, ma'am.
Clear.
Okay. Give me cautery.
Ma'am, you are drilling in a C-shaped manner, no, ma'am?
Yes.
So-
From there to there. Only the lateral attic wall. Only the lateral attic wall. That is the scutal wall. Cautery.
Okay.
Cautery, monopolar cautery.
Can I call it transcanal atycotomy?
Yes, yes, yes. You can call it that. Because we are working in canal only. Okay. Okay. Now give me the drilling.
Ma'am, position
Now?
is please little bit orient us, ma'am. Actually, the position.
Okay, okay, okay. Okay. Give me sickle knife. I hope till now I have made points clear.
Yes, ma'am. Yes, ma'am. Right.
Okay. Now this is 12 o'clock.
Yes,
Okay.
ma'am. Yes, ma'am.
Focus is not there. Slightly more focus is there. Is it better? Can you see the neck of the malleus there?
Yes, ma'am. Yes, ma'am.
Neck of the malleus, lateral process. So this is 12 o'clock. Okay.
Yes, ma'am.
Anterior to the handle of malleus and the processus cochleaformis is the anterior atic place. Can you see? This
Yes,
is
ma'am.
the area of eustachian tube covered
Yes, ma'am.
completely by the cholesteatoma. This is supratubal area, and we will see the tensor tympani muscle there when we
Yes.
lift the cholesteatoma sac. And
Yes, ma'am.
above that is the anterior atic place. Can you see there?
Yes, ma'am. Yes, ma'am.
It is completely covered, and as our protocol is, we are not going to disturb the continuity of cholesteatoma sac till I expose it in all directions. So I'll keep it intact and sacred and lift it gently and show you all the structures. Okay?
Okay,
So
ma'am.
now I'm coming from anterior to posterior, trying to follow the cholesteatoma sac. Okay?
Okay, ma'am.
So I will do the drilling so that I'm able to lift this sac without. So here I don't need the endoscope. Can you see?
Yes,
I'm
ma'am.
making all the bony ledges. You can see the anteriormost part of the cholesteatoma.
Yes, ma'am.
Okay, now I come posteriorly. Keep drilling the lateral attic wall in an inside out manner. Can you see
Ma'am,
this?
is your burr is touching the ossicle or is the part of the burr is touching the ossicle, ma'am, or?
No, it is okay because there is no incus and stapes. So we shall be taking care. If it is continuous ossicular chain,
Okay,
we
ma'am.
are very careful. But here there is no long process of incus, no suprastructure of stapes. Okay.
Okay, ma'am.
There is no continuity on ossicular chain, no continuity at all. Okay. This is only malleus. There is no long process of incus there. I'll show you.
Ma'am, in case if there is continuity.
So definitely we have to be very careful. What I'll do is I will remove it then with the curate. Once I will thin it, give me curate, sister. So what I'll do, then I'll only rub the this diamond bar laterally and then remove this with the curate without touching the.
Ossicular chain.
Yes.
Or can we disarticulate the incudostapedial joint and continue with the drilling?
Yes, that can be done, but no. Incus is a very good saving landmark for facial nerve. We try to keep it till we have exposed nicely, okay? So
Okay.
incus is our friend. Sickle. Incus is always our friend. We try to save it because facial nerve lies medial to it, okay?
Yes, ma'am.
What I'm asking about disarticulating the incudostapedial joint so that the burr.
Yes, we can disarticulate. Yes, absolutely. Your suggestion is absolutely right. That incudostapedial joint is to be disarticulated and let the incus be there, but should not be touching the stapes. That is what you mean to say, na?
Okay. Okay.
That is to prevent the acoustic trauma that can happen to the labyrinth.
But usually when it is intact, na, we'll keep drilling on the lateral wall and rest of it we'll do with the curate only. Okay.
I see. Okay. That's a good idea. A precise dissection, as you said.
Yes.
Facial nerve is medial to the fossa incudis. So
Now you
it's
can
always
see
safe.
this seems to be the cauda,
Cauda.
inflamed cauda. Can you see?
Yes, ma'am.
Inflamed cauda, and if needed, I will cut it rather than traumatizing it. Okay. So
Okay.
there are lots of studies which tell that patients were followed 6 months, 1 year after surgery. 3 situations: cauda not touched, cauda stretched, and cauda cut. So out of these 3, cauda not cut and cauda cut were the two situations where the patient improved after 6 months and he said that the taste is not, he's not bothered about the loss of taste on that side. But if we stretch and traumatize the chorda without cutting it, that becomes more dangerous. Patient can have perverted taste on that side. Okay. So if
Okay,
a situation comes, because this is already an inflamed chorda, can you see that?
Yes, sir.
It is
Yes,
not a
ma'am.
normal chorda. Anyway, I'm keeping it anteriorly. I am showing anterior to the this neck of the malleus. Can you see this?
Yes, ma'am. Yes, ma'am.
There will be anterior malleolar ligament and the chorda even. Okay.
Yes,
Yes, ma'am.
You see, and there is a cholesteatoma sac beneath it. I am not touching it. I am still removing the lateral bone of the attic. Give me drill. So this is chorda. I am making a drilling there. And to avoid hitting the tegmen, many a times tegmen can be low lying.
Yes,
So
ma'am.
again, my circular knife comes to my rescue. Circular knife denge. I will show you how we know where is the tegmen. And a very good instrument is
Once you
circular knife.
finish
It
again, we'll
always
get the
guides us
audio-visual.
because we have to
Please show
show all
what
the
you have done
lateral bony ledges. Give me circular knife.
No, one show, ma'am. One
Well,
show.
what the what? No, no, what?
Now just see.
Why
Can
not?
you see?
Yes, ma'am.
Yes, yes. It's
It
dipping
is
into
going
the
deep.
attic.
Yes. So this is the attic. The tegmen is quite high up. Okay.
Okay.
So I'm
Yes,
not
yes.
bothered when I'm drilling in that.
Yeah.
Everything I should be careful. I should not be opening the structures, and inside out is beautiful in that way that we keep moving away from important structures. Can you see? We are not going towards it. We are moving away.
Ma'am, while you were drilling that area, inferior area, that area, yes, ma'am, that area, the
Yes.
precautionary measure to take, because that is the area of stapes, no, ma'am, anteriorly.
No, stapes is far behind. Let me show you. इसको थोड़ा एक सूचर लगा देंगे.
Yeah, 1 minute. Let them
I'll
switch
show
it
you.
on, no? Then only I can.
वॉश देंगे. इसको एक
Yeah.
सूचर लगा देंगे.
क्योंकि ये वायर एक लूज है ना कुछ स्ट्रेट गैस तो हाँ
Okay.
हेलो
Tickle.
हेलो
Yes, sir.
Tickle. I'll show you the incus. Okay. Can you see the incus?
Oh.
Hello.
Yes, ma'am. Yes, ma'am.
Can you see the incus?
Yes, ma'am.
The
But
infusomalleolar joint there.
yes, ma'am.
Can you see?
Yes, yes, ma'am.
Yes, yes.
And there is no long process. It is all eroded.
It's eroded incus. The
Okay.
body.
So now if I am drilling this bone,
just about
the stapes is deep down by. We are quite lateral.
Okay, ma'am.
Okay. This is the long process. The stapes would be down there.
Yes, ma'am.
I thought it
So
was
this is the area. Give me curate. I'll show you
Yeah,
this
yeah,
the
it's
area
a
from where the chorda comes out from the posterior wall.
This is the wall of the bulla remnant, you know.
Okay.
Again,
Can you see the chorda?
45-degree upturn Blakeslee.
Can you see the chorda?
Yes,
Yes,
ma'am.
yes,
Yes,
the
ma'am.
chorda. Okay. You
Chorda.
can see the emergence of chorda there.
Yes, emergence of chorda. Maybe it is still lower down. The emergence will go down, lower down.
Yes.
So I'm clearing it. Just give me sickle. I want to show you the area of stapes so as to remove that fear.
Yes.
Yeah.
Okay.
Yes.
So now see.
Yes, ma'am.
This should have been the area of long process of incus. Okay.
Yeah, that should be.
There is no long process.
Come on.
Can you see?
Yes, ma'am.
Connected the
So long process would have been like this. And this is the deep area where the stapedial footplate is there.
Yes, ma'am.
नहीं लेकिन ऑन होना चाहिए ना वो
Can you see the
hello
footplate area so deep down? We are
Yes,
quite lateral.
Okay, ma'am.
Okay, we are drilling the lateral attic wall. We are not going on the medial side. And this stapes is quite medial there. Can you see this? The incus I am not removing because if this is footplate,
yes ma'am,
this is the area for the facial nerve.
this is good
Pull
enough.
it anterior. Pull it
Maybe the
anterior.
frontal you'll have to work on this side.
I hope I have made the thing clear.
But both frontals I want.
Once again, repeat, ma'am. Please, once again.
Okay, this is handle of
Straight
malleus,
forceps.
Yes, ma'am.
lateral
Yeah.
process of malleus.
This side
head of
also we need to
malleus,
wash, madam. Just can
infusomalleolar joint,
Yes, ma'am.
incus there. Till incus is there, we are not bothered about facial nerve. It goes medial to that. Okay.
Okay, ma'am.
So there could have been a long process of incus there
You're
in
also
place
doing
of
15
sickle,
days here, 15
and
days
the
there.
stapes would have come there.
Yes, ma'am.
Deep inside that is foot plate, suprastructure is missing, long process is missing, very bad eroded incus is there. Can you see?
Yes, ma'am.
So I am keeping this intact. I'll remove this bone more and then remove the incus so that the facial nerve remains medially and we are safe. While
Okay, ma'am.
doing the drilling, I'll show you. Okay.
Okay, ma'am.
So
That is
inside
also
out is a
3
very,
mm Baroli, ma'am. The 3 mm Baroli, ma'am, you are using?
3 mm. Yes, yes, yes.
Okay, ma'am.
This sphenoid
I'm
was
going
smaller.
superiorly to I have exposed the anterior margin nicely. Now I'm exposing the superior margin of the cholesteatoma sac, and I'll go posteriorly to expose the posterior margin.
That was a
Now
frontal.
posterior margin will guide me how far I have to go. Okay.
Okay, ma'am.
Now I can remove the. Look, I am coming, going either in a circular
Hello.
manner or coming out like this. Okay.
Yes, ma'am. Yes, ma'am.
Coming out.
You
So
come
I
this side,
cannot
you
be
can
doing
finish
any
it.
trauma when I am coming out.
Left.
This is what we call inside out mastoidectomy.
Connect irka.
Okay, now I'll remove the incus and show you the cholesteatoma sac beneath sickle. So this is the residual incus. Can you
70
see?
degree scope.
Yes, yes.
Yes,
very,
ma'am.
very much.
Now I'll show you
eroded.
the beautiful cholesteatoma sac.
Shall I
Just see,
take
this
out
is
the
the sac.
shelf
Can
or
you see
we
this is the
take
lateral wall of the
shelf?
sac?
Yes, ma'am.
This is the whole sac.
Yeah.
Yes, ma'am.
45 degree.
Okay.
I use a 45
Where
So
is the
again-
horizontal facial? Can you just locate?
Will be
me?
here, this area.
Horizontal facial.
Yes, that will be in this area. I'm not
red.
exposing it yet because I'm not disturbing the continuity of cholesteatoma sac. Okay? I'll
Okay,
just
ma'am.
remove the lateral wall. Can you see? When I
Yes,
open
ma'am.
it, the cholesteatoma sac, I'll just remove the lateral wall. Medial wall is not going to be touched till I expose it in all directions. I'll show you that becomes very beautiful. So now I'm removing the lateral wall. Now this white muck is keratin. Okay?
Yes, ma'am.
Cholesteatoma sac has got two layers, matrix and submatrix. So matrix is the epithelial layer which secretes its acellular debris. This is called keratin. Okay?
Take it out.
This
Yes, ma'am.
white glistening material is
Yeah.
keratin. Okay?
Yes, ma'am.
I can remove this
Leave it.
keratin.
No
And the subepithelial or submatrix layer has got mesenchymal cells.
Audio 5 minutes.
Those
sir.
cells secrete inflammatory cells as well as the proteolytic enzymes which
Just 5
erode
minutes. I
the
want
bone.
the audio.
So
Madhuri ma'am.
cholesteatoma. Okay.
Madhuri ma'am.
Yes.
Ma'am, with your permission, can we take few minutes because Deepak
Why-
sir
why-
wants to share
yes,
the
yes.
remaining part on his side?
Till then, I will keep
5
exposing the cholesteatoma sac and then come back to you.
Will that be
Okay.
fine with you, ma'am?
Perfectly fine. Perfectly fine.
Thank you so much, ma'am. Thank you.
Perfectly fine. Okay. Drill de do.
Deepak sir,
Hello. Yeah.
sir, over to you, sir.
Can you hear me?
Yes, sir. Yes, sir.
Yeah.
And-
Now Shilpi madam is with the camera now. She will show what all I have finished so far. Just
Sure,
give us
sir.
2 minutes. I don't want to interrupt Madhuri madam for a long time. Can you see the opposite side? Are you getting the endo picture?
Yes, sir. Endo picture we can see.
You can see the opposite sphenoid. Can you see the opposite sphenoid?
Yes, sir.
You can see the maxillary.
Yes, sir. We can see.
Yeah. And then with 70 degree, I think she will show you the skull base now. 70 degree. Just another 2 minutes.
Sure, sir.
Yeah. That is the frontal there on the left side. Hello?
Yes, sir. We can see it.
Yeah, yeah. I'm really sorry because the first time I came through so much of oozing, probably because of the neoosteogenesis and the bleed. Of course, Shilpi madam will do another 10-15% of the job, which I am not complete according to me. The other side also will show, madam. That's all.
Sure. Sir.
Yeah. And now the other side where I did the first side, you can see the maxillary, and then you can see the sphenoid which is covered with blood. She is putting the suction there. You can see the sphenoid there, and the skull base and the frontal. Frontal is very anterior there where the suction is going. Yeah, that's the frontal. I feel the other one is a supraorbital cell. And the anterior, yeah, that is a supraorbital, I feel. And that could be the anterior-ethmoid location or whatever, where the shelf is to be removed. Thank you very much. Once Shilpi madam is finished, we'll again show you. We'll get back to you. I don't want to disturb Madhuri madam more. Thank you.
Thank you so much, sir. Team, we can shift to
Madhuri ma'am.
camera. Thank you so much, sir.
Yeah.
And thank you, team from Haldipur sir's operation theatre.
Madhuri ma'am. Ma'am, could you hear us?
First, I stop, tell you, and then go further. Okay.
Yes, ma'am. Yes, ma'am.
Now
Ma'am, could
I'll
you please tell from where to where you had drilled during this time of 2
Yes.
minutes or 3 minutes?
I'll wash to acha sa. I'll clean the area and then tell. Okay.
Yes, ma'am. Yes, ma'am.
So that it becomes clear to you. इसको clean करेंगे section को आगे से पकड़ के. बस ऐसा ही है. So now see. Sickle. Okay. So now from inferior, I will show you. Can you see the tympanic membrane intact?
Yes,
There?
ma'am. Yes, ma'am.
This is the lower part, 6 o'clock, 12 o'clock, 9 and 3. Okay.
Yes, ma'am. Yes, ma'am.
So now this was the start of the cholesteatoma sac. I have exposed it nicely. Can you see?
Yes, ma'am.
I can see all the edges of cholesteatoma. Still, I will not disturb it. Okay.
Okay, ma'am.
Till I have exposed every bit of cholesteatoma. Now, what I did was, I made a drilling here to expose, then I went posteriorly. Now, can you see I am almost reaching the superior edge of the cholesteatoma?
Yes, ma'am.
Can you see there? This is the head of malleus. Incus
Yes,
has
ma'am.
been removed, and this is deep cholesteatoma going deep inside.
Yes, ma'am.
Can you see?
Yes, ma'am.
Superiorly, it is circular knife denge. I will touch it and show you how far the tegment from this place is. Almost reached it. Okay.
Okay. Okay, ma'am. Okay.
Now the circular knife will guide me posteriorly. Now, as you were asking whether to go canal wall up or canal wall down,
Yes,
I'll
ma'am.
see how far. Now put the circular knife there. This much drilling still to be needed. Okay. And
Okay.
again, let me tell you, don't get terrified. I am removing the lateral wall, not going medially. So facial nerve does not come into question.
Okay, ma'am. Ma'am,
And I'm
could you-
following the disease. This is the area you are terrified. Okay.
Yes, ma'am. Yes, ma'am.
Okay. Give me sickle. So let me show you. Okay. Can you see? If
Yes,
I
ma'am.
can focus, this should be visible very nicely unless until I, can you see the round, this oval window there?
Yes, ma'am.
Yes, ma'am. Better now.
Yes,
This
ma'am.
is the facial nerve, horizontal part. Can you see?
Okay. Yes, ma'am. Yeah.
This is, and this cholesteatoma is filling whole of the attic. Now I am
Yes, ma'am.
taking away the keratin. I am not disturbing the continuity of the sac. I am just taking away the keratin to make you visualize where the facial nerve is. Just see. Give me scissors. Can you see the facial nerve nicely there?
Yes, ma'am. Is that the LSC, ma'am? LSC.
Okay. What is this? Lateral semicircular
Lateral
canal.
semicircular canal. Yes,
It
ma'am.
is yet to appear. That will be there. Okay.
Okay, ma'am.
There. I am removing the lateral wall. Try to see I am not disturbing any continuity on the medial wall. So be reassured. I am not doing any. You are not going to do damage there. I am just removing the lateral wall. Okay.
Okay, ma'am. Okay, ma'am.
Here is the area where you were worried that the second genu will come.
Yes, ma'am.
This is the area. So when I am removing the lateral wall, I am keeping lateral to the facial nerve. Okay.
Okay, ma'am.
And there I will use the diamond burr, not the cutting burr. Okay.
Okay,
What
ma'am.
is the burr there? Now cutting. Okay. First, what I am doing is, because I cannot be working in small tunnels, I am widening it outside also. Okay.
Okay, ma'am. Okay, ma'am.
We shall not be working in narrow area, so that the visibility should be there. Just see. And that can be done with the cutting burr. No risk there. Okay.
Okay, ma'am.
And you know, burr's usage is very interesting. I can make my cutting burr into diamond burr just using a feather touch manner. Okay.
Okay, ma'am. Okay, ma'am.
So I don't keep changing the burrs usually, because I know how much force is needed to give a feather touch drilling and what is to deep drilling. Okay.
Okay, ma'am.
So now I am coming posteriorly. Okay. So I
Okay,
rotate it there. I hope this is the area of your, this is the area of second genu. Okay.
Yes, ma'am.
Drill. Fast, 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 fast. Now because I am away from important structures, I can do a bit fast drilling.
Okay.
Can you see how beautiful? This is the hump of the lateral semicircular canal. I hope I can show you. Can
Yes,
you see
ma'am.
this?
Yes, ma'am. Yes, ma'am. Visible.
This is facial nerve. So the three structures lie in lap of each other. Facial nerve lies in the horizontal part of facial lies in the lap of the lateral semicircular canal hump, and oval window or foot plate lies in the lap of the facial nerve. Okay.
Yes, yes, ma'am.
The lateral and superior most is the ampulla of lateral semicircular canal. In its lap comes the facial nerve, tympanic segment, posterior part, and second genu. And in the lap of facial nerve lies the foot plate, one below the other. Okay. So
Okay,
you
ma'am.
keep this in mind. Now just see, I am removing the lateral wall. Can you see?
Yes, ma'am.
So nothing to worry.
Okay.
I am keeping lateral to this. Okay. I am just following the disease.
Yes, ma'am.
Ma'am, for students and beginners, what tips you will like to give here?
Yes, the ossicles are basically saviors because they protect us from exposing or injuring the facial nerve. And when you are close to important structures, move over to diamond burr. Even when there is a dehiscent facial nerve, if you have a diamond burr, chances of injuring the facial nerve becomes very, very less, very less. Okay. So always use a diamond burr when you are close. So now see how in a speed I can use the cutting burr because I am away from important structures. I am following the disease anyway. So keep following the disease. Inside out is good because it is moving away from the important structures. So it makes it the life very easy. Is it visible?
Yes, ma'am.
Okay, I am following the disease wherever it takes. Though the CT was showing the disease is up to antrum, but I feel somehow it is going up to the mastoid cavity. Let me see. Drill, same drill. Just see what I'm doing. Just following the disease. Just following the disease.
You have crossed the additus area and into the antrum.
Yes, yes, yes. I'm about to enter the antrum. I'll show the posterior most extent of the cholesteatoma to you. Okay.
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 Yes,
Just
ma'am.
following the disease as it is. This is
I am about to reach the posterior most extent.
until you could see the fundus of the sac.
Okay.
Yeah, some granulations there.
It seems this sac is ending here. I'll confirm it. Though wash the na.
That is the fundus area, perhaps?
Yes, yes, yes. You know what? As I'm continuously telling you, don't disturb the continuity of medial wall of the cholesteatoma, but we can take away the lateral wall because we have to see the end of the cholesteatoma also. Those sickle dena. Can you see beautifully we have reached up to the tegment there? Okay.
Yes, ma'am. Very beautifully exposed.
And this is the area where the sac will end. This is the hypertrophic mucosa.
Yes,
I am
ma'am.
removing.
Yes, yes. The granulations around the.
Yes, yes, yes. Give me cotton ball. Now this is the almost the end, but I'll confirm it before finding it. Give me diamond bar. Now because I want to maintain the integrity of the cholesterol.
So by this technique, it is going to be very limited drilling. Very limited.
Yes,
drilling
yes,
of
yes.
them. Yeah.
Only that much drilling which is required. Okay.
Yes, yes. Yeah.
Yes, ma'am.
So now I have taken over the diamond burr, same size. I am going around the sac.
That is the tegment plate.
That is the tegment, yes. And for PG students, whenever you are drilling on the thick bone, it will be a different sound. But once the tegment gets thinned, when you rub the this burr on this will give a feel of tin, like you are moving on a tin or a metal thing. The sound changes. It is like we are moving on a thin metal plate. So the PGs should know when they can feel that the tegment is approaching. Okay?
Yeah, the tactile
ma'am.
feedback and the
Yes.
sound, change of the sound.
A good otologist has to have a tactile feel of everything. He should be knowing when the labyrinth thick bone is appearing, when the fallopian canal thick bone is appearing, what are the nerve vessels. So these are achieved by doing repeated this temporal bone dissections for, just have a feel where you are going.
At the same time, an eye to see the change of colors.
Yes, change of color also. Yes, slightly pinkish color starts appearing.
Yeah.
Okay, now give me sickle.
Yeah.
This is the end of cholesteatoma.
Yes, yes, we can make out. That is the fundus and the granulation tissue around. It is ending up there.
Yes, but still I want to be clear. I don't want to leave the cholesteatoma behind just 2 minutes. And once I have exposed, then I'll remove in toto. Okay?
Yeah.
Okay, ma'am.
Luckily, this has not been an extensive cholesteatoma. Usually,
Yes.
pediatric cholesteatomas are very aggressive, very destructive. They go up to the tip of the mastoid. Lot of destruction.
Yes, yes, absolutely right. Many a times there is a fistula in lateral semicircular canal also.
Yes, yes, right.
So basically, it has been aggressive in the area of ossicles and the facial mesotympanum, and less on the mastoid cavity. So the spread is different, Cholesteatoma can spread in different directions, causing different kind of erosion. Isko pakadna, ab cotton dene.
So for the postgraduates, it's a very good technique, inside out technique. Usually what we do routinely is outside in. We do the cortical mastectomy, then take out the bridge, canal wall down, along the ridge. That is the classical way of doing, classical method. But it's a very good technique, inside out.
Yes. Now can you see? What I'll do is now, sickle is not the right instrument to remove this. First thing I want to show you, I have removed all the bony ledges. Give me circular knife. I'll show you the area of second genu and the bone lateral to it. Can you see? This is the bony ledge still to be removed. If I want to take it out completely. So diamond burr, no bony ledge lateral to the cholesteatoma sac should be left. Can you see there? I will drill it away. Whatever bony ledge I found, because I want to take it in toto, don't want any cell, epithelial cell to be left behind.
Is it area of fossa incudis or I'm
Ma'am,
not well
This is
oriented?
slightly, you know
Where is
what?
the fossa incudis?
Fossa incudis, this is the area of lateral this is the area of fossa incudis. We have come way behind.
Okay, okay. And now I got it.
Ma'am, whether you were drilling near the LSC or
This
lateral
lateral
semicircular canal?
I'll show you. I'll show you. That is the lateral semicircular canal ampulla. That is facial nerve. I am behind that. So this is the area where the facial nerve will take turn, but slightly anterior. Okay.
Okay, ma'am. So near the PSC you are drilling, ma'am? Posterior semicircular canal?
Posterior will be deep. I'll show you. That is quite deep here. Because the facial nerve is anterior medial to the ampulla of lateral semicircular canal, but
Yes,
it
ma'am.
becomes anterior lateral in the vertical part to the posterior semicircular canal.
Yes, yes, ma'am.
Yeah. Now
Yes,
give me needle, curved needle. I'll show you how I lift the cholesteatoma sac. Even while lifting, if I feel it is hiding behind some bony ledge, I will drill it out and then only, this is needle, curved needle and cotton ball. I'll show you how to lift it without leaving behind. Give me another retractor. I'll put it there. So that doesn't come in the way. Okay. No.
Yeah, the heat is so high.
Hold it. No, it is not working. Give me that only.
Ma'am, once please keep in, please orient us, ma'am.
Yes, again I will orient you. Okay, again. Wash.
I think you said we can leave it like this. Yeah. Said we can leave it like
Okay. Give me needle. I will show you hockey. You call it hockey. Okay. This is promontory. Can you see the promontory?
Yes, ma'am.
This is oval window.
Yes.
Plate. This is the area of round window.
Yes, ma'am.
The whole cholesteatoma is, this is called in mesotympanon, we call it a false epithelium. When it goes up and becomes the cholesteatoma sac where it is secreting the keratin also. Okay.
Okay.
So this is the foot plate. This is facial nerve.
Yes.
Okay.
Yes.
This is lateral semicircular canal ampulla. So in the lap of ampulla, facial nerve. In the lap of facial nerve is the foot plate. Okay.
Strips.
Now I
Yes.
have gone behind and exposed the cholesteatoma sac. Okay.
Yes,
Now
ma'am.
give me cotton ball. Small cotton ball. Yes. Now see how I'm going to lift. Okay. Now I push it there.
Cotton ball dissection.
Yes. Scissor. ये बंद हो गया, सक्शन बंद हो गया, सक्शन चेंज करेंगे और ड्रिल देना, ड्रिल दे दो, ड्रिल।
मैडम
यस, ये बंद है, ये मेरे को लगता है इसका कनेक्टर बंद है।
Sorry to disturb you, madam.
Yes.
One announcement I have to make.
Okay, okay, good, good. Go ahead, please.
Thank you. We welcome Dr. D.S. Deen Dayal, sir. We welcome Dr. Deen Dayal, sir, for this workshop. Janaki Ram is on the way to Vasavi Hospital. He'll be operating after this master surgery.
Give me scissor.
Thank you, madam.
Okay.
Yeah, we are with you. We can see you are
Okay.
dissecting out the sac.
Yes, give me needle.
Sorry, madam, because of the
Oh, cotton ball.
yeah.
So, dissecting the cholecystoma in continuity.
Yes, in continuity.
That is very, very
Yes,
important.
very important. Can you see the wall of the sac there? I'll show you.
Yes, we can see.
You can see?
Yes, yes, we
Yes,
can
ma'am.
see
Yes,
very
ma'am.
clearly. Nice.
Give me cotton ball. So
The
I
segment.
lift it.
Yeah.
Can you see?
Yeah, very
Yes, ma'am.
very nicely being dissected out.
So when I come close to the important structures,
Yeah, LSC particularly there.
yes, it should be meticulous one. Chota
Yeah.
cotton ball do.
And 25.
Chota. This is slightly big. Chota, chota. I'll show you the continuity everywhere.
Supposing there may be a dehiscence or the LSC.
Yes. Yes,
what
yes.
precautions you would be taking?
Yes, the precautions are whenever we have seen in the CT scan or
Yeah.
we take it, there can be a dehiscence. Even when the CT is not done, if the CT is not done, we take it, there might be a dehiscence there. Okay. So 2-3 things to be done. Take a steroid soaked gel foam or cotton, put it there for a few minutes. Then with the help of this cotton ball, create a right plane. मुझे gel foam देंगे, steroid soaked gel foam.
Okay.
Ma'am, is the area of SSC?
It's the
SSC?
area for superiors, yes, but it is
Yes.
quite deep. It should be.
Does the cholesteatoma doesn't while we are removing the cholesteatoma, there any precautions for?
Yes, yes. Definitely. This is why I am using a cotton ball or gel foam. A cotton ball be there. We don't put our instrument directly there. And again, if there is something showing on the CT scan, the superior were absolutely normal. I'll take a smaller suction. Important thing to remember, don't put your suction directly on the fistula or suspected fistula. Okay?
Okay, ma'am.
Suction will cause a damage, cotton ball there. So that's why I use gel foam soaked in steroid and the
Lunch is ready. You can have working lunch.
cotton ball.
Can we leave an island of epithelium if there is a fistula, LSC fistula?
No, if it is, I am suspecting a very deep, still, I am able to lift with a smaller suction and a ball probe. Either I take a ball probe or a curved needle with the help of a cotton ball or gel foam. I'll gently separate it, or if we are suspecting that it can cause trauma, I'll leave the fistula covered with epithelial layer. And once everything else has been done, drilling has been done, no bone dust is flying, then in the last I will take it off. But I will definitely take it off in the single stage. Okay? Okay, I'll not leave. We don't leave cholesteatoma. Cholesteatoma is a big enemy.
But you will do that at the end of the procedure. You will come.
Yes, yes. Definitely we can do that.
Yeah.
And you see, once I had exposed, I don't have any problem lifting it. Nowhere we are leaving it behind. Can you see that?
Yes, ma'am. Sorry.
You keep watching. If the this thing is not clear, you please focus it. So, I'm not leaving behind any epithelium.
You had something? Ilya. Next year, how? Achi, she did the left frontal. Left frontal she did.
Dena?
So, if you can get the
Cotton ball, yes. Slightly smaller.
Not now, let us just see the whole thing. Left frontal, she did a fabulous job.
Can you see?
Yes, ma'am.
It is coming out completely. Give me diamond. Can you circular knife? There's a bony ledge there. I don't want to take out from under the ledge. Can you see? So drill dena.
Yes, ma'am.
एक smaller size diamond, or you can do give me this one. No, it's okay. I will expose it and thoda बिल्कुल अभी मत डालो हाँ अभी मत डालो.
You will always find a shelf of bony projection there at that area. You have to
Yes.
be careful about that. From the
You know why? You
segment.
know why? Because the tegment plate
Yeah.
in the lateral part
Yeah.
is more inferiorly placed than in the medial part. Medially, it is more located superiorly. So slight space is always there medially because the tegment is slightly highly placed in the medial part.
Yeah.
Okay?
Right.
And
Exactly.
you always take a diamond burr there.
Yeah.
Again, diamond burr is a very good friend of ours.
Because there is one area where the cholecystoma can creep in deep.
Yes, yes.
So that should always be explored well.
Always, yes. Smaller section. Yes, Dr. Janki. Okay, thank you, Janki. Oh, thank you, yeah. Thank you very much.
Are you enjoying it?
Yes, of course. It's okay. We have made our neck flexible like, you know, this is, yes, I asked them ki,
Not ready now. Table is not ready now.
देना फिर से वो दो needle. So I think I'll do, first I remove and then I can get the. So now see.
Yeah.
Can you see it has been removed?
Yeah.
Yes, ma'am.
Dissected out very nicely from that crevice.
So now I'm coming here. Can you see the lateral semicircular canal?
Yes,
Yeah,
ma'am.
Yes. The bulge.
Lifting it.
Madam,
So
Yes.
that is exactly.
madam, I have a question. That
Yes.
just in case there is a iatrogenic injury to the lateral semicircular canal
Okay.
during the drilling, what would be the way you will deal with it?
It should be immediately covered with the, I mean, if there is an injury, wash it with saline, clean the area, put some gel foam or covering, or you can put some bone wax there. Bone dust and bone wax, continue with the rest of the work. The whole bone dust should not be flowing into the fistula. We should not be putting our suction on the fistula. Do rest of the work and come back when we are doing the repair of the cavity. Okay? Then we will take this cover away. And if it is a very deep fistula gone up to the endolymph, then we'll have to replace it with a muscle tissue, piece of muscle, bone dust, and over that bone wax. And if it is only bony deep, we'll just resurface it with the bone dust and the bone wax. Usually, if you are using a diamond burr there, never use a cutting burr there. If you are using a diamond burr, usually it is only the bony part which will go and may not cause harm to the inner ear. Okay?
Right, madam. Madam, I think the two important points is not to leave it unattended because all the bone dust will go inside.
Yes.
And second, as you said, that not to use the suction there.
Yes, absolutely. Now you see, my suction tip is not going deep on the surface. I am keeping it, pushing it and keeping it on the sac only. Can you see there? I am not using my suction there, though there is no fistula. Avoid using suction directly on the facial nerve, directly on the area where we are suspecting some fistula. Okay? So I am lifting it gently. You see, it is all intact. I have not left even a single bit of epithelium. So that's why I tell you, I don't need an endoscope. Maybe I am right for myself that just see, I am able to separate. You see?
Yes, ma'am.
And because anteriorly, just see anteriorly, I have exposed, so it will become very easy. I will show you. You know what I do? I debulk the cholesteatoma in 3 parts. One part is when I have reached the from the cavity or antrum towards the horizontal part of facial nerve. You see this? Horizontal
ma'am.
part of
Yes,
facial
ma'am.
nerve.
Yes,
So
ma'am.
I will debulk first part of the cholesteatoma here. Okay? Scissor though. So that makes life easy for me because this whole bulk will not let me see the right. Scissor. I'll cut it here. Okay?
Okay,
Okay,
ma'am.
you see?
Okay, ma'am.
So first debulking is at this level. Give me needle. Slight lifting in this area and then I'll debulk it. I don't want any change because something new might happen and then we will. So see how deep the cholesteatoma has gone there.
Yes, yes, medial
ma'am.
extent. Is it crossing the cog or is it confined to the level of the cog?
Cog is usually a bony septum which arises from the superior wall and reaches up to the processus cochleaformis. Okay.
Yes.
It divides the epitympanum into anterior and posterior epitympanum.
Ah.
So this seems the cog is already gone. There is no cog here. I cannot see any bony projection there.
Eroded means it is already extended into the anterior attic.
Yes, yes, of course. We have seen it from below.
Yeah.
Can you see there how deep it is going?
Very
And
deep.
Yes, ma'am.
had we not taken care of this cholesteatoma, it would definitely have eroded the superior semicircular canal. Can you see there?
Yes.
Yeah.
Very deep. So more of medial spread.
More of medial spread, yes.
Very deep has gotten.
So you will see that there is no lateral bony ledge.
Looks like
So I'm
perhaps
not
the
worried. I am not worried that I am scooping it out. I am seeing it and removing it.
perhaps the posterior aspect of the superior aspect of the horizontal facial may be exposed with this kind of
Yes,
erosion.
many a times.
The
But in
superior
30, almost I have seen the cases, almost 25% cases, there is already a congenital dehiscence. And mostly it is in the tympanic part or it is in the geniculate part. Okay. Now this is the area where I'll do scissor. I'll do first debulking of the cholesteatoma. Okay.
Yes, yes.
Okay, ma'am.
This is the first debulking. I'll take it out.
The part of the epitympanum you are taking out.
But anteriorly I am leaving. Can you see?
Yeah.
Yes, yes.
Now
Anteriorly
this
is
is the
leaving.
first debulking. Okay. Wash.
Yes, yes.
Now the second debulking would be from the anterior attic. Wash then. Wash. So this is how I have divided for my convenience. Because again, I don't want my sac which I have lifted to obstruct the view for anywhere else. Okay.
Okay, ma'am.
Can you see there is no sign of any cholesteatoma deep down there? Now
Yes.
coming to anterior attic. Now this head of malleus is obstructing the view. Can you see?
Yes,
I
ma'am.
want to see the cholesteatoma sac in continuity. So head nibbler, malleus head nibbler is there. So there is an instrument which is called head cutter or head nibbler. Yes, can you see this?
Yes, yes. Malleus
Yes, ma'am.
snipper.
Malleus snipper. Yeah.
Malleus nibbler.
You can still find that cauda there, cauda tympani there.
Still it is hanging out there. I don't know
Yes,
how
yes,
far
yes.
can I.
Let it be. It's a good
Yes.
landmark for us.
Okay.
Nipping
Head
at
is
the neck.
gone. Forceps. Head is gone now. Oh
Yes.
shit. You know what? Okay. Now see why I left the attic area behind, because this bone also needs to go out. Circular knife.
Yes.
So this is how accurate the cholesteatoma surgery should be. Give me. This bone also need to go. I want to see the cholesteatoma diamond bar. So that is how the cholesteatoma surgery can be perfected. I won't scoop out the cholesteatoma. I will remove under vision. And that's why I don't need any endoscope there.
The suprachiobal recess.
Yes, anterior buttress area. Now see, okay? Give me needle. Can you see the whole of cholesteatoma sac there?
Yes.
It will very easily come out. Now from here it is going into anterior attic area. Can you see? Table thoda uncha kar hi do. Is it focused?
Yes, ma'am.
Yes, ma'am.
Now I am removing this cholesteatoma sac. Had I not removed the head of malleus? Yes.
Yes, ma'am.
मेरे से? हाँ, मेरे to the audience ना? हाँ, why not? Anytime you just have to tell me. Now, okay, I stop. I stop.
Hello, audience.
Yes, sir.
We are changing over to Dr. Deepak ji. He has finished the case. You can see the final cavity. Hello.
Sure, sir. Sure.
Okay,
I
change camera to Deepak ji. Deepak ji, you are now online. 1 second. You have the
Hello.
mic.
Mic is on. Mic is on.
Can you hear Dr. Deepak ji, please?
Hello.
Deepak sir, over to you.
Yeah.
Can you hear? Can you hear him?
Yes, sir. We can hear him.
Okay.
Yeah, because of this extensive neoosteogenesis, the oozing was simply there through the surgery. So I must really acknowledge the help of Dr. Shilpi Bhatia Sharma. The left frontal, which I was struggling, she helped me with it and she fine finished the work actually. Finally, we requested Janki to inspect once and tell us whether we had done a good job. I'll just show the picture now on 70 degrees. 70 degree, please. Oh, this 70, is it? Okay. Sorry. Yeah, curved section, please. Yeah. Can you see the frontal? Hello?
Yes, sir.
Can you see the frontal there? 1 minute. I'll put it there now. Can you see the frontal?
Yes, sir.
Yeah. And also the supraorbital cell and the anterethmoid artery there.
Yes, sir.
1 minute, I'll show you the anterethmoid. Can you see that? 45 degrees angle, posterior to anterior. Can you see this?
Yeah.
Yes, sir.
Frontal proper, this is the supraorbital cell, posterior part of the supraorbital cell, the anterethmoid artery, the middle fovea, and the sphenoid sinus.
Yeah.
Can you see the sphenoid here?
show the sphenoid little more closer, sir?
Yeah. 1 minute. Can you see this? This is the sphenoid. I think I'll show you with the 0 degree next. 0. I can only take 70% of the credit. Remaining should clearly go to Dr. Shilpi. Yeah, can you see the sphenoid here?
Yeah, you're able to see, sir.
Can you see the sphenoid?
Yes, sir.
Yes, sir.
Here. You can see this?
Yes.
You can see the maxillary
Yes.
and you can see the frontal in the same view, 0 degree. And on the other side, similarly, straight Blakeslee, ma'am. Yeah. Believe me, Dr. Shilpi is superb, fast, precise, and because of the numbers, she does an amazing job. Left frontal, I really didn't do anything at all. It was all Dr. Shilpi. Even there is a hard ledge here. You can see the skull base. Yeah, give me the 70° for the last time. Can you see the oozing even at the end of the procedure? How much blood? This is a case of neo-osteogenesis. These are difficult cases where everybody comes across. This is the sphenoid which was small on the other side. You can appreciate this. This is a sphenoidal mucosa. 70°. And this is the first ever time I have washed up along with Dr. Shilpi Bhatia Sharma, and I could see her work. Amazing. Yeah. See, this is the frontal. Can you appreciate?
Yes, sir. You can see.
You can see the frontal there.
Yeah.
Supraorbital. Anterethmoid artery. Can you see here? I think we'll take out that piece of bone anyway. This is the anterethmoid artery. Can you see here? This artery, this vessel.
Okay.
And this is the middle fovea. This is a small sphenoid. This is the maxillary. Thank you. I don't want to eat into Dr. Madhuri's time and then Janki's time.
Sir,
Doctor-
can you just
Dr. Deepak ji, wonderful cavity. I'm really thankful to you, and let us all give him a big round of applause.
sir, can
please.
you add a note on
Sir, there is one request from the panel, please.
can you just tell us about the post-op, how you'll manage, sir, this patient?
Yeah, that I will tell anyway. But first I have to give credit to Dr. Shilpi, and final word, like the Judge Janki came and he applied the finishing touches.
Yes, sir.
I think basically
Sir,
the sinuses.
Really big round of applause first. I want to hear the applause for Deepak ji.
Yes.
And see, post-op care in this case, I would like to use steroids for fair amount of time, and most important, budesonide irrigations, because neo-osteogenesis. When I reading the CT scan, I told you, I was apprehensive both about the frontal and sphenoid today morning, and invariably it was so. But what I'm trying to say, as Janki put it, when we have a picture-perfect, flawless, bloodless demonstration, it looks nice. But for many of you, when you go back home, when you find bleeding, sometimes despite everything, see, anesthetist was spot on today. They kept the heart rate at 60, BP was 90/60, head and elevated, Mirocell we used adrenaline, we used ribbon gauze. It kept on oozing, it continues to ooze even now, if you can see. Even now it is oozing. But the whole, take-home point of this demonstration is, when you have a difficult case due to neo-osteogenesis, the only thing that can save you is patience, and more patience. Pack,
Yes,
press,
sir.
and pray.
We
and
agree
go
with you,
slow.
sir.
Yeah. Okay.
Do you like to use any oral steroids and itraconazole in this patient?
Yeah, why not? Definitely steroids. Oral steroids at least for 2 weeks.
Okay, sir.
Itraconazole, not that much glue was there, to be honest, except both the maxillary sinuses showed a glue. Even that was not mucin. When I look back, it looks like thick old mucus. I would wait with itraconazole in this case, because even CT scan doesn't show AFR.
I agree. I may not start itraconazole as Deepak ji says. I would definitely start on steroids, but not itraconazole for this case. Yeah, perfect.
But remember, you will get these cases in your practice, and somebody has to bell the cat.
Yes, fully agree.
Yes.
And this is the kind of cases when you go back home, you might think, the demonstration was bloodless, but now this is the kind of case we're going to face day in, day out with neo-osteogenesis.
Yes.
Will bleed. Whether your pulse rate is 60 or 90, 60 BP. See, the BP is also low, the pulse rate also low, but still it's bleeding. It's purely because of the repeated infection.
Yes.
But on the whole, final result, if you see, all the sinuses have been opened. You can't do anything more in this particular case. That is what you want to achieve. And that's what Dr. Deepak ji has done.
Achieved by 70% and remaining by
no. By patience.
Yeah.
Thank you very much, Deepak ji. Thanks for coming to Bangalore. It's from Bangalore to Hyderabad. It's a
I will
honor.
keep coming.
I always call him K. Balachandar of ENT. Are you seeing us? I really love him because he involves me as well as the great Satish Jain for every workshop of his. I'm so happy and I love him. I love him. So
Thank
let
you,
us
thank
see
you, thank you.
custodial.
And
Really love him.
and till Janki stops calling me, I'll keep coming.
No, it will never happen. Thank you very much, sir. And another important thing, I welcome my teacher, Professor Deenadayal, sir.
Yeah.
I worked under him for, I think, 10 days. After I saw him in Singapore, I told you yesterday, I saw him in Singapore. I came, worked under him. Thank you very much for coming and honoring us, sir. Now the workshop is complete. All the biggies.
Fab Four.
He told in the morning, the Fab Four, he told you.
Yeah.
And they have all come to this workshop.
I made it the big five.
Yeah.
Janki is just being nice. There's nothing like that. And Deepak, wonderful job done. Enjoyed every bit.
Deen Dayal will always support me because his wife and me, we come from the same place in North Canada. Yes. His wife speaks Konkani. Yeah.
Oh, really?
Yeah.
Oh, wow. Super, sir. Super. Thank you very much, Deenayal, sir. I'm really privileged and honored by your presence, sir. Thank you. No words.
And I'm looking forward for your surgery.
You don't look forward. I'm scared.
I'm coming there to the hall to moderate as well along with you. And when Deen Dayal praises me, it is more than genuine praise, it is marital diplomacy.
Sir, you say it is both, not more. Both. It's both. So thank you very much, sir. We'll shift over to Dr. Madhuri Madam in the other theater. Then we'll come back for our case. Thank you.
Thank you, sir. So, along with the clinical learnings we have learned, always we should be prepared for unexpected things, and always teamwork wins. So with this, my request to team to shift to Madhuri Madam's OT, please. Madhuri ma'am, over to you, please.
Madhuri ma'am, you are live now.
Ma'am, over to you. Ma'am, can you hear us?
Can you hear me now?
Yes, ma'am.
Because
Over to you, please.
Microphone was switched off. That's why you could not hear me. So what I've done is, this is the floor cartilage as I told you. Can you see?
Yes, ma'am.
I'm cutting this floor cartilage because now I am going to, after removal of the cholesterol, I thought I'll utilize this time for harvesting cartilages so that I save on time. Okay. So this is the cartilage I am harvesting for a use. Now I'll show you again. Going back to the cholesteatoma sac. Can you see there? Then a sickle or suction.
Yeah, we can see the remnant there.
Coming back
Needle.
to that leftover cholesteatoma and the epitympanum.
Yes. Needle and cotton ball. So this is the second part of debulking.
Yes.
Okay. दो इसको लो sister इसके ऊपर से.
Ma'am, can you please explain what we missed for last 2-3 minutes?
No, I didn't do anything. I just harvested tragal cartilage so that I wanted to show you. I didn't do anything else here.
Okay, ma'am. Thank you. Yeah.
So this is the part on the anterior attic, absolutely clean. Now, mostly it goes around the processes cochleaformis. Can you see there?
Yeah, ma'am.
Yeah, the process cochlear
I'll just
form
focus it. Okay, I'll focus it.
the cochlear form.
Okay. Now this cholesteatoma, can you see there?
Yes. We can
Every
see that.
bit of it is to be out. Now I will separate it together. Whenever there is a cholesteatoma on the facial nerve, either you come from the attic side or you come from the processus cochleaformis side. You see, I am coming from this side. Can you see?
Yes, ma'am.
I'm gently lifting it. And this is the facial now. Is it visible?
Yeah, visible, visible.
It's beautiful, ma'am.
That is the facial nerve.
That is
Tympanic
the-
segment. Tympanic
Yes.
segment.
Oh. I'll have to cut the scissor then.
Actually, the fallopian canal is not dehiscent in CT scan, no, ma'am.
It's slightly at one place it seemed. We will look for that. I want, if there is a I am cutting the cauda. Please don't mind it because we'll not be able to perform the surgery nicely.
Okay, ma'am.
So better to cut it. Now see. Because I don't want cholesteatoma be just see, can you see the continuity of the sac there?
Yeah, we can see that. Appreciate the continuity of the sac.
Now this is
But
facial.
well plastered to the medial wall.
No, actually, the facial no.
I am separating the sac from the facial nerve. Can you see the processes there?
Yes, yes, ma'am.
Yes.
I have separated the cholesteatoma sac from there also. Okay.
You're working close to foot plate now, ma'am.
No, foot plate is there.
Yeah.
I am on handle of malleus, separating it from. Can you see the handle of malleus being separated?
Yes, ma'am.
Okay. Now, this facial nerve is exposed.
Ma'am, routinely facial nerve will be superior to processors.
Yes, just see, this is the facial nerve. This is processes.
Yes.
This
Yes,
facial
ma'am.
nerve is going superiorly.
Yes, ma'am.
It is always in an angled way.
But it is not dehiscent, no, ma'am. There also. It is not.
This is facial nerve, and there will be tensor tympani tendon, which will be horizontal.
Yes, ma'am.
Tensor tympani tendon is always horizontal. Facial nerve takes a slightly superior turn, 2
Yes, ma'am.
millimeters superior to the processes. This is processes. Okay.
Yes, ma'am. Yes, ma'am.
This is facial nerve becoming first genu there,
Yes, ma'am.
and then it will take a dip medially as a posterior medially as a labyrinthine portion. Okay.
Yes, yes, ma'am.
So now this is the facial nerve I am lifting. Now I want to show you here. Somebody was worried what happens to the second genu. You must start following your facial nerve in a way that you must know where is the, your instincts have to tell more than the landmarks. Is it clear?
Yes, ma'am.
I am lifting it from there. From the foot plate area. Can you see?
And
Yes,
that is the
ma'am.
foot plate area.
Yeah, we can see now.
Oval window. Foot plate. There is no superstructure and it's totally plastered to the foot plate.
Yeah, yes, ma'am.
Okay.
Yes.
Now again drill. This is the bony ledge which is stopping me from removing this area, diamond burr. No bony ledge lateral to the cholesteatoma. We don't scoop out the cholesteatoma.
With
We
the pyramid,
remove it under vision.
that is the pyramid area.
That is the area from where the cauda was coming. That's why I could not drill it. Can you see facial nerve is there?
Yes, ma'am.
So this is the ampulla of semicircular canal. Now this is going to take a back turn there as second genu
Second
and
genu.
come there. So
Yes,
you were
ma'am.
expecting it there. Can you see? Somebody was worried that
Yes,
facial nerve will come there. Can you see this much bone needs to be removed? I'll
Okay.
show you. All fears will be gone once you see it. Can you see how much bone can still be drilled? You keep watching the horizontal part of facial nerve and keep drilling. Here, facial nerve cannot come here. That is far more posterior.
Okay,
So now
ma'am.
I have exposed this area. Okay.
Okay, ma'am.
This is the area people don't clear.
The sinus
Hold it.
tympani.
Yes, sinus tympani.
Do you
Give
use
me a
any
needle. Give me a needle.
endoscope, ma'am, at this station?
No, I don't. I will expose it, see it nicely, and then only remove. Okay? Just
Okay,
see.
ma'am.
I'll do it under vision now.
The key here is dissecting in continuity. That is very, very
Yes.
important.
We don't
That is
break.
the pyramid.
Madam, I have a question.
Yes.
Suppose the facial recess, the stapes is there. and the facial recess has a lot of granulation inside it. And how do you deal with such a situation?
If it is canal wall up, I will keep thinning this area. And if it is canal wall down, I will thin and lower the facial ridge. I have to clear this area and clear everything. Sinus tympani should be absolutely clean. Okay? I'll show you. I'll show you processes, I'll show you the pyramidal eminence and how deep can be the facial nerve there. Okay? Okay, now see. Can you see the pyramidal eminence there? No, sickle or ball pro. I'll show you. Sickle or needle. Okay. Can you see this is the pyramidal eminence? Can you see?
Yes, madam.
Ma'am, a little fine focus is possible?
Okay, I'll try.
Yes, ma'am.
मेरी आंखों का कचूमर निकल रहा है. Can you see this?
Yes,
Fine
ma'am,
focus
better.
कर दो. Can you see this processes? Sorry, pyramidal eminence.
Yes, pyramid.
Facial nerve is just behind it. Can you see there?
Yes, ma'am.
This is the area of second genu.
Yes, ma'am.
And when I was drilling here, can you see how deep it was?
Yes, ma'am.
I was drilling here. This is the second genu just behind the processes. And I am separating. This is the stapedial tendon along with the cholesteatoma sac. Okay, now it is out. Now the important thing is to remove the false epithelium or the sac from the mesotympanum. Now what we have to do, can you see there? It is all stuck to the, as I was telling you, gently with the ball probe. There. I lift all. Can you see this sac?
Yes, ma'am.
I
the
lift it
promontory.
gently. Yes.
But you will always find a pocket around that round window.
Yes. Some plane would always be there to
Yes,
make me find. Can you see? There is a plane there.
Yes,
Yeah,
ma'am.
you will always get a plane there.
Cotton ball.
You will rarely find the cholesteatoma sac going into the round window.
Yes, there may be a retraction pocket there. I will just put a cotton ball and lift it gently. Can you see there is a plane there?
Yes, ma'am.
Yes, ma'am.
I am creating the right plane. Now this is the mucosa which is coming with the epithelium. Mucosa of the promontory.
Okay, ma'am.
And here it is stuck to the mucosa of the promontory. I hope it is visible.
Yes.
I am lifting the
Trying to
sac. Can you
separate the
see?
epithelium. Yeah.
Yes, ma'am.
From the
So
mucosa.
wherever the mucosa may accompany the epithelium, we should not be leaving behind the epithelium, even if we have to sacrifice the mucosa of promontory. Can you see it is stuck there?
Yes, ma'am.
It is stuck there. So
Yeah.
I'll be lifting their mucosa with the epithelium rather than leaving the epithelium behind. Can you see?
Yes, ma'am.
Yeah. You have to do a very fine dissection to get into that plane.
Yes.
Plane of epithelium adherent to the underlying mucosa.
Yes. Just see. I am just lifting the. Can you see the sac?
Yes.
Yes, ma'am. Yes. Very beautifully.
That is the
doing.
mucosa.
The vessel is already there. I have not disturbed it. I am just peeling it off.
Which vessel, ma'am? Ma'am,
Okay.
which vessel, ma'am?
This tympanic artery. This runs on the promontory. Na?
Okay.
So now this is the area I have lifted. Now I will use this flap for reinforcing the temporalis fascia graft. Okay.
Okay,
Now
ma'am.
anteriorly it is still left. Can you see there?
Yes,
So
ma'am.
now I'll go anterior. Again create a plane. Now the cauda is gone. I can cut it here. Give me scissors. So CODA usually in such cases, basically how far I may save it. In limited disease, when it is medial extension, CODA most of the times is sacrificed. Okay, now you see, I am separating, creating the plane. Do you think anywhere I needed an endoscope?
No.
Now this is the false epithelium. And can you see the mucosal band there?
Yes, yes, ma'am.
Canal for tensor tympani.
I'm just separating it nicely.
And that is the tensor tympani. The bulge.
Yes, yes, yes. That is tensor tympani. This is eustachian tube.
Eustachian
Yes,
tube.
yes.
I told you in the start of the surgery, this retraction pocket is sitting on the eustachian tube. Can you see there?
Yes, ma'am.
Eustachian tube.
Ma'am, any precautions there for carotid artery?
Carotid is medial to the eustachian tube.
Yes.
Okay, one thing is CT will be guiding us, but otherwise the promontory is intact and eustachian tube is intact. It should be medial here,
Yes, ma'am.
but you're very medial.
Inferior
Unless
medial.
until it is exposed. If it is exposed, we'll be very, very careful in lifting. Use non-blunt, I will use blunt instruments and use a lot of cotton ball to create the plane. Okay. Now, this is a false epithelium. Give me scissors. I will not use this. I will cut it off and keep rest of the this flap for repairing the. Now, this is the third debulking. Okay.
Okay.
First was at the level of tympanic segment of facial nerve. Second was from anterior attic, and this is the third area where I have debulking. Okay. Now give me a circular knife. What I'll do is I will lift the fibrous layer there so that when I keep this temporalis fascia, I should have a space to support that. Okay.
Okay, ma'am.
Air pocket around the eustachian tube.
Just a pocket. Okay. Can you see? That way I will have a space in middle ear. Otherwise, if I don't do, space will not be. Can you see?
Yeah, lifting up
I
laterally.
prepared a beautiful flap to cover my tympanic neotympanum. Okay. So now I've lifted it. Okay.
Okay.
Now disease is completely out. You agree with me?
Yes.
So now comes the reconstruction. I think this handle is also not very good.
Yes,
I will rather remove it. It is because we don't have any incus for ossiculoplasty. Will not be able to use it. Okay.
Okay, ma'am.
So now give me scissors. It is of no use. So I cut it. Now talking about the posterior canal wall reconstruction and the ossiculoplasty wash and the tympanic membrane repair. Now 3 repairs need to be done. Okay. Scissor dena. Disease is completely out. Scissor. Now I have taken the tragal cartilage because it was getting a bit late. My flight is at around 4:30. So I'm trying to finish it fast. Give me the tragal cartilage. I have harvested and prepared 2 grooves there. Can you see this one groove? No. Focus it. In the no cartilage इधर रख दो. आप focus करें grooves के ऊपर. और sickle. Deep. Hello?
Yes, ma'am.
This is the posterior groove and this is the anterior groove I have created for the placement of cartilage. This is the posterior canal wall reconstruction. Okay?
Yes, ma'am.
Yes, ma'am. Yes, ma'am. Super.
This will stay there and then I just wanted to show you the size. Now keep it. Now I have got all this torque for. I'll try to finish it because it takes slightly longer time. Do you want to see titanium top?
Yes, ma'am.
Okay. Titanium top का box देना. Titanium.
Ma'am, any cartilaginous reconstructions or?
You want cartilage? I can do that. If you want a cartilage reconstruction or titanium torp or Teflon torp, what you want to see?
Ma'am, cartilage.
Tell
Whichever
me.
is okay, ma'am. Whether it is your convenient.
Cartilage, I think.
You want? Because ossicle is not there. First choice is always ossicle. And if it is not there, second comes either cartilage. As a boomerang cartilage, I can do that. I will just show you the titanium torp and do the cartilage reconstruction or do the titanium. Rather, cartilage is very easy. Titanium is bit too tedious because we have to create 3 layers. What do you want?
Cartridge, I think, would be good because TORP is not available with most of the centers.
So I
I
will
think
just
the
show it
audience will
how
be
it
more
is done.
interested.
I'll not do it. I'll just show it. Okay. But we'll do cartilage. Okay.
Yeah, cartilage may be a better idea, but if it is a TORP, you have to always do it as a second stage procedure, not at this
Yes,
stage.
absolutely right. But because this case does not have any inflammation or, usually TOP we avoid because it may lead to extrusion if there is any inflammation or infection. It seems a clean case, but I'll do the cartilage. Okay.
You have experience with TORPs in the single stage. How is the outcome? Single stage.
I do it. But yes, you're right because it is a costly one. But if it is clean now, then it stays.
Okay.
Give me cautery. I'll take a slightly bit of conchal cartilage for, repair for cartilage because the tragal is completely, hold it. So this is the.
you have two options here, you're going for a reshaped malleus and reconstructing and also a cartilage. Which may be better in your opinion?
So cartilage is better because does not cause anything to the patient. And
No.
TORP is when
Reshaped
you are
malleus. Reshaped malleus. Against reshaped malleus.
reshaped malleus needs something to support it laterally. Medially, it can be kept on the foot plate.
Yeah.
But laterally, if it is does not have any added support, then there is no use putting this. And this all ossicles are badly necrosed. Local dena jaldi. So I am taking a slight strip of conchal cartilage because tragal has been totally used for the.
So
I don't
you
want to
feel
cut
the cartilage will have a better stability.
No, if we do TORP, that also has a better stability, but it is okay. I am taking cartilage now.
Yeah.
Forceps and knife, jaldi se de do bas. No. Hold it. Let me see. Kahan hai? Okay. Hold it. खींच इसका. Give me plain forceps. Plain forceps. ये erode कर रहा है उसको तो जल्दी.
Conchal cartilage from that area, that inferior aspect, will be very tough, thick and thicker cartilage you can get there, from there. It may be better for the reconstruction.
छोटा हो गया है. I think small. लो पकड़ो इसको. This is a small one. छोटा हो गया. पकड़ो इसको जल्दी में हो रहा है ना सब. Take it. एक बार इसको पकड़ेंगे. Longer strip चाहिए. And this is where. That is a smaller strip. पकड़ो इसको.
A good chunk of cartilage. That's good.
Yeah, slightly curved cartilage I have taken. 10 minutes.
10 minutes only.
Huh. Yes. Okay, okay. Okay, thank you. Okay, okay, okay. Cockroach, just hold it with the forceps, this part. Yes. Hold it. Very good. Very good.
Madhuri ma'am,
Yes.
you have flight at 4:25. Can we postpone it?
Yes, yes. How much can you postpone?
I'll just check
Please
through
do
team.
that. Please do that.
Yeah,
So that I
because
can
right
work
now
at
it is not looking feasible to take the flight.
Yes, yes, yes. Please do that. Please.
Sure, ma'am.
Thank you very much.
Yes, ma'am.
Thank you. So now I have taken this boomerang shaped cartilage. Can you see there?
Yes, we can see that boomerang shape.
Very clear.
Clear.
Yes, take this. Hold this one. This soft tissue. Hold it. Oh, pull it towards you. Okay. I will finalize the size once I keep it there because slightly it seems bigger, but I'll do the adjustment there only. So now put the retractor. For placing the cartilage, we need to have two stable points, okay? When there is no suprastructure of stapes, on both the sides, the cartilage should be fitting like a, bridge, over bridge, okay? So what I'll do is I'll drill a groove there in the anterior bony sulcus. Wash. So this, okay. Now small drill, okay? Small diamond drill. So what I'm doing is,
Can you just elicit and show the round window reflex ones?
okay, why not? After placing the cartilage, we will show. Okay?
Either
Okay.
way, no problem.
So that way we will be confirming our this thing also, ossiculoplasty also. Okay? So this is the part. This is footplate. Can you see?
Madam, a little bit of fine adjustment is possible.
Okay. Up now, is it okay?
Yes, madam. Now it's fine.
Look, I am not putting any time my suction on the footplate. You should not. That will be really bad. Now I'm drilling a groove there. Can you see side knife dena? There, this area. Okay? Side knife, flag knife. And slight small size suction. One size small suction. I don't want this flap to get into my drill. Okay? So I'm separating it from this part. Now give me small drill.
Janki sir's team, theater team, are we ready with the patient?
So I'm making this groove there. बंद हो गया suction change करो.
Is it at the level of the annulus you are making that?
Yes, bony sulcus area. Just, diagonally opposite to the foot plate. It is mostly in the anterior inferior part. Can you see there?
Okay.
So I've created the groove. Now give me what I created out of the cartilage for ossiculoplasty. Cartilage. ध्यान से गिरे नहीं.
Can you just fine focus it a bit?
Okay, we will do once I start
The
keeping. No?
medial wall.
Ma'am, some fine focus is required, please.
Okay. भाई फाइन फोकस देखो सेक्शन थोड़ा छोटा गिव मी डू
Okay.
लेट मी डू अ बिट ऑफ सक्शन छोटा सक्शन देना हाँ उससे भी छोटा जो पहले दिया smaller. Can you see the foot plate?
Yes, ma'am.
The focus is okay. The best whatever can be. You want more? Now?
This is better.
This is better. Cartilage and sickle. Cartilage, whatever boomerang shape cartilage I have taken, keep it here. यहाँ गया साथ दिया आपके हाँ now this is quite big for this area. Okay, can you see?
Yes, ma'am.
So I have to trim it.
Yeah, too bigger than us.
Forceps आ गया रुको. Okay, give me knife. Now I have an assessment how much I should be trimming it. Okay. Very good. Forceps. Oh, इधर है ये सब निकालना. Hold it. Slightly still bigger, I think.
This boomerang thing may be a good idea. What about columnar reconstruction?
Columella?
Columnar strut.
Usually, yes, columella interposition graft is always better than the columella. But once the incus is not there, then interposition cannot be done. Though with titanium torp or port, we do 2-point stabilization technique. Okay. One is we place a cartilage shoe at the stapes foot plate to stabilize the medial end of the this. Okay. Medial end of the shaft, because I don't know why companies make a circular shaft out of the torp of the different companies, whereas the shape of the foot plate is always oblong.
Oval.
So it is always unstable on the medial part. So what we have done is we create a cartilage shoe. I'll show you if I get time and they delay my flight. I don't do it. I will show you how the titanium is done. Okay.
Ma'am, do not worry about the flight. We have postponed it to 8:15 now.
Oh, very good. Done. Okay. So now hold this piece. Yes. Because this is fine work. I will not be doing justice to the patient by just fast forwarding it.
True, ma'am.
Okay. Now let me check again. So if we take a good boomerang now, it gives height to the middle ear as well. So height always adds out to the middle ear space and the working of the ossicles. Okay. A good height of around 4 to 4.5 millimeter is good enough for the ossicular working. Slightly more. Give me forceps. Suction बंद हो गया. Knife फिर से दे दो. Just fast.
What about cartilage palisading technique? In the middle
Cartilage
ear?
palisading is required when you are afraid that the middle ear space will not be maintained. Why shall we place big size cartilage? Because when nature provided a very thin vibrating tympanic membrane. Okay. Palisade is usually done in cases we feel ki eustachian tube blockage can be there, leading to middle ear effusion and retraction of the membrane. Okay.
I see.
Only those cases. We don't do it usually in. We will keep a good temporalis fascia graft there with a big height achieved by this conchal cartilage. You will see it will be beautiful once I keep it finally.
Okay.
Palisading is only for specific cases. You don't do it in routine.
When you are anticipating eustachian tubal dysfunction.
Yes. When there is and the thin tympanic membrane, they suspect that it may get retracted again. Now it is almost fitting there, but this edge needs to be slightly trimmer to sit nicely on the foot plate. Now I'll just trim this to sit on the foot plate nicely. Knife. This the end. ये पकड़ लो इसको थोड़ा और. I'm just checking the round window reflex. It is there, but I want to thin it. Can you see? I'll show you. Can you see the round window?
Yeah, we can appreciate that. Yeah, we can see the reflex.
Very clear, madam.
But I'll just thin it. Sorry, I have been slightly over perfectionist. Just give me 2 minutes more and then I'll close it down. And then I'll try to show that titanium top if we have time. Will not use it, but I'll show you.
Madam, is it mandatory to remove all the mucosa from the cartilage before you put it inside the middle ear?
No. Why? At least mucosa on one side gives vascularity and stability to the. So at least mucosa on one side should always be there. It gives stability as well as दे दो, बस हो गया। अब अपन को वो वाला कार्टिलेज देना फिर मेरे को, पोस्टीरियर कैनाल वॉल। Now you see it is going. Okay. अब मेरे को वो देना जो ट्रेगल कार्टिलेज। वी विल रिकंस्ट्रक्ट द पोस्टीरियर कैनाल वॉल। Give me the this cartilage. Cartilage, tragal cartilage. Yes. क्यों इतना हिल रहा है? Somebody is shaking the microscope. Okay. I will place the tympanic, the temporalis fascia. A small piece of cartilage, please give me, जो मैंने निकाला था। कोई नहीं, पहले आप मेरे को वो दे दें। Yes. Wet it. थोड़ा पानी डालें इसके ऊपर। You know, I use the temporalis fascia in a semi-wet form. Put saline, slightly saline. आप इसको ले लें, बस ले लें इसको। Take this, forceps. It is slightly bigger. Give me scissor, fast. No? This is the residual tympanic membrane I saved. Can you see?
Yeah. The remnant tympanic membrane.
Yes. So I can spread it now. So every bit of skin is being used, or epithelium. Now this gives such a good cover to the interior part of the tympanic neotympanum. Can you see? Give me cotton ball, small cotton ball. This is a overlap over the. And always check your दे दो थोड़ा cotton ball छोटा सा. ये section बंद हुआ. I'll just check the usually the ossicle or ossiculoplasty reconstruction may get dislocated. We'll see. So now this is two layers of one is epithelium, one is neotympanum. Can you see there? छोटा देना, छोटा देना वो सेक्शन बहुत बड़ा है.
Yeah, there is a round window reflex.
Yes.
We can see that.
Yes. Thank you.
Nice.
Now I'll replace back the this skin which we had lifted. We don't need to do much of cartilage, this meatoplasty of the skin, because now not much of the widening has been done. Whatever widening was done has been repaired. Can you give me a small piece of cartilage there? It is lying there. Small.
So no meatoplasty is needed in this.
No, not. No. Yes.
Obviously.
Obviously. Yes. Dena, just want to put one cartilage piece there. The scissor there. Slightly. बड़ा वाला, बाहर वाला scissor, बड़े वाला. Yes. And then I'll be replacing back the skin. Okay, take it.
A bit cartilage support at 1 o'clock.
Slightly. Yes, yes, sir. The one here.
Yeah, there. Understand. To prevent any future retraction.
Yes, yes, yes. Retraction. Now I'll place back the skin. Okay, pakro. Now this whole skin will go back inside. Okay, this is how we lifted it.
Yes, yes.
And I'll put the suture there with this.
That's how you fashioned it in the very beginning. You had taken care.
Yes. And had it been a canal wall down, I would have given a vertical cut and a horizontal cut, and all this skin would have opened up like a book. I would have spread it on the cavity. So it was not needed. So we will keep it back. Okay.
Yes,
Suture.
yes.
So we
It's almost like a normal, natural external article.
Yes, absolutely.
Madam, how would you deal with the condition in which you find extensive granulations in the oval window and the Eustachian tube area?
Had it been there?
Granulation, madam, in the oval
So
window.
what is the best way to deal with the granulation on the delicate structures like foot plate and round window membrane or dehiscent facial nerve? Don't ever try to remove them. Just keep a gel form soaked in steroids or adrenaline and keep it there for a few minutes.
Madam, if you are through, we can start.
Yes, we are through.
Finished.
This is the last question I'm answering. I'm finished. Done. Yes. You can shift. I'm just answering this question and we are closing. This last question I'm answering and then we are through. We are closing. Okay.
Okay.
So for granulations, you don't put your sharp instruments directly on that. Just leave some gel form soaked in on the granulation for good 3 to 5 minutes. Let them shrink and then with the side of a flag knife, gently with the gel form and side of a flag knife, just scrape off whatever is superficial and rest of it to be left behind. Okay.
Thank you, ma'am.
Okay. Thank you. This suture. Huh?
Thank you so much, ma'am, for the wonderful surgery.
Yes, there also. There also. Oh, what is the question? Suture?
And where is the PPT? Ask Purva, no? Purva will have, no?
And thank you, panel, for the wonderful moderation for the case.
Read it, no? Yeah.
Thank you. Thank you, panelists, for chairing this session. Next, we have Dr. Janaki Ram, sir, demonstrating.
Hello, can you hear us?
Yes, sir.
My dear friends, can you hear us, please?
Yes, sir. Yes, sir. We can hear you.
Hello. Hello?
Sir, we can hear you.
You're audible, sir.
Hello?
Hello.
Hello, can you hear her, please?
Yes, we
Hello?
are checking, sir. Just a minute. We can
Hello.
hear you.
Sir, we can hear you.
So, Purva, we are
Yes,
going
sir.
to wrap up with the last case. I think this is going to be a highlight of this conference. If it is going to be a good case, I don't know. And you can invite the
Yes, sir.
panel members so that we can start.
Yes, sir. I would like to invite Dr. Deendayal, sir, Medical Director of Dr. Deendayal ENT Center and Chennai Hospital, Hyderabad. He was the first ENT surgeon in India to use radio frequency in ENT in 1996. First ENT surgeon to perform silendoscopy in South India. His guest faculty in several cadaver dissection courses, live surgical workshops nationally and internationally. Organizing chairman of Indian Association of Surgeons for Sleep Apnea. Practicing ENT in Hyderabad for more than 40 years. Sir holds various national and international publications and published books on stroboscopy and obstructive sleep apnea. We welcome you, sir. And I would like to invite Dr. Ananda Acharya, sir, Professor and former HOD Usmania Medical College and Hospital, former AOI Hyderabad President. Dr. Sarbajit Sardar, sir, Consultant ENT Surgeon at BDH Hospital, Bashirat. Dr. Saikat Kumar Basu, sir, Consultant ENT Surgeon at Dr. Roy's Super Specialty Hospital, West Bengal. Dr. Sri Prakash, sir, Chief ENT Surgeon at Micro ENT Hospital and Research Center. Dr. Shyam, sir, Dr. Nageshwar Rao, sir, and Dr. Krishna Kishore, sir. Please chair the session. Over to the OT.
Let the chairpersons tell something. We start then after that.
Yes,
Yeah,
yes.
let them settle down.
Yes, sir.
Good evening. I think it's a pleasure to share Dr. Janaki Ram's, surgical expertise here.
Yes.
And the case, a skull-base hemangioma, is not a very common condition.
Yes, sir.
And like he said, this is going to be the highlight.
Yes, sir.
And Janaki, you need to expect a lot of questions from me.
Sir, you are my teacher. I will try. I learned from you.
No, we are going to see the best operating and we're going to have a wonderful time.
Thank you so much, sir, for honoring us. They told about you. I just want to add that in 1998, Professor Sethi is my teacher. He doesn't call people just like that. And he had called you to Singapore General Hospital, and you were the orator there. I remember that. And I was awestruck by your presentation there. Thank you very much for being here after many years.
I just wanted to add that the first endocon happened in Hyderabad and the faculty was Dr. Sethi and Dr. Milind Kirtane. And the first cadaver FES dissection course was at Usmania Mortuary by Dr. Sethi and Milind Kirtane. In India, actually.
Yes,
Wow. Let's give a big hand, actually. Yeah. And also, special thanks. Morning, Dr. Anand Acharya was not there. I thanked you.
Yeah, I'm sorry
I
for
thanked him
that. Sorry
for the polyp case which you had sent, sir. Thank you very much. Welcome all the panel members. Dr. Shivakumar is going to talk about the case.
Good afternoon, everyone. I'm Dr. Shivakumar from.
Dr. Shiva, you're not audible.
Keep it close.
Hello, can you hear
Yes,
me?
you're audible. Yes, please continue.
Good afternoon, everyone. I'm Dr. Shivakumar from Royal Pearl Group of Hospitals, Hyderabad. We are presenting a skull-based hemangioma case. Here is a 29-year-old male who presented with complaints of headache and bilateral progressive loss of vision since 2009, and for which he has undergone MRI brain, and it revealed 4x4 mass indents the posterior extent of the optic nerve on both sides, abutting the chiasma, and for which they have taken a sphenoid biopsy, which was suggestive of hemangioma, and patient underwent radiotherapy of 30 cycles. And there was a history of nasal bleed, which was spontaneous, unprovoked, and which used to stop on medication and compression since 2019, for which he undergone multiple blood transfusions every episode. And patient also reported cerebrovascular accident with left hemiparesis, with responded to physiotherapy and patient fully recovered. And he has undergone multiple
Next slide.
surgeries in 2009 and 2020, endoscopic sinus surgeries, and they've taken biopsy. And it is suggestive of capillary hemangioma. And digital subtractive angiography was also done recently, which is suggesting the feeders from left internal maxillary artery. On examination, anterior endoscopy, the deviated nasal septum to the left, and ear and oropharynx within normal limit. Eye examination, the perception of light is present in all the quadrants, and there was bilateral optic atrophy. I will give it to the sir for the radiological findings.
Hello.
Yes, sir.
Yes, sir.
I hope you heard the history. History itself is a little scary history.
Yes.
Patient presents now with bilateral loss of vision, and he's a young male, and he has been operated 3 times earlier. Biopsy has been done, abandoned due to bleeding. So, and the biopsy has been capillary hemangioma. Well, with this history in mind, what do we do? How do we proceed? Number one, having this history, nobody would take him for surgery because, you know, hemangioma treatment is either sclerotherapy or, a radiotherapy or, embolization and things like that. But the thing is, he was referred to me from Bombay, and also few doctors from Pune referred it. And they said that try your best to, try to remove it maximum, if not completely. And I thought, shall I send him for sclerotherapy? Where do I inject the sclerosant? So that is a big challenge. If it is outside, usually we'll put in a sclerotherapy and things like that. But here it's intracranial and it's intraosseous. So first of all, once I saw the patient was completely blind in the sense bilateral optic atrophy. So I wanted to understand the expectation of the patient. What do you want from me? Do you want the vision back? It's not possible because optic atrophy already has set in. So I asked him, they said he's got severe epistaxis, hemoglobin falls every time, we have to transfuse blood. Can you do something for it? I said, I will try. I'm not sure if I can do it. And I told the doctor yesterday, I received a lot of calls from Bombay also. A lot of doctors called up. I'm a little tense in doing it, but then I want to show you. So the first thing I did was, let me do a CT scan with contrast because the patient did not have a CT scan. So let us go through the CT scan now. This is a CT scan with contrast, which I've done. You can see that is the, can we have some silence in the theater? Thank you very much. So that's the CT scan. You can see that's the septal body. The bony septal body is a little thicker, turned towards the right side. Both frontal sinuses are pneumatized. Why do I need to know the frontal sinus? Because I might have to do a draft 3 if I have to do an anterior craniofacial resection. Okay, now you can see that this frontal sinus pneumatized septum, this is the maxillary sinus. This probably is just polyp. You can see this is all polyps in the maxillary sinus, filling the maxillary sinus. And that's the middle turbinate. You can see the anterior ethmoidal artery dehiscent on both sides. Supraorbital pneumatization is there. Well, as we go, that's the orbit. Having a note on the orbit whether any hemangioma is present on the orbit or not. Now, let me go back and see here that this is the optic nerve, medial rectus, superior oblique, superior rectus, and then this is the lateral rectus, inferior rectus. This side, a little distortion is already seen. And you can see in the orbit, you can see this is not a normal orbit. You can see there is definitely some hemangiomas inside the orbit compressing on the optic nerve. Same way, this side also you can see hemangiomas in the orbit. So, vision-wise, we can't do anything now. So, what is the aim of this treatment? Aim of this treatment is to get rid of epistaxis. Now, where is this epistaxis coming from? Definitely from the hemangioma. But if you look at it, which part could have produced that epistaxis? Now, when we look at it, this is the anterior ethmoidal artery. Behind the anterior ethmoidal artery, you see that the supraorbital pneumatization, and you find this big lesion here. This big lesion is sitting underneath the frontal lobe. This is the gyrus rectus. This is the frontal lobe. But a CT contrast, it is not enhancing much. What should it do actually? It should brilliantly enhance because it's a hemangioma. But capillary hemangiomas don't enhance much. This is very important to note that in a CT, it doesn't enhance too much in a CT. So this is a characteristic of a capillary hemangioma. Of course, in MRI it enhances, but not in a CT because the vessels are so small, tiny, which feed it. Okay, so that's again in the posterior ethmoid, just above the posterior ethmoid, he has got a big lesion and the dura is intact. That also I don't know. Whether the dura is intact or not, we don't know. So we have to take an MRI. For this only, I thought, okay, we'll take an MRI. But if you look at the bone here, look at this bone, the parietal bone, you can see intraosseous hemangiomas. These are all intraosseous hemangiomas. All these are intraosseous hemangiomas. Now we will go back. This has got a bony covering here. You can see there's a bony covering here. So this is very unlikely for that patient to have epistaxis from here because there's already a bony covering. There is a small gap here through which he can bleed. This is there in the level of the planum. He has got it. So that this area he might bleed. But more importantly, as I go back, you can see that is a sphenoid sinus. This could be polyp. And there's a lot of osseous. See the osseous changes. So much of osseous changes. Greater wing of sphenoid is completely, maybe there's hemangioma here. All these are hemangiomas. But more importantly, look at the clivus. Intraclival hemangioma, very clearly seen intraclival hemangioma. This is the intraclival hemangioma. This is also completely filling the clivus. Hemangioma is filling the clivus. So now I thought, what is the investigation I need? Why do I need another investigation? Number one, I don't know the status of the dura. Number two, I don't know what is the kind of enhancement this lesion is producing. So then I went for a MRI with contrast. Now let us look at the MRI T1 with contrast. I need the coronal. This is actually, you can see the hemangioma spreading along the temporoparietal region. Can you all see that clearly?
Yes.
See, this is not going to produce epistaxis for him anyway. It is intraosseous. This has to be completely removed by the external approach. And for this, he needs a craniectomy. Okay? So that will be done by a neurosurgeon. I will not be doing it. But what I will be doing is, you can see here, this is a lesion sitting underneath the frontal lobe. Can you see here?
Yes.
So, but here, it seems as if the dura is intact. It seems
Yes.
as if the dura is intact, but I'm not pretty sure. But here, definitely you can see the clivus completely enhancing there. Can you see here?
Yeah.
The clivus?
Yes. Yes.
See, that's the carotid artery. This is the carotid artery. This is the maxillary artery. So there's a supply from the maxillary artery. That's the carotid. And this completely is enhancing. The clival bone is enhancing with a lot of contrast. So that means it's an intraosseous clival hemangioma. So this probably is the site where he's bleeding from. So what will be my plan? Now, my plan will be, number one, capillary hemangiomas, even if you control major vessels, it might bleed because they're all supplied by capillaries. So anyway, what I'm going to do is to do a Denker, and I'm going to ligate this maxillary artery because that is the major artery supplying it. I'll try to go peripherally, get the SPA, DPA. So this will be my first step to get the feeding vessel. But you can have venous drainage also. In a capillary hemangioma, you have both artery and vein. So what I will do is I will try to completely, devascularize this area. Then what I will do is I want to remove the septum. I want to remove the septum completely. And then I want to completely expose the sphenoid sinus. I will not touch this region at all. Hey, follow me. I will not touch this region at all. I will not touch this posterior ethmoid region. I will not touch this superior part of the left sphenoid. That will be done last. So I will be going to the clivus and I will be drilling off the mid-clival region. Complete drilling of the mid-clivus and the greater wing of sphenoid. This side is extending laterally. I cannot do this. So I have to place Surgicel here. I have to place Surgicel here because that lesion has to be tackled by the neurosurgeon. Then what I will do is I'll remove all this hemangioma from the clivus. So this will be my part 1 of the surgery. And then the part 2 of the surgery is if I am going to remove this part of the hemangioma here. Maybe it's a different lesion also. I don't know what this lesion is. Whether it is a hemangioma or anything else, I don't know. It's sitting right underneath the frontal lobe. For that, what should I do? I have to now either go in for I have to ligate the anterior ethmoidal artery. I have to transpose the orbit here. I have to transpose the orbit. I have to drill off this bone. So I will do an orbital transposition and I will drill off this bone, the thick bone, and then I'll be right on the lesion. And once I'm on the lesion, you have posteriorly the bone. So I'll get a lateral control. I'll get a medial control. I'll start dissecting it from the dura. Once I start dissecting from the dura, I'll have a posterior bone very clearly, and I can actually try to sweep that lesion down. I will try not to disturb the dura because I'm going to use bipolar. But if I disturb it, then my only option would be either a Haddad flap or a pericranial flap. So I'll be harvesting a Haddad flap on the right side first. Right side Haddad, and then going for a left side Denker, and then I'll be proceeding. So this is going to be my route of approach for this case. I think I read literature. There are 2 cases reported like this of intraosseous hemangiomas with epistaxis in the ethmoids, or maybe something more. But I went through, not many cases have been reported. And if we do this, I think at least in India, this will be the first case to be done. So with this, I would like to answer any questions which my teachers, the learned audience ask me. I will try to answer to the best of my knowledge. Now, there are 2 instruments which are very vital in this case. Number 1 is the drill. I'm going to use the S3 neurodrill system, or what drill system do we have? Medtronic. Okay, we are going to use the Medtronic drill system. Number 2 is I'm going to use the coblation. Number 3 is the diathermy. So, hey, you use a new one, don't give a old one, please. So, I'm going to use a diathermy, bipolar diathermy, and I'm going to use Surgiflow or Flow Seal, and I'm going to use Surgicel, gel foam, all that ready. And of course, and I will, if I open the dura, plan for anti-epileptics as well. So yes, I can, this is what I'm planning to. You can ask me any question now.
I think it has been so beautifully explained, Janki. I only have one question. Is the epistaxis unilateral or bilateral?
Left side.
Always left side.
Yes.
And maybe a little deeper into the history. Is it mostly an anterior bleed or a posterior bleed?
It comes both anterior and posterior.
And quite severe?
Yes, very severe. His hemoglobin drops very dramatically. That's why he's been transfused many bottles of blood.
So right side, it's not there at all.
Yeah, I think one episode now he has developed. Now, last time he got admitted, he got one episode.
There is one cut in the CT scan, I think 3rd row or 2nd row, where you see the bone is absent and the mass is protruding towards the right side.
Right, yes,
and
yes.
there
yes,
is
I
no
agree.
bone over there.
I fully agree.
So there could always be a possibility of a right-sided epistaxis.
Fully agree. Fully agree. That is Dr. Dinayal, sir. Actually, I also told there's a small defect here. Of course, there's a defect here as well. So there can be epistaxis from both sides. Perfect. I fully agree. Yes.
So you'll be mainly doing on the left side itself.
No. I'll be doing an anterior craniofacial dissection. That is a bilateral approach.
Perfect.
It's going to be a midline approach. I'll be taking off the whole of the skull base.
Sir, however, this unfortunate boy is already lost vision. Any preoperative radiotherapy, role of preoperative radiotherapy. This radiotherapy itself gives fibrosis of the hemangiomas.
Radiotherapy given, no. History,
Yes,
they told.
Yes.
Radiotherapy given.
Yes,
they
sir.
try to inject. So many things have been already done. So we
Yes,
are
sir.
left with only one option, that is surgery.
Yes.
Radiotherapy given already.
Yes, sir.
Now, as a last resort, he has been sent, okay, try your best for, I also told the patient, I'm not sure if I can do the best. Let me try, because if it bleeds very heavily, I can't make the patient die on table. It's not possible. So I will try to do my best. If it bleeds too much, I pack and come out. So that is my plan. I should know when to stop also. We have reserved 3 bottles of blood. 3 bottles of blood is already there on table, right? 3 bottles of blood or on 3 pints of blood on table. And of course, we have another 3 pints ready. So, yeah. I am planning for a centripetal approach as much as possible. So, we'll try to go around like an AV fistula. We will try to go around like an AV fistula. So, it's a skull base vascular lesion.
All the best. And I know you're going to do well.
Sir, I need your blessings.
All are waiting for the academic feast, sir, after lunch.
I hope some of them are waiting. Most of them would have gone or into a slumber.
No, sir. Still hall is full, sir.
Sir, one thing, sir. Is the left CVA of any significance in this case, considering his age is 29? Left cardiovascular.
Patient, yeah, very good question. Dr. Anand Acharya, is it?
Yes, sir.
Lovely question. Actually, what had happened now is, that's a very, very nice question. Very nice. Patient developed severe epistaxis, severe hypovolemia. He developed hypovolemic shock, following which he developed a CVA. So that also history we took. So that is the reason for a CVA, following which he recovered. The transfusion was given and then he recovered. Now he is just limping and walking now. He is walking. He has come walking only. Only thing is blind both eyes.
Any anesthesia implications for that?
Sir, anesthetist madam. Madam, idhar aaiye. They want to ask about anesthesia, any specific thing you want to do?
Only hypotensive anesthesia I'm going to do, sir. And massive transfusion protocol has been already switched on to the blood bank. So I am ready with the 3 points of blood, 3 points of FFP and 2 platelets, sir.
I think, Janaki, just one more question for you is, have you thought in terms of carotid angiography?
Carotid angiography?
Yeah.
4 vessel.
For knowing internal carotid supply, if at all there is any.
Yeah, did you see that also we have done that? The supply is mainly from the IMAX.
Yeah, IMAX. Yeah, but anything to
There's
do
no
with...
ICA feeder. There's no ICA feeder. We made sure. I went to the radiology place. I sat with the radiologist. We had a massive study yesterday for 1 hour. That's why I told also the audience I came late. I was sitting with the radiologist for 1 hour. I studied each vessel which supplied the tumor. But to me, I think I'm going to expect more of venous bleed because it's in the clivus. The clivus is richly supplied by clival plexus. So I'm going to have a lot of venous bleed.
Okay.
So that is what I'm expecting. Number 2 is, you'll have to pardon me because it involves a lot of drilling. If you look at it, bones are all very thick. So thick. So all these bones I have to drill to reach this tumor. So this tumor I can reach by just drilling here and an orbital transposition. But this bone I have to reach only after drilling all these bones. So you might have to be a little patient. It might take around 2 hours for me. My expected now it's around I was supposed to start at 1 o'clock. 2 hours delay. I might go on till around so 3 means around 5 o'clock. Is it okay?
Please go ahead. Please go ahead. We are looking forward.
I'll wash up. The lights down a little bit, huh? You can focus on this. Lights a little down, please. The apron, right? So Dr. Madhuri madam did a very good job. I hope you give a big round of applause for Dr. Madhuri madam. I was not there. I was washing up. I mean, in the sense I was in the other theater. Moderators. Purva. Wonderful surgery by Dr. Madhuri madam.
Yes.
Actually, we have to congratulate her because she has shown the boomerang cartilage very well. I would definitely say that that has been so nicely demonstrated, and the round window reflex has been so beautifully shown by her. And in fact, even the reconstruction of the posterior canal wall with the cartilage and the way she had nicely replaced the flaps, what she had planned up pre-operatively, has been so well demonstrated.
Ready? I'll do. Okay. We'll start right there. Head and elevation, please. No. Come on. Oh. Come. No, black sleeve first. Hair cut panliya. Oh.
Elevator. Pack ready.
Right. Did you see the nasal endoscopic finding, please?
Yes, sir.
Yeah, table up, please. So I'm going to start. Give me an elevator. So my plan again is a binostril technique. A elevator, please. Ready. I'm going to start with the lateralization of the inferior turbinate. I'm infracturing the inferior turbinate, and I'm out fracturing the inferior turbinate.
Instruments, irrigation, suction, R&D.
So that is the first step which I want to do.
Okay, thank you.
Okay, the next step which I want to do is give me a coblation now. Elevator. So the next step I'm going to do is medialization of the middle turbinate. Already FES has been done, as you can see here, polyps and things like that.
Yes.
So you can see that the region of the horizontal attachment of the middle turbinate, that's the basal attachment. So what I'm going to do is to ligate the sphenopalatine artery first.
Irrigation, coblation, irrigation.
Scissors. Yeah, thank you. So that's the first step which I'm doing. I mean, like the pituitary, it's the same like the pituitary. A coblation ready?
Ready.
Suction, please.
Suction ready.
Lakshmi and Shilpi Bhatia Sharma are helping me. Lakshmi is a super trained, and of course Shilpi, I don't have to say anything about it. Lakshmi is from Chennai. She's come all the way just to help me. Not sponsored by Sun. I want to tell you that.
No conflict of interest.
Bring it into books.
The minute you spoke in Tamil, I said somebody has come from Tamil Nadu.
Sir, you are very clever, sir. Okay, coblation, please.
Ma'am, tackle little late, ma'am. Let's be ready.
Now, see here, what I'm going to do now is, yeah, give me a good irrigation. Madam, you have to calculate blood loss depending upon the irrigation fluid we are using, okay? Don't calculate that as blood loss. Hey, make it 9.5, setting as 9.5. That's the superior turbinate there. Okay, infiltration. I'm taking a hard flap. Infiltration, please. I'm so honored to operate in front of Deenadayal, sir. My God.
I am happy that you're doing such an interesting case. I'm enjoying every bit.
No, sir. The days were there when I used to really, I came to a clinic with a waterfall with internal cameras. I was actually seeing you with awe.
Knife ready, ma'am. Ready.
Yeah.
Now you can see that I'm just infiltrating. I infiltrate normal saline, no xylocaine with adrenaline. This is something I keep telling. Knife. And infiltrate at one point. Don't infiltrate at too many points. So this is the incision I make. I make it on the vestibule skin. Just on the skin, elevator. Now this elevator I've designed myself by just drilling the, yeah, you have one end which is cutting. So that is the plane which I got. So one thing is that you have to remember this Osler-Weber endo. Multiple telangiectasia.
Yeah.
But that doesn't present like this. I have seen a lot of cases. I have done septal dermoplasty for many cases. I think 7, 8 cases I have done. But none of the cases presented like this. So that should not be confused with this. This is a... Yes, sir. Yes.
We have done about 4 Osler-Weber endo. And there, what we have done is we have done it in 2 or 3 sittings. We have used radio frequency.
Wow.
And the results have been excellent.
Fantastic.
And
Okay.
the last Osler-Weber endo was done hardly about a week ago.
Wow.
Wherein that patient was operated elsewhere 2 times. To an extent, they even put a spinopalatine clip. And actually, the bleeding was from a highly deviated nasal septum, where there was a huge one of these telangiectatic thing, superior, that was not clearly visible. And it was from the anterior ethmoidal supply.
Okay. Sir, but I'm sure that those cases which you have seen have not presented like this, right?
No, not this. We had one case of massive bleed. If you allow me, I'll share that.
Oh, sure, sir.
Similar sort of a massive bleed. And that time I was out of country and my team saw admitted It was a blind patient
Hmm.
who had a head injury about a year ago or 9 months ago. And when we did a CT scan, it looked only that the sphenoid is hazy and the right ethmoid was hazy. Sphenoid and right ethmoid and posterior ethmoid, and everything else was fine. So as usual, I said, I asked them to do a diagnostic endoscopy, have a look where the bleeding is coming from. And they said the same thing. They had to transfuse blood and all that. And we took the patient, saw nothing was there, extubated, came into the post-op ward. He bled massively. We took in and I did an exploratory endoscopic work. I had to just put my Blakeslee into the posterior ethmoids. There was a torrential bleed, and I said, I've hit a aneurysm. It was a pseudo aneurysm of the carotid.
Then what did you do, sir?
I mean, I had a very nice team. I just said, get a balloon, get a balloon. Immediately
Fantastic.
they got a balloon. I pushed it into the posterior ethmoid straight. It went into sphenoid. And
Fantastic.
dilated. The bleeding got controlled.
Beautiful.
Then took the patient for angiography, double confirmed. And the one nice thing about that patient's thing was that there was, the supply was for the carotid supply was there from both sides. And so we did a internal carotid ligation on that side. And the whole thing got controlled.
Wow, fantastic, fantastic. Okay.
I had a similar case, Janki.
Deepak sir, Deepak sir.
Yeah.
How did you go so fast? Did you take a shopper?
And that, but in that case, the circle of Willis was not complete.
What circle?
Circle of Willis. The opposite flow was not there. Patient went into stroke and problems because post-traumatic keratoconus fistula. He had fallen from a coconut tree.
Nice.
Yeah.
Okay.
Yeah.
But getting that, as Deen Dayal sir said, both Deepak Haldipur sir and Deen Dayal sir, they are working in hospitals which have beautiful neurosurgical as well as radiological backup. So that is very important.
But still, Janki, when we see that bleed, actually when the carotid bleeds, which you have seen obviously.
Yeah.
Arey boss, it's a very unnerving experience.
Yeah.
Deen Dayal sir is a cool man. He must have remained cool.
I have published it in JAMA.
Yeah.
And JAMA has a index factor of 21, and our article 21, yes. Along with Karan and myself, we published four internal carotid artery bleeds.
Wow.
I can share that article with you. All the dramatic, as Dr. Haldipur sir says, they are actually nightmares. Knife.
I think Deen Dayal sir will agree when you see the bleed. He's very poised anyway. So that's one.
If you have a good team, I'm sure you will be able to manage. The team has to be good.
Yeah.
Sir, one thing I have noticed, Deepak sir, is you can never make Deen Dayal sir tensed at all. You see, even when he talks,
I know.
He's cool.
Yeah. I've never been tense. You're true about that. I've never been tense.
I have seen you from 98, sir.
He told me about his adenoidectomy experience in the beginning of his practice. And he was narrating that very coolly as well.
Coolly he will talk. No tension. The sky should fall down even then. Okay, so I just did a Haddad flap here. Just in case I have to open up the give me a pack. I have to open up the dura. If I don't, it's okay. But anyway, it's better because I'm doing an ACFR. Give me a pack. See, the one thing which I learned from operating abroad is that, see, I think this is very important. I am going to convey that. See, when I ask for an instrument, uh, they will say ready. Ready. So that word ready. I think all of us should actually ask our staff nurses or whatever that I learned. And Shilpi, cobbler. Shilpi is one who will always say ready. All the staffs will say ready. So it gives tremendous confidence for us. I don't know how many of you are practicing that ready. Dindal sir, what about you?
In fact, we follow a similar sort of a protocol what you follow.
How, sir?
In terms of like any case, even as simple as a adenotonsillectomy or along with it doing a nasal workout, there has to be a thing called as plan of action written down.
Excellent.
In a stepwise manner.
Okay.
And our plan of action is shared with our group, that is the theater nurse. We have OT technicians, both anesthetic as well as rest common OT technicians.
Wow.
So they know exactly what to be kept.
What we are doing. Okay.
So for suppose there's a case of angiofibroma taken up. So even without telling in advance, they'll see that they'll keep balloons. They will see that the blood part of it is arranged. All the things go automatically. So we just have to walk in and ask, and they'll say everything is in order, everything is in place.
Scissors. No, that is there. But then I'm talking about, see, when I said scissors, ready, then she...
They say ready and give it to you, or it's ready?
Already given to me. When they say ready,
that's super.
I just have to pull my hand and it's on my hand. So that training, I think that Shilpi usually trains all the residents to say
really
ready is here, ready. So actually it boosts the morale of the whole team actually.
I agree with you. It's really nice.
So that way, I think that is one very nice thing I love in my theater. I have 4 tables, all the 4 tables saying ready. Wow. I love it.
Sometime I'm going to show you the radio frequency.
Sir, I've already seen it.
You know why?
Yeah.
Because the number of wands that you're using and all that,
okay.
I cut short on my wands because of radio frequency.
What happened?
It's so addictive, coablator.
Oh, very addictive, sir. Very addictive. Once you start using it, you become dependent on this.
Have you tried the nasal wand by Bonds?
Of course.
Nasal wand, that is?
Similar to the Precise.
Now, the nasal wand of Bonds is 3 millimeters.
Yeah.
Whereas the tonsillar wand of the Bonds is 4 millimeters.
Okay.
And this 3 millimeter one is really very malleable and good in the nose.
But I'm telling you, sir, they are bringing wands for the ear.
Yeah.
I saw the Rosens and the plasters being used with the coblation. I don't know what's going to happen to ear surgery after that. Believe me, that's going to be scissors. A revolution in ear surgery. At least people doing endoscopic ear surgery. Of course, I don't do that. Okay.
Join the club.
I
said join the club.
You do it, no, sir. You do
No, no.
endoscopic, right?
Endoscopic is only when there is, I would like to visualize the sinus tympani or a facial recess area. And sometimes if there's a minimal work to look
Tanni
into the
kudumma.
attic. Otherwise,
Ah.
I love my microscope.
Ah. Oh, so you have the endoscope ready. Somehow I never got trained with the endoscopic ear surgery. I don't know. And Anthony keeps scolding me. Mohan Reddy sir is here, huh? Mohan Reddy garu. Tip clean. Mohan Reddy garu. Pioneer in endoscopic ear surgery in India.
He has not come today.
Oh, yesterday he was there. Hey, Tanni. Aldipur sir. KB. चले गए क्या? Oh, okay. So, how come Dr. Nageshwar Rao Garu is completely silent today?
Sir.
You didn't eat, ah?
No, sir. I'm there, sir.
You didn't eat,
No,
ah?
sir. No, sir. No, sir. I'm
I will
there.
ask son to give you some sweets, boss.
Sir. Our senior teacher is speaking, sir.
He ate more.
So that's the anterior piriform aperture.
Sir.
Now what I'm going to do now is I'm going towards the IMAX elevator.
Sorry, boss, I had gone to pick up my soup. Thank you.
Sir, that 2 minutes I missed you, sir. Huh? Like a lover is missing.
Oh my God.
That's a very nice relationship.
Let's be happy, not gay.
Hold. Sir, Haldipur sir is such a sweet person, sir. I hope his wife is not seeing the comment.
I had the privilege of spending time with both of them. In, which place was that, Deepak? Tiruvananthapuram? No. In Kerala.
Kerala, yeah. Calicut.
Calicut, I think.
Yeah. Calicut.
And he has a wonderful sense of humor.
Yeah. Madam also, she's a lawyer.
Deendayal sir.
Yeah.
In Telugu, there is a saying.
Chappo.
Aivariki vidyemu ledu, garvamu ledu.
Sir, repeat in Tamil or English.
It means the bloke doesn't have much knowledge. Obviously, he's also not arrogant.
No. That is wrong. Did you see the intraorbital nerve I showed?
Yes, sir.
Intraorbital nerve.
Yes, sir.
I showed that, no?
No.
That's the intraorbital nerve here.
Yes.
See here. Okay?
Yes.
See the Asan Masan, you can see that small nerve here. You can see that very beautifully.
Yes.
Okay, right. I'm going to start my drilling. My plan was, number 1, to do a Hadad flap. Number 2 is to do a Denker. So that's exactly what I'm practicing here. And third will be a septectomy. And fourth will be a sphenoidotomy. Drilling off the sphenoid. Then I will go in for the clivus. So this is the attack. I will leave behind the ethmoidal one for the final assault. Okay, again, I'm not doing a 2 lateral osteotomy or a 2 inferior osteotomy. Just I need an access to the IMAX. That's it. Like yesterday only. Not a very big tumor. Okay. Suction block. Suction block. Now I have to get the nasolacrimal duct. Drill.
I heard the word ready.
Yeah, sir, you will hear a lot of readies when I'm operating. One by Shilpi, one by Lakshmi, one by my staff. So I just have to pull my hand out and everything comes there. So somebody asked me, how are you able to talk during surgery? Because I don't have any other job.
Yes.
Everything is done by these people. I have to jolly well keep talking.
What is your left hand doing?
My left hand is holding my suction.
So you have both the drill and suction in your hands.
Yeah.
And one
Shilpi
of
is
them.
holding. Hey, can you give the external camera
Yeah,
picture,
external
please?
camera is there, sir. Right, just endoscope.
Shilpi.
Nobody can hold like stable.
Population.
Yeah.
So
Now,
this is not 4 hand, but this is 6 hands.
I have the luxury. That's why.
Now I got the whole picture. Hey, now I'll say that it is a 6 hand job. It's wonderful, wonderful.
Hey, Tanni kudra.
Allah, artery
I know. Hey, coagulation not working.
Seeing experience.
You have a precise max with you?
No, sir. This is EVAC 70.
If they have one precise max, ask for it. That will do a wonderful job.
Yeah, that will do definitely. But the thing is, they have provided it free of cost for me for the workshop. All these patients are free, done free of cost.
You can ask those arthrocare fellows to give you precise max instead of EVAC 70.
They will give me a big bill also. Scissors, please. Which I can't pay.
So Shilpi, you stabilize the camera with your left finger, left hand.
Hey, Shilpi. Can you give a mic to her?
No, like your left hand, what is it doing on the nose?
I stabilize my scope.
She says she stabilizes the scope sometimes.
Exactly.
So that's what she's doing. And Lakshmi actually is irrigating from the other side. And if she is having a little, she becomes tired, I have Shivakumar washed up, ready to, be the next assistant. Yeah. Now, Blexley. Now, coagulation, please. Hey, suction is not working. Coagulation pare.
Will be there in December.
अरे क्या हो रहा है यहाँ पे? Suction करो. Coagulation ready पन्ना. Pack. So I expected the polyp. Did you see in the scan also? There was polyp in the maxillary sinus.
Yes.
Very clear. Same thing I'm having. Coagulation. Yeah, I saw that in the. Hold man. Hey, Tanni suction coagulation work Sir, but one thing, sir, Professor Deenadayal, sir.
Yeah, Janki.
Sir, you get this luxury, like I travel in your car. I would never travel in a Maruti. This is luxury personified. 3 people assisting, and you don't hold that camera.
Actually, I'm telling you, it's such a beautiful coordination and it's so well done. It's because of the teamwork you can confidently say 2 hours. If somebody had asked me if I'd started something like this, I don't know when I would have said.
This is purely a teamwork. Always when there is a intraosseous bleeding, if it is going to be a spotter, use the ablation mode. Don't try to keep on using the coag mode, blue. Don't do that. It will never stop. So when it is coming from inside the bone, straight away use the ablation mode. This is just for the sake of juniors. Of course, the seniors will know it. What? Okay, so I've defined the posterior wall of the
maxillary sinus.
Maxillary sinus very beautifully. Now I'm going in for the isolation of the IMAX. And for that, always get this area. This is the area which is the junction of the perpendicular plate of the palatine bone. This is the perpendicular plate of the palatine bone, this one here.
Yes, sir.
And the posterior wall of the maxilla. They see this area, if you don't delineate, this is the hardest part of the maxilla. The medial part and the lateral part are the hardest. In between, the posterior wall is thin. So, if you want to drill this, you have to delineate this area very clearly. So that is where, this is where the DPA comes. This is where the SPA comes. Okay, this is the thinnest part. Here you can catch the IMAX, but you cannot remove this bone. If you can't do that, then you cannot go for trans-pterygoid approach. So all this you should keep in mind. Okay, right. Give me the drill now. Is it clear? The picture is clear?
Very absolutely clear and very well seen.
Okay, ready? Sometimes what happens, you know, the second assistant, the first assistant, Lakshmi or Shilpi, they just go and first of all lodge themselves. Are ye mera jagah hai? And then finally the surgeon will not have any place. They will say, no, this is my place. Already I have caught my seat. First row, second row, like that. Drill, please. So here, very important. See, that's the junction of the roof and the posterior wall. Don't go low, go high. Only then you can hit the inferior orbital fissure. Okay, this is very, very important. When you go, you drill like this, not like this. There's a small difference. Go at 60 degree, not at 90 degree. See here. Now see, that is the way. This is what it's called. Irritation. Lakshmi, no. You never irritate me, man. You're my darling. See the kind of irrigation. We always call the irrigation as the last piece. Sorry to tell you this. In front of the girls.
Got it.
It should be intermittent. It should not be forceful. These are all the basic principles.
Excellent.
So here, when I drill here, no, I might accidentally open the greater palatine canal, which is this is the anterior
bony covering of the glycopalatine canal. I might accidentally open it. In case I do that, I will have a bleeder. You should, so this you should already encounter, already anticipate. And then if it's there, then you should be ready with your coblation. So all these are what is called anticipatory techniques. You anticipate. Before it happens, you anticipate. That bone I told you is thick, right? It involves more drilling than the part here. Suction block. Come. Suction है. Cat's paw. Okay. Now cat's paw, please. Okay, here we are. I'm going to remove this bone.
Is that an instrument designed by you?
No, sir. This is the back of the Freer's elevator. For the sake of understanding for my staffs, I call it
Cat's paw. Okay,
Of course.
That's your
Yeah.
code name. Code name for that.
Just for making my people understand. Come out. Up. Okay, now that you have seen that, the most important part is to identify the IMAX and to ligate the IMAX. Now, before, come out. Give me a coblation. See, whenever there's a bleeding, use the suction as a stent. See here. I'll just show you. This happens to everybody. See here. See that? Bleeding, right? So nothing you should not go and do packing. See here. I use my suction. I press. See that? That's it. Finished. See, you can see the ooze there.
Yes, sir.
Now use your coblation. Do whatever you want. Bloomer. That's the region of the exit of the sphenopalatine artery. Very clearly seen. Okay. So here the sphenopalatine artery divides into 5 branches actually. Okay. Now having done that, now see here. Now where will be the IMAX? Go closer now. Now see here. That should be the IMAX. Here I'm going to use the yellow. See here. See that. Exactly on the IMAX I did it. Let's see how the bonds works now. What, boss? Are you convinced?
Wonderful.
Give me the no. Give me ball probe. Ball probe, Daganne. Okay, I'm just going to take off the clip.
Yeah.
You clip. Hold.
Holding, sir. Holding.
Go inside, my dear.
One more clip.
One more clip. Can you see?
Yes, sir.
Always remember that the IMAX is, if you draw a line from 1 second. I'll show you that. Wait. If you draw a line from superior to inferior, always remember you will not find the IMAX in the middle. Find it superior. It's very close to the infraorbital nerve. You should understand that very clearly. Don't search for the IMAX down. Of course, you can have a branch, but the real IMAX will be superior, not inferior. This is dictum. Okay, these are all branches now. Okay, now see here. This could be the descending palatine. Going towards the descending palatine canal. See how big the branches are here. Hold. These are all because they are supplying the hemangioma. Give clips. Can you see, all of you?
Yes, sir. It's beautifully demonstrated. We are enjoying every part of it.
Sir, all your teachings only, sir. What new we are doing, sir? One more.
I am learning a lot.
Sir, don't tell me. Give. No. Clip. Clip. Give me copulation now. Now what I have to do is to define the pterygoid wedge. Now get ready.
Long pack ready.
Use always the clip has come out. Go closer.
I think the last clip
Was loose, no?
Yes.
See, whenever you do know, there is a small trick. You go like this and you press, you will be on the bone. What bone is it? Pterygoid wedge. Okay, just go like this and then you sweep your corblator towards the palatine bone. Later, now I can't do it. Can you see the pterygoid wedge, please, all of you?
Yes. Clear, absolutely clear.
Small tricks. That's the median. See here. That is the intratemporal surface of greater wing of phenol. So what is this muscle? This is the lateral pterygoid muscle. What is this foramen here? Can you see V2?
Yes.
Hello?
Yes, sir.
See the V2 there. Come on. Is it clearly seen?
Clear.
Yes, sir.
That's the communicating branch between the V2. Yesterday I demonstrated that.
Yes, sir. Yes.
Between the V2 and the median. You see, is it the normal pterygoid wedge? No. It is enlarged. You see, this is the enlargement of the wedge. You never find a wedge so thick. See, the osseous enlargement is due to the intraosseous
Hemangiomas.
hemangiomas. All this containing all that. Now we are going to really fight with the blood later. Of course, till now at least. Now see how many clips studded with clips like earrings. Give me a pack. Okay, now I am finished almost the first most of the surgery now. Now I have to directly jump on to the clivus. As I told you, I'm ready for the clivus now because I have ligated the IMAX. In fact, I ligated the SPA, DPA very clearly. And in fact, they were not normal in size. They were very big compared to the, hey, cut it, man, not this. They were not the normal size. The pterygoid wedge also not normal size. Everything is enlarged. And pterygoid wedge contains marrow. It contains marrow. If a hemangioma is there in the marrow, I'm expecting venous blood along with capillary ooze. So that can be controlled only by Surgicel. So we should remember all these points. Now I'm going in for the middle turbinate resection. Give me a scissors. Thank you. I am not expecting bleeding here because I have ligated the. So I am not going in for that which Professor Dinadayal sir said, that hemangioma above, not now. Later. See, there is a bleeding here. That is the old blood, old blood. That means he has bled. I have a beautiful protocol for epistaxis. I only wish that we do one conference just on epistaxis. Believe me.
That will be great. That will help a lot of people. And I also have a few ideas pertaining to that. It will be great to have that.
Sir, we'll do it together, sir. Please, sir.
It will be great. We'll work out on that.
Yeah, please, sir. Because many people in the medical colleges, everything are taught only packing. And in our center, till date, we have never packed. Now we are almost on the tumor, my dear friend. Anesthetist, get ready. Now I will tell you when you have to start. So we have never packed a single case, post-nasal, antenasal, nothing for epistaxis. So we have a completely different protocol. In fact, one day, one of my fellows from Hyderabad, there was a case of epistaxis, sir, I packed it. I got so furious. I said, hey, what did you pack? Then he said, sir, I don't know the protocol which you follow in Royal Pearl. I said, boss, don't worry, next time I'll teach. I've still not taught him. Hey, suction. So I want to elaborate on protocols for epistaxis. Actually, they're all old protocols. This packing and all, pre-endoscopic era. Where there are no endoscopes, they used to pack. Now, why we should pack? We don't have to pack.
I think that's a good idea. We'll work out on that. That will be a great help to many people.
Yeah, juniors, especially the juniors. What to do when the patient comes with each hypertensive epistaxis, whatever. I mean, some condition. What should we do?
A classical algorithm can be made.
Yes,
depending on something like
Lovely.
one-sided bleed, both-sided bleed, anterior bleed, posterior bleed, comorbidities, age of the patient. All these things would a little bit on history.
Yes,
I think it will be great to work out on that.
Yes, sir. Please plan it, sir.
And facilities available. It's correct.
Count me in.
Exactly.
No, that side Hadad removed, no? No Hadad, this is. Phenopathine is gone, no? What you will do?
Sir, what is Janus plap, sir?
What is what?
Janus plap.
No, I'm not doing a Janus in this case, but of course, Janus means a small Hadad on one side, bilateral Hadad with one small and one big. It's called the Janus flap.
Sir.
Of course, we see there's already, see that clivus.
Yes, sir.
Okay. Let's see. Give me another cobulation, please. I want to resect a larger part of the septum because my plan is to do a draft free as well. हाँ पहले देखेंगे ना, अब नहीं करूंगा. क्यों आप डर रहे हो? अरे क्या हो रहा है? इतना क्या? அரே தண்ணி தொடா ஒண்ணுமே எல்லாம் பண்ணிடுறானுங்க. See, now they have totally stopped. கம்மினா ஒண்ணுமே இல்ல. Okay, right. Now, right. Now I am ready for my final kill. So here we are. I'm now, that's the Denkers done. That is the packing done on the left side. That is the rostrum exposed. That's intraosseous. So what should we do, juniors?
Ablation.
Ablate. Tanni. Tanni. Give me. Irrigate, please. Okay, I'm going to start my septectomy now to expose the clivus. Sir, so far any questions, sir? Deendayal sir, Deepak Haldipur sir, Nageshwar Rao sir, Anand Acharya sir.
No
Give me
questions. No questions, sir. We are waiting for the final.
We are just looking for the answers.
With bated breath.
That is why I'm asking now itself, because I don't know whether I will continue.
So far, so good.
Yeah, correct.
And they say well begun is half done.
We can't say that.
Scissors, heavy scissors.
Heavy scissors. Heavy scissors.
Ready.
Hold.
Suction.
Hydrogen.
Oblation.
Ready.
I'm scared to go this side also, because that's the area where. Okay, right. We'll see later. Oblation, please. Okay, I'm going to start my.
Spinal phase.
Septectomy.
I'll get one more combination ready.
Yeah, get one more coblation.
One more combination ready.
Get two coblations, 2 once. Usually what I do is I have three coblations in the theater, in each theater. So if one coblation goes off, another one. Same way, microscopes 3, spice cameras I have 3. So that backup even if one fails, because the patient is a patient. I cannot work with just one, and suppose it goes off, what will happen? So we have three of everything. This is how we work in Trichy also. Okay. Give me a tuck, please. Suction. Hold. Tuck. Madam, I'm going to start my drilling now. No, not yet. The lesion I have not yet reached. This bleeding is just mucosal. 1 second. Come out, Shilpi. Tuck.
Ready, sir?
Tuck. That's the pterygosphenoid synchondrosis, and
Yes,
that's the palatovaginal canal. You can see palatovaginal canal very beautifully.
Yes.
Superior turbinate. Okay, come out. Okay, right. Now I'm ready. Give me a Blexley. I'm going to take that out and start drilling now.
You
I'm
are
going to
going to do
expose.
shoulder osteotomy, sir. You are going to do shoulder osteotomy.
Yeah, triple osteotomy.
Yes.
Okay, here we are. Okay, first I'll do the planar osteotomy. Give. Drill, please. That is the planum. Drill mode, please. Yeah, thank you. Hey, can we have AC in the theater? I'm feeling like, already started sweating. Somebody put it off. No, make it the coldest because I'll be having heat. Sir, are there little crowd in the audience or zero?
No,
No,
there
sir.
are lot of people. Lot of people there.
Lot of people there.
Okay, what are the divisions of the clivus? We should know that because what part of the clivus are we going to deal with?
There
in
are
this
three
case?
divisions, sir.
So there are the three divisions of the clivus. Good.
Yes, sir. From the dorsum cilia to Dorales canal.
Correct. That's the upper clivus.
From Dorales canal to jugular foramen.
Correct. That's the mid clivus.
From jugular foramen to hypoglossal canals.
Perfect. Super. Who is that?
Nageshwara, sir.
My God. रट दिया आपने, रट दिया. कसम को रट दिया. Now that looks to me like the mucosa.
The sixth nerve is having long course and traversing through the all compartments, sir.
Yeah. Now, copulation, please. Now, what I'm going to do is to delineate the posterior ethmoid a little bit here on the left side. I'm a little scared because I don't want to touch that hemangioma part. Go closer. This is all blue. Blexley. The most important thing you have to do in a sphenoid sinus, whenever you operate on the sphenoid sinus, is to get the planum. Unless you get the planum, do not do anything to the sphenoid because the planum will give you an idea of the optics and the optics will give an idea of the carotids. So unless you get these two, don't go for clivus, don't go for anything for that matter. I'm not at all bothered about anything else except to get the planum. Drill. So I know that's the planum here. I've already got a little bit of the planum. Drill. See, there's no anatomy at all. From here, how do we get anatomy? That is the key now. Go up.
Janaki, a question.
Sir, yes, sir.
Role of navigation at this juncture.
Of course, sir. You're absolutely right. I would definitely go for the navigation. I have the navigation, but then somehow I've been trained.
I know that you don't.
But I fully agree with you. If you have the navigation, please use it. Don't do it like what I'm doing now. This is not the right way. Of course, because of the cadaver dissections, we've done more than 180 cadavers now.
Wow.
So the moment I can just tie a kerchief and do this sphenoid. So that's because of the cadavers. Give me a suction. No, sorry, Blackersley. Blackersley and a pack. So, and especially what I used to do is I used to go to the obstetricians, get hold of stillborn babies, and used to do sinus surgery and brain surgery for them. That way I learned a lot of this art of drill, quick. Now I am now going very close to what I expect to be the. Yes. Now what I will do now is pack the nose, get the lamina papracia. Very, very important. Pack the nose, pack the sphenoid, get the lamina.
Post-rhythmoid artery area, sir, please.
Come again? What?
Post-rhythmoid artery, please.
No. Now there's nothing. No landmark ball.
Plenum.
If you leave, you're losing something. This is something which you will never see in your lifetime. Go. Blackersley. Blackersley. Don't go now. Cancel it and go tomorrow. என்ன ட்ரெயின் தானே வாங்கினா போச்சு. You got a case? அதான் போதும் என்ன பெரிய கேஸ். ஒரு செப்டம்பர்ல டான்சில் வச்சிருப்ப. இல்ல அப்படி இல்ல சொல்றேன் நான். They love you, man. Give me a drill.
So she has to go all the way to Trichy now?
No, Chennai. She is practicing in Chennai.
Okay. So நாளைக்கு early morning train la போங்க. I mean plane la.
பாத்தியா எவ்வளவு ரெக்கமெண்டேஷன் வருது பாரு உனக்கு. சாருக்கு தமிழ் தெரியும். Okay, give me a debrider now quickly. So that definitely is the planum there. There is no doubt about it. I'm just going to trace the lamina papracia. See, the most important point again and again and again and again I want to insist is get your landmarks. Get your landmarks. Don't operate without landmarks. You can see the lamina there. Can you all appreciate that?
Yes, clear.
There was a little polyp, so I couldn't get the lamina. A fist has been done. Maxillary sinus has been opened on this side. It's okay. Now that's the. Can you see the anterethmoidal artery there, all of you?
Yes, sir. Now the planning is explained.
On the scope. Yeah. Right. Now I got the right plenum. So I have, hold. I have a beautiful landmark there. With that, I will start tracing the carotid artery. Can you all appreciate the right plenum, please, all of you?
Yes, sir.
So that's the plenum here.
Yes.
So of course, I don't have the panoramic view of the sphenoid sinus because left side, as you know, was very filled with the hemangioma. So I don't want to go that side. I want to avoid that. Hey, illada, drill da. So now what I'm going to do is to get the carotid on the right side. I'll get the carotid. Go closer, please. Something on the drill. Something on the drill. Now I'm trying to get the dura there. Indial sir, is the picture clear, sir?
Very clear, sir.
Drill.
Very good picture.
Hey, there's something on the drill, I think, man. Oh, yeah. Go closer, go closer.
So beautifully delineating the plenum.
That's the dura. You can see the dura already.
Right. There is a talk here, Janki, that you use the word called like a paintbrush.
What? Like what? What,
Like
sir?
like a paintbrush movement.
Ah, correct. Can you enlarge? Can you enlarge, please? Yeah. Go closer. Go closer, please.
ICL on the
Is there something on the drill? No. I'll try to take off what this is. Give me a ball probe. Ball probe. Yeah. Can you see the optic here?
Yes, sir.
This is the optic.
Yes, please.
Yep.
The supraoptic recess go inside. That's the dura. Can you see here?
Yes, sir. Elbows here, sir, here.
You have a lot of mischief, boss. I'm searching for anatomy. You're asking for LOC here. Nageshwar Rao, sir, always mischief only. So that's the optic. That's the only anatomy I've got now. Hey, can you see the dura here, all of
Yes,
you?
yes, sir.
That could be the peeping of that. Go closer.
Yes.
You see that? I will not touch that right now. Let's see, let's see. Okay, very, very super interesting it's becoming.
Yes.
It's more than a James Bond movie.
All the audience are breathless, sir, at this moment.
Boss.
Yeah, breathless, sir. We are breathless.
Drill, 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 drill. You know, good thing is, see, neurosurgeon, 2 cases of this workshop were referred by neurosurgeon. That's so good. Neurosurgeons are recognizing that, okay, fine, these guys can do it. I'm very proud of my specialty.
A neurosurgeon referring a case to you is a feather in your cap. The reason is very simple. If there is any surgeon who has the highest ego or the biggest ego,
Yeah, you're right.
he is the neurosurgeon. They have the biggest ego.
Do you know this joke, sir?
Tell me.
Sir, do you know this joke? Can I tell this joke?
Please tell.
Okay, there was a meeting in Atlanta, and it was a general meeting, a party. And one person, there's a big party in which many people had assembled, and one was a chief chef, chief cook.
Yep.
He said, I'm a cook in somewhere Atlanta. Another person said, I am working in a bank and things like that. There's one Dr. Smith.
Yes.
And he said, I am a neurosurgeon.
Yep.
And then he shook hands, like, giving the hand on top.
Yep.
You know that gesture, right? I am a neurosurgeon. And then he went on to everybody and said, I am a neurosurgeon. I am a neurosurgeon. I am a neurosurgeon. And everybody, wow, neurosurgeon, wow. And then finally he came to a guy and said, I am a neurosurgeon from Atlanta. And that guy said, oh, that's very good. Then for that, may I know what you're doing? He asked, I'm a neurosurgeon. What are you doing? Oh, I am just a scientist. I leave rockets in the NASA and we are planning to conquer Mars. He just after that he went and sat in the corner. I'm sure you would have heard of this joke at least.
Oh yeah. And actually, I think there is a play in that also, a British play, wherein this type of a joke has been shown. Wherein one person walks in and keeps on introducing himself, and finally there's somebody who,
We have heard this joke, but only thing is we have not heard this being narrated when somebody is dissecting near the optic nerve and clivus. We have not heard
I know. Come out.
somebody narrating this joke when he is drilling near the optic nerve and clivus.
Sir, don't remind me, sir. I'm trying to deviate myself and you're trying to bring me back to the surgery. This is the midline, my dear friend. Now I'm going for the dead center clivus, the mid clivus. I'm going to find the lesions now very shortly.
This part of the clivus itself bleeds, isn't it?
See, can you see? Go closer. See.
Yes, sir.
Biopsy bottle ready.
Hey, biopsy bottle ready. Drill. All these are intraosseous hemangiomas. Hey, get the coblation, second coblation ready. Hey, coblation one, surgical one. Now we'll be encountering. Hey, show me. Huh?
Is this midline?
No, this is the midline. Here. What a case, no, sir? Deepak ji.
Yeah.
My God. No words.
That's why, when Nageshwar Rao said, I wanted to add one more word. The audience is spellbound. Generally, Sunday afternoon with a meal at Hyatt, difficult to stay awake. But this case, and you are narrating a joke, other mala.
This is the optic now here.
Yes, sir.
This is the clivus intraosseous hemangioma started already. Now I am not going on to the other side because I don't want to touch that big hemangioma intracranial. But of course, I am defining the sphenoid. No anatomy at all. I said, absolutely no anatomy. I will completely define the sphenoid, every bit of the sphenoid. He was asking LOCR and all. I'll do that. Hey, suction box. Suction. Quick. Now you will encounter bleeding. The best way to control it, intraosseous hemangiomas, is don't irrigate while I'm drilling. It is the same like how you do for the mastoid. See here. See the bleeding already which has started coming. It's arterial. Can you see that?
Yes, sir.
This never comes in a venous, only comes there. See, once I irrigate, once I do, what happens? It stops. Did you see? Irrigate now. Irrigate. Suction. Oh, sorry, Blackesley. Quick. Now somehow I have to get the carotid or else I'll get lost. I have to get the carotid now.
Sir, are you using vascular Doppler, sir?
I have. Wait. I'll use it. Not now. Hey, show me the optic. Give me a... No. Ball probe. See and assist. Hey, give me a Blexley. I want to take a biopsy. Wait. Take a biopsy now. This is an hemangioma. See, all these are kuti hemangiomas. Go closer. Biopsy. See how it's bleeding.
Yes, sir.
Drill, quick. Hey, you should be very fast now. There is no question of, hey, suction block. Hey, get me 2-3 suctions, get ready everything. Get all the suctions into the theater. Okay, ready. Hey, all of you concentrate now. Hey, drill. Hey, drill not working, man. That's a carotid artery. This is a carotid artery.
Yes, sir.
Drill not working. Drill not working. Okay, now I am delineating the carotid artery. Irrigate. See. Can you see?
Yes.
This is a cellar. Wow, beautiful. Now that's a LOCR. Give me a Blexley or a. That's the optic, that's the carotid, that's the cellar. I am getting all the anatomy now. Beautiful. Hey, illada, idra. No, I'm sorry. Ball probe. Quick. See, that is the. See, this is the cellar here. This is the optic here. This is the carotid here. That is the LOCR here. Oh, closer. Oh shit, that decent, man. Hey, give me this one. Doppler. Hey. Doppler, please, quick. Quick Doppler. My God, that was completely decent.
No.
Can you hear?
No.
No.
No. No, sir.
No, wait, you keep the mic. Keep the mic. Outside mic. No, in Zoom it doesn't come. Yeah, there's some problem. We always face this. High frequency noise doesn't come. They filter the high frequency noise. There's a called the high frequency noise filter. Hey, give the mic, man. Give the mic. Quick. Anyway, I got one anatomy. Very important anatomy. Hey, can you have this external camera voice? See.
I think there's an issue with the sound system.
Can you hear?
No, sir.
No issue. If you're able to hear, it's fine, Janki.
How can they not hear? Boss, try to do something, boss. Drill. Drill. Huh? No, don't worry. Nothing will happen. Hey, get that noise out, man. I want that noise. Hey, can you get it? Playing for me? My dear? Not possible. No. Last time Harsha did. Hey, Harsha is there in the audience, huh? If Harsha is there, he'll get it. That is Harsha. Suction.
Sir is not here, sir.
Oh, madam. How are you, madam? Oh, thank you so much, madam, for coming. Madam, let us all give a big hand for madam. Sure, ma'am. Thank you so much, madam. Thank you so much for coming. Son, will please arrange for the transport, my dear friends, for madam.
Yes, sir.
No, inferiorly. Hey, can you get that Doppler sound? Because I want that to be heard, man. Because the Baszler also will be seen now. Hey, boss. Or record it, boss. Record. Hey, boss. Audio visual. Hey, you're sleeping, huh? Hey. Record it on a phone, boss. And record it on a phone. And transfer it on the this one. Wait. I'll keep it, record it on a phone now. You have a phone? Give. Doppler.
Yeah, we can hear the sound.
No, you can't hear.
Yes, sir.
Yes,
Yes, sir.
Yes, we got it.
Very beautiful.
Can you hear?
Yes, sir.
Crystal clear,
Beautiful.
absolutely. Good.
Okay, now what I will do is I'm going to define the other side sphenoid. I'm leaving behind the superior part. I want to define this side carotid artery. Don't keep this for biopsy, they'll give a bad report. They'll say clots.
Now the blood is on flow, sir.
What?
Now the blood is transfusing now.
No, why? Till now there is no.
No, they're transfusing.
Till now not much blood loss, madam.
Yes.
But ये HB10 है सर एकदम लूज करेगा तब करेगा.
पर अभी तक कुछ ज्यादा नहीं है ना, फिर क्या? See, that is the area where you have the hemangioma. Can you see?
Yes.
Wow, see, intracranial hemangioma.
Yes, sir.
Oh, wow. Now, that's the intracranial hemangioma. Cobblator, please. Give the cobblator, please. Give. Somehow, I have the gut feeling that I can cure this guy. I don't know. Something tells me. Hey, coblation. Sun Pharma. People are there. Sun Pharma.
Yeah.
Sun Pharma are there.
I should tell them about Madhuri Madam
Lakshmi,
transport.
if they can arrange for one, because I need her now.
Huh?
No, you tell Sun.
What do you
What do you
arrange
need,
it?
sir?
Yeah.
We need one ticket for her tomorrow to Chennai morning.
Yes, sir. A Sun Pharma person is here. He will arrange it.
No, as he assured.
Yes, sir.
Okay.
Mr. Mohan is saying he will do it, sir.
Oh, Mohanji is there means what? No, but I don't want to take advantage. But you see, she is very necessary now. See, this case, if suddenly it starts bleeding, eating and all, no, I can't manage. As Dr. Dino, hey, shush.
Pack ready.
Pack.
Ready. Surgy flow, surgy cell ready.
No, don't do anything. Just hold on.
Ready, sir.
कुछ भी नहीं करना.
Whenever you need, we'll give it to you.
Cut it. That is right from the carotid artery. Give me a surgery cell, man.
इतना बड़ा नहीं चाहिए.
Go closer. Shit.
You want muscle, sir?
Hey, give me muscle. नहीं आती भी नहीं Can you give me a smaller pack? Give me a smaller pack, please. This smaller pack. This small pack. Cut it. Give me a drill. Boss, come out, boss. Now you just listen to what I say, okay? Nobody talks here. Nobody's going to talk. You have a neuro lint? Do you have a neuro lint? Okay, drill. Quick drill. Now, come on. Hey. Shilpi, you do it, man. Go closer. Suction block. Just have 2 suctions of water. I don't want you to change the suction. Irrigate. Sir, are you able to see the picture, please?
Yes, yeah, very much, very much. Clear. You are seeing it clearly and in all attention.
Go closer, go closer.
Sir, I can't do
Lexley.
Ready, sir.
Hey, keep surgery cell. Go closer, my dear friend. You can't. Drill. I don't. Drill. Hey, clean this. Clean this.
Hey, clean this man. That's why I said I want a neuro lens. இருக்கா குடு 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 நியூரோ லென்ஸ் குடு. Lexley. Deepak ji.
Yes.
Keep talking, keep talking. Why are you all silent?
Seriously watching, sir.
Be happy that we have not gone to the toilet.
Actually, we are talking, but we are not including you in that.
What?
We are actually talking, but we are not included you in that. That's
Why?
all.
You talk. You talk. I will get. I mean, if I can be included, I am ready to answer your questions.
Sir, no picture, sir.
No picture. Ah?
Yeah.
Hey, 1 minute, just hold it, Janki, if you can.
No picture. Ah? Drill, 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 drill. No picture. Ah?
Now
Now
it's
we
there,
got
sir.
it. Now we got it.
Ah?
Now
we
it is
got
there.
the picture.
Defog, defog. Are you getting picture or not?
We are
Yes,
getting
sir.
picture.
Hey, you got the muzzle or not, man? You better get just the muzzle. Don't, later will do. Don't close it.
Normally, the muzzle is taken from where?
Quadriceps.
Okay.
So all intraosseous hemangiomas. Deepak ji,
Yes, boss.
are you there or not?
Very much.
Why I can't hear your sweet voice?
No, me and Dr. Sam were talking to each other. It's just that we don't want to distract you.
No distraction. Keep talking.
I don't know. I felt the distraction made you open up the carotid on the left side.
No, 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 sir. No, sir. This is not the carotid. It is a feeder from the carotid to the hemangioma.
Then it's wonderful.
See, every hemangioma, if you do this one, no, the DSA, small feeders need not be picked up by the DSA.
Actually, that was my first question when I asked you in terms of
Yeah, you told
angiography.
me. But see, sometimes, you know, I went and saw.
See, Janaki, even for the most constipated surgeon, the best laxative is this bleeding.
What, sir?
Even for the most constipated surgeon, the best laxative is the operative site bleeding.
Why? Nothing. There's nothing like that. Sir, if a surgeon is going for diarrhea during surgery, then he cannot be a skull-based surgeon.
Yeah.
He can be a stay-piece surgeon.
Sir, out of interest, this question I'm asking you, sir. If there is
That's
some,
a
will
Drill,
you
drill,
go
drill.
from here? Can you go to the middle ear, sir? If we leave you,
Sir, but there is no indication.
He can go next to the carotid. He can go. Peter's carotid.
Yes.
He can go.
There is no indication for that.
yeah, yes, sir. Not in this case.
Go closer, go closer.
In his language, எங்கேயாலும் போக முடியும். எக்கடானா போச்சு.
Can you see the clivus here, all of you?
Yes, sir.
The normal clival bone.
Yes, sir.
Drill. See how beautifully the clivus has been delineated. And that's the paraclival carotid here. Lexley. All small hemangiomas sitting on the carotid canal. See, that's the carotid canal. Give me a pack. Give me a pack. Okay, now let me go on to the area of interest, that is this one. Give me good irrigation, please. Stop. Give me a curette. Go closer, go closer, go closer. Curette, please. Curette. Got the muzzle, huh? Got the muzzle? Okay. Okay, give me the curette. No. Curette kudra. இதான் எனக்கு பிடிக்காது. சரி வா 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 இது ஓகே. Let me just check the lateral recess. Okay, I think I've done good justice except this side. That is where the bleeding was coming from. Ma, give me a Doppler now. Wait, come out, come out. Come out. Where is the pterygoid wedge? Drill the pterygoid wedge. Ah. Yeah, we have drilled it. Come out. So that's the hemangioma. Drill. Drill, drill. I'm now going to drill off and uncap that hemangioma. Huge one. Which is sitting right on the carotid canal. Can you see that, all of you?
Yes, sir.
Go closer. Can you see the Vidian now there? Vidian, here.
Yeah. And that is our guide towards carotid as well.
Yeah, it points toward the carotid, and that means this is sitting right over the carotid. This
Yes.
lesion is sitting right over the carotid artery.
Yes.
Okay, now what I will do is I'll just leave that lesion right now. I'll just come to it last. Okay, I'll finish off the skull base lesion. Give me another. No. Give me some muscle. Give me little muscle, not much. So what you do with the muzzle is that you just take the muzzle. This is not enough, man. Just mince it. You understand? Mince means just keep crushing it and then place it. Okay, right? Give me a small pack. We'll do it later. I'll come for the superior quadrant. Can you understand what I'm trying to do?
Yes, sir.
Yeah.
Now what I will do now is to finish off the skull base hemangioma and then go for that last one over the carotid. That's the planum. That's the optic. So that's the hemangioma which I have been talking about inside the brain. Give me now. Yeah, no, I'm just going to see. Dura I think is intact. Drill. Now let us see. I'm going to drill off that bone, the thick bone, and I'm going to elevate that hemangioma. Let's see. Hey, get ready with bipolar, man. I can't use the cobbler on the dura. Ready, drill. All of you ready?
Yes.
I think the hall is empty, huh?
No.
Sir.
Boss, to get such a case is like, what can I say? What, Deepak ji?
Yeah, very much. It's like the last 8 balls of that T20 match 4 days back.
No, what I'm trying to do is to define the lamina paprasia and to get that junction between that lamina and that small hemangioma. Okay, that's the hemangioma, I know. This is the one. This is the one.
Yes, sir.
This is the mucosa. Can you see that lesion inside?
Yes, sir.
All of you.
Yes, sir.
Very well seen. Would you be taking a biopsy from there?
No, I'll take that whole lesion. Better not to take piecemeal. I'll go extra capsular. No, drill. I want to go extra capsular. If you meddle with the hemangioma, I said I might be able to do a orbital transposition. Hey, the surgical is caught. Irrigate, please.
Oh, suction lines.
Suction wood. Muzzle. Okay, let me go in for this hemangioma. I'm going to do two-handed. Or cat's paw. I'm going to do it now. Just have a look at what I do. Suction, please. So that's the one intracranial. Can you all see the lesion now, all of you?
Yes,
Yeah.
yes, sir. That is seen in the scan.
Hey.
Biopsy.
That's a googly.
Yes.
Exactly. That's
Yes,
a
sir.
googly.
Hey. No, give me a culture swab. This looks like a dermoid.
Derma.
Or a mucosal. It could be a mucosal.
என்னப்பா பில்டப் பண்ணா இதுதான் unexpected. Anticlimax ஆயிப்போச்சு.
இல்ல, the hemangioma is still there on the carotid, boss. No, that is still there.
This is
an
breather.
anticlimax. Hey, I want a bigger
small
needle.
breather. No, but good. Considering it's attached to the frontal lobe or whatever.
What sir?
Considering that this is attached to the frontal lobe or whatever.
Yeah.
This may come in a nice plane.
Yeah. Hey, give me a ball probe. I'm just going to open up that small nick which I made. Only hope that I will not. So this content looks definitely like a mucosal. Mucopyocele. I've never seen a mucosal. Anybody has got an experience of this kind of tumor inside the brain?
Unless that place was meddled before.
Unless?
If that place was meddled before by another surgeon, yes, you will.
Good answer.
Yeah.
Hey, give me a suction tip itself, man.
What is it?
Oh, give me a suction tip. Culture swab. Spinal needle. Hey, no, you just give me a suction tip, man. Curved suction tip, that's enough for me. No, man, this is not working.
Wait, sir. I have another one for you. Wait.
Just give me a curved suction tip. Aspirate. Lakshmi, aspirate. Go. Aspirate. Aspirate. Podum. What, boss? Give me this one, Rosens or something like that. Let me marsupialize it. See the dura.
Not liquefied brain, no. Not liquefied brain, no, I said.
So we call it Kaliman irukku appadina. You remember that? Mandala enada Kaliman vechirukka appadina. Like that. Mandala enada ivlo see vechirukka. Hey, why are you going on talking? Now comes the last part of that carotid artery. Suction. Hey, give me a 30-degree telescope or a 70-degree telescope.
70 degrees, 70 degrees.
Want to see the dura?
70 ready.
Oh my goodness. So anybody, any comments, any comments, any comments? Tuck, I want the diagnosis immediately. It's the mucocele of an onodi cell.
Again,
It's the
is that
mucocele of the
color,
onodi cell.
again, that red color or reddish blue you see, it's the
This
carotid
is the
there?
optic nerve. This is the optic nerve here.
Yeah. But below
So
that,
that's the mucocele of the onodi cell.
yeah.
Of course, that's the dura here. Above is the dura. The above is the dura. This
Isn't that the carotid or that where you're touching?
Yeah, that's a carotid. Yeah.
Yeah.
So that's a mucocele of the. Come, Shilpi, let's finish off. Come on. So now it's straightforward. We have done the case. Just want to take off. Give me a good wash. And final over the carotid. Give me a good wash, man. Good wash. Hey, all of you get ready. I'm going to deal with that bleeding as well as remove the tumor. Wait. Hey, suction is working.
New section is
Okay, madam, maybe I'll finish it, fast, or maybe I might not finish it also. I can't tell you right now. Depends on the bleeding which I might encounter. Okay, ready. Mucocele of the onodi cell. That is the sella, that's the clivus. Give. No, Blexley. That's a muscle. Have this muscle, man, with you. I need this muscle. Now, give more. Now, I'm going to remove this gauze piece and then see what I can do about that bleeding. Okay, that's the clivus. This is the carotid here. Now, this is definitely the tumor over the carotid artery. Now, the problem is if I manipulate it too much, I might develop a pseudoaneurysm. Give me a ball probe now. I'm going to do a little blunt dissection here. So that's the tumor here. Hey, muscle is there. Give me a Doppler, please. Let me check if that is a little carotid over there. Keep irrigating. Keep irrigating. Keep irrigating. Keep irrigating. Keep irrigating. It's okay. Keep irrigating. Keep irrigating. Keep irrigating. Keep irrigating. Give me a Doppler now. Keep irrigating. Wait. Check.
Irrigation.
Yes, sir.
Can you hear? Now I'm going to remove that. In any case, give me a ball probe. Let's go for it, my dear friends. Or else this patient will not be all right. This right over the carotid artery. Lexley.
Ready.
Yes, we got it.
Yes, sir.
You saw that? See, that is where the perforators were coming. Come closer. See the vessel. See the vessel.
Yes, sir.
Can you see?
Yes, sir.
Yeah, very clear.
My God, see the feeder vessel. No, I'm going to drill. Give, drill. No, Shilpi is saying stop. I'll not stop. Drill.
Shilpi is speaking for all of us actually.
Hey, drill. No problem, don't worry. I exactly know what I'm doing, my dear friend. See, there's another hemangioma. Can you see here?
Yes, sir.
Yeah.
Biopsy. Hey, where's the vessel? Show me the vessel. Ah, there. Okay.
Should I continue? No.
Hey, can you please shut up?
Janaki,
Show me the vessel, my dear friend. Show.
Thank you, Deepak. Don't do anything.
Hey, go closer.
Fourth bar.
Hey, Doppler. Hey, irrigation, Doppler. Quick. Sir, yes, you asked me something, Deepak ji.
I said what a case to finish the course today.
Sir, I am running on an electric wire.
If you say an encore, this is it.
If you say that you're running on an electric wire, it doesn't look. It looks like a swan swimming on the water, but the legs are moving very fast below. So we are only seeing a swan on the top. I don't know how you say that you are on an electric wire.
Yes, sir.
Hey. Sorry. Come out. Where's the optic? Drill. Hey, एक शो वीडियन दिखाओ ना. वीडियन है यहाँ पे. फिर ये है कैरोटिड. फिर ये क्या है? हॉरिजॉन्टल कैरोटिड में ऊपर क्या? ये वीडियन है ना? हाँ. ये क्या है? ये क्या है? अरे यार.
I want a default.
Hey, give me a Doppler again, please. Doppler, that's a VDN, but it's going just, the lesion is going lateral and over the horizontal carotid. Give. Digao.
Sir, why there is continuous sound instead of pulsatile sounds?
What?
The sound is continuous sound, sir. Actually, if it is arterial, the pulsatile sound within, sir.
Hey, wait. Just go inside. Go closer, please. Give me now the Doppler. I have removed the hemangioma completely. Did you see that?
Yes, sir.
Give the Doppler. I know now where the carotid is. Just behind this. Yeah, behind it is the carotid. There's a little bone over it. I don't want to do anything there. That's the artery which was supplying. See here, that is the artery. Can you see here?
Yes, sir.
No, I'm trying. See how. Hey, go closer. Hey, give me a bipolar. Bipolar, yeah, bipolar. Go closer, Shilpi. I've never seen a vessel like this. Okay, I think I'm done.
Wow.
I'm just going to take off this alone. So
Super show, Janki. Super,
Sir,
yes.
Thank you so much, sir. Really.
They call it the grand finale, no?
Drill. Now I'm just going to make that sphenoid lookable.
No, do
so
it.
that
We are there. No problem.
this will take 1 minute for me.
Deen Dayal sir was amazing company.
I enjoyed every minute, Janki. Wonderful show.
Sir, it's a privilege to operate in front of a teacher, sir.
But I loved every bit of it. It's so good. It's one of those once in a lifetime things
Yeah,
you
yeah,
can
yeah.
see the whole thing right from the start to the end.
No, I was so surprised that you are sitting till the end, actually.
How can I leave this? Such a beautiful demonstration. And I would say I want to ask you a few questions as you are doing this.
Yeah, please.
What are you going to do with the Haddad?
I'll place it on the carotid. See, this is the carotid exposed. I want to place it over that.
So now, just another loud question, whether you would use a fine, diamond burr to completely the clival area and around the carotid area, wherever there is a little bit of the cancellous bone, would you like to use a fine diamond burr or no?
I wouldn't actually, because I'm happy with what we have done right now.
Okay.
But in case you want me to do that, I'll do that. But
because there's still a little bit of cancellous type of bone there, so fine diamond burr would clear up most of the thing, I felt. So that, it's something like doing a mastoid surgery, the finer part of it.
yeah, but actually the aim was to remove the hemangioma. I think according to the scan, I think we have removed it except for the parietal bone. So of course, yeah, as you say, polishing would definitely be lookable, but doesn't carry extra weight to for disease clearance.
Okay.
Of course, I can do that. There's no doubt about it. I am see that's already see the bone here. Beautifully.
Yeah, that is the type of the bone I was talking about.
Yeah, this you cannot do. This area, even if you do it, I have to remove all this bone. Give me a drill. I have to remove all this bone. It's not that it'll. This bone is not like this. See, there are two things. In the clivus, we have 3 bones.
Yep.
3 bones. Number 1 is the outer cortical bone. This is the outer cortical bone.
Yep.
The middle layer of marrow. This is what I'm drilling. The middle layer of marrow.
Yeah.
And finally, there will be another inner cortical bone.
Right.
So here in the floor of the sphenoid, it's not like that. This is all marrow.
See, now that with your drill over there, you see there's so much of a change in the floor.
Yeah.
Yeah, that's all I was asking, whether you can give that sort of a look.
Oh, okay. That
so
was in my
what
plan.
happens is that invariably, if you're going to put the Haddad over that, tomorrow even the slightest chance of bleeding also will not be there.
I fully agree with you, sir.
I mean, when we have done so much, why should we compromise at that level?
Oh, fully agree, sir. Fully agree, sir.
Very, very well demonstrated, Janki.
Sir, all your blessings, sir.
Oh, definitely our blessings are there.
What more can I say?
Job.
I think all his bleeding was from that bleeder which you finally bipolarized.
Yeah.
All his bleeding episodes were due to that feeder coming from the carotid.
I told you, no. I saw that.
Yeah.
The moment that was there, no, I saw it was a feeder. Or else I will not proceed, sir. Shilpi said, why are you proceeding? Stop, we'll go. I said, boss, I know what I'm doing. See, that is what I call.
Deen Dayal sir said here in the audience when he was sitting with us here. He said he knows what he is doing.
Yeah, I told you in that lecture also, the eagle's eye. The eagle's eye, the eagle notices it from kilometers away, and just a small fish, it just dives, it catches hold. That is skull base. The moment it comes, you should be able to pick up. God gives one chance, you know exactly what you're doing, or else just stop. That's give me a drill, please. So you have the optic here, the planum there. So even if somebody wants to follow up the case, there will not be any confusion. They will not think, oh, what? Hey! Sorry. So you can see the sella there, the clivus there. Very, very clear now. Now give me a good wash. Nageshwar Rao Garu. He ran away, I think. Are you there, sir?
I think this patient can be discharged after 48 hours.
3 days better, sir.
3 days. I still feel a little fine drilling would help, Janki, if you don't
Yeah, I'll
mind.
do that. I'll do that. I'll do that. I'll do that.
Because this fellow must have roamed around everywhere and he has come
Yeah,
to you as
sir,
a,
from Bombay.
as the last
Bombay.
resort. I mean, it'll be a lot of good you have done for him.
So all your blessings, sir. What can I say? Blexley. Yesterday I received 4-5 calls from Bombay. Oi, you be careful, he's my relative. I said, boss, I can't do anything for his blindness. Not possible. No, remove just that epistaxis. Drill. Huh? Yeah, I think you can go. Hey, Lakshmi, thank you very much. Really, I think we should give a big applause for Lakshmi. Thank you so much, Lakshmi. You did a great job. It would have been difficult for this case especially. Thanks a lot. God bless you, Lakshmi. Do a great job in Chennai. God bless you. People are watching from Chennai, definitely. Drill. As Dr. Deenadayal sir says, do a little more drilling so that, I have a better picture.
Hello, Dr. Janaki.
Yeah.
Can you compare radiological findings now? Now
Yeah,
that you are done.
Dr. Shyam sir only, no? I'll do that, sir. One second.
Yeah.
Hey, can you go, sir?
Not much of a difference once that is done. See. That irregular part, I don't know why it is not there because of the bleeders that is present, which he has. At just inferior to where you have, I think, diathermized the bleeder.
Here?
No, a little below and medial. That one. I think it's come out beautifully.
Okay, so I'm going to, just pack it. Thank you. Keep muzzle there. I'm just going to get the camera there, man. Get the camera. Hello, camera people. I want to just correlate this now. Beautiful question by Dr. Shyamji. Wow. What a scan. What a correlation. See here, sir. Now let us describe here. What is this? What we found here. Okay, hello.
Yeah, we can see the scan.
Okay, now
I think can the brightness be reduced? Yeah, now it's fine.
I hope you can see my hand here. See,
Yes.
that's the optic apex. So there was one here. We couldn't actually make out what that was, but it was not enhancing also. So see, that one was the one which I was terrified about because it's entering into the brain. But that was actually a mucocele of the onodi cell, definitely above the sphenoid sinus, below the level of the skull base. So this is onodi, for sure that's the onodi, and we removed that. Okay, fine.
But Janki, this was a MRI with contrast done for this?
Yeah, this is the MRI with contrast, sir. See here. See.
But MRI should have made out the
Any
mucosal.
proteinaceous content will enhance. There is a proteinaceous content, no.
Okay.
In T1 it will enhance.
Okay.
But more importantly, this was the lesion. See here, this was the lesion.
Yeah. Which you removed wonderfully.
Very clearly that was a lesion on the left side. Going towards the carotid, this is the carotid artery here. And to correlate, this was where the feeder was there. The feeder was going like that.
The feeder and the bleeder from the feeder was the exciting part today.
Oh, yeah.
And the noise of your Doppler when you put
See,
it
that's the
there.
lateral carotid. That's the horizontal carotid.
Yeah.
And exactly here was the bleeder here. That was the bleeder. And as Dr. Deenadayal sir correctly pointed out, just drill that last hook. And we drilled that and made it into a... But there, if you look at the sphenoid, there is no anatomy at all. Did you see? There is no anatomy.
Exactly.
Absolutely no anatomy.
Yeah. Yeah.
and asking for LOCR, nothing was seen, nothing. But now we have completely delineated the plenum, everything now is seen. So this was the lesion, we removed it completely. This was the lesion. Now
Fantastic.
I'm
Shall
sure
we,
that this
shall we
guy,
all give a big hand to Janki?
Yeah.
Because I think it's wonderful.
Super show.
sir, thank you very much, sir.
Unbelievable stuff.
Wonderful show. This patient will definitely improve and you have helped this patient out.
Thank you, sir.
And this was the case of the course.
And the time is 5:07. You're only 7 minutes late.
Oh my God.
And poor Lakshmi has to go today only, forgetting the flight.
Sir, I may not be able to come there. Really want to thank all of you, especially senior surgeons like Professor Deenadayal sir. If I start naming, 250 people came.
Yeah.
But the faculty, I want to definitely thank Professor Milind Kirtane sir, Professor Deepak Haldipur sir, Madhuri Mehta madam who came here. And then, of course, I want to thank Prathamesh Pai sir and
Sir,
Nupur Kapoor
Nageswara
madam.
here, sir. It's a wonderful case. First of its kind in the world, sir. All are
That I don't
enjoyed.
know.
All
But,
are enjoyed, sir. Really, you are born for this Kalbes, sir. Really, yes. God's gift for the poor and certain patient like this boy, sir.
And even the moderator, first of his kind in the world.
Excellent demonstration, sir.
Sir, I also thank my team, Dr. Shilpi Bhatia Sharma, Dr. Shiva
We'll
Kumar,
all give a
Dr.
big hand for them also, please.
Yes,
A
sir.
big hand.
Dr. Shiva, Dr. Purva who is there, and Dr. Bhavya who is here, and Dr. Avinash. I don't know if Avinash is there. Avinash, are you there? Thank you very much. And I want to thank the anesthetic team. Very surprising to see husband and wife standing side by side and giving anesthesia. Please focus on the couple. See,
big
focus
hand
on the
for
couple.
them. Big hand for both of
Yeah.
you.
This is husband who is an intensivist anesthetist, and wife, both of them are dedicated people. And I told them we are doing it free of cost, and they agreed for Vasavi. It is really a big boon.
Fantastic.
And of course, my staff nurses, as I told you, with a VP Shant one is standing, and Anita, then Aishwarya, Anandi, all of them are from Trichy. Ramesh, Beulah, my whole staff team is actually from Trichy. We have placed them in Hyderabad with a house here. So that is how we have planned. So I think we will call it a day. I thank the Sun Pharma, especially the GM, and then Mohan sir, and also the anesthetist technicians, and our boss. He always has a smile and takes a photograph. Surender Garu, my lovely friend in Vasavi, and thank you very much, all of you. Sun Pharma, you want to have any closing remarks? You can please tell.
Yes, sir. Yes, I will call sir in a minute. Just give me a minute. Before I hand over the mic to Amit sir, I would like to request the audience if they want to share their experience about the workshop.
Dr. Sham sir, I want you to share something. Dr. Sham sir is one of my mentors, guides in Hyderabad. One of the main reasons why I am staying in Hyderabad are few people. One is Dr. Sham sir. Second is Dr. Surendra LSR sir, LS Sudarshan Reddy Garu. All these people are really helping me a lot. Help is by moral support, that we are all there like that. So Dr. Anand Acharya sir, all these people are there. Thank you so much, sir. You can carry on, Dr. Sham sir.
Good evening, Janki.
Good evening, sir.
Yeah, God has sent you here to elevate the ENT fraternity to the next level. So it is very nice. Everybody are learning now. And I am really privileged that you accepted the invitation of starting in Vasavi and taking the hospital name to a greater height. Thank you very much for your work, whatever you are doing. And the management is also reciprocating to you. Thank you very much once again.
Thank you, sir.
Oh, Janki,
Yes, sir.
I have been sharing my views with Deepak.
Sir.
I said, is it the 180 cadavers he has dissected? Or is it the Sattvic person who can fool anybody by his looks, but who has a hand over his head? Something like divine, that you have what is called as the sixth sense, where you're going and what you're doing. The best part is you are helping those needy patients who need you, And that is what I want your expertise to be there. The rest of the smaller stuff, there are people who can do. There are many, many people who can do smaller stuff. You are there for the big things where others might find it difficult. You need to help each and every patient, and that is where you will be blessed. Our blessings are there. God bless you.
Thank you, sir.
Dr. Janki sir, you are making the impossible possible.
With
That's
you,
what
sir,
I have to say.
everything is possible, sir. With you.
And from the faculty side, the humility with which you attended to each one of us made us comfortable, looked after us, though you are a celebrity by yourself, was simply astounding, outstanding.
Thank you, sir.
I request Dr. Sudarshan Reddy garu to speak few words about this workshop.
Thank you all for attending the workshop, and Sun Pharma for giving the opportunity to conduct this. And no words to tell about Janakiram. He has done excellent workshop, and the way he conducted and the way he mingled with the guests, delegates, down to earth. Congratulations to whole team of Sun Pharma, Royal Pearl Group of Hospitals, Vasavi Hospital, and everybody who made this a grand success. Thank you.
Thank you, sir.
Thank you, sir.
I request Dr. Krishna Kishore garu, ENT skull-based surgeon and cochlear implant surgeon, Visakhapatnam, to speak about the workshop.
Yeah, it's been one of the excellent workshops I have attended, and all the aspects of ENT are well covered in this workshop, starting from head and neck and the phono surgery, but not all, the rhinology, otology, everything, and top of that, the skull-based surgery, where Dr. Janakiram has demonstrated the surgical marvel. And spellbound, we are all spellbound by his surgical techniques. And as Dr. Shyam has put it, he is taking ENT to a different level. I'm sure all the youngsters are going to get inspired by his work a lot, and we are going to see more and more number of surgeons who are going to serve the needy for the society. You really are doing great job, Dr. Janki. God bless you. Thank you. Thanks, Sun Pharma, for giving this great opportunity.
Thank you, sir. I request Dr. Jadhav garu to speak about this workshop.
Hello. Sir, I am coming
Thank
from
you.
remote place, Surendranagar, which is 100 kilometers away from Ahmedabad in Gujarat. I am associate professor there. Many a times I was thinking to meet you. I know many things about Kirtane sir, Nupur Nerurkar sir, Prathamesh Pai sir, everything. And it is a chance to talk with everybody, to clear all the funda after talking and clearing all the doubts. So it's an excellent workshop, and it's a boon for us to take our knowledge to heights and to share, same thing share to our juniors which are studying with us, undergraduate and postgraduates with us. So once a time, I would like to thank you for arranging nice workshop and everything, which is targeted to us, especially for us, which ENT should take at other heights. Thanks a lot, sir. Thank you.
Thank you, sir. I am Dr. Basu from Asansol, long way from Kolkata, West Bengal. So I met you last in Bombay, and again Last month, I have seen you doing surgery when we are in Goa. It was an excellent CSF league. Again, this 2 days of feast was excellent. Last of all, I can only say that khub bhalo hoyeche, excellent. I pray to God, I pray to Almighty for success. Thank you.
I request Dr. Sri Prakash, Senior Consultant, Micro Ear Center, Kokatballi.
Good evening all. When I heard about Royal Pearl team coming to Hyderabad, really I felt very happy because I know Dr. Janaki is doing extraordinary work for last 20-30 years. When I was in PG, I used to think about skull-based surgery, but at that time only we were thinking about foreign faculty when we are doing skull-based surgery here in workshops. But now Dr. Janaki has made it possible and is teaching juniors very well, and is making so many skull-based surgeons in future. And we are happy to welcome him to Hyderabad and to start his Royal Pearl group here and to encourage new people, new juniors to come into the skull-based surgery. And thank you.
I request Dr. P.J. Mandal, sir, to speak about this workshop.
Thank you. So I'm Dr. P.J. Mandal. I stay a little far from Kolkata. And today it feels great that the neurosurgeon people are referring patients to ENT. It is not, it hardly bothers to a society whether I am educated or not, or whether he is educated or not, until the light of this education reaches to other people. So I hope that Dr. Janaki Ram will impart his lessons and his education to all of us who are here and will enrich us so that more and more neurosurgeons refer to us, to ENT fraternity. Thank you, Dr. Janaki Ram.
Thank you, sir. Finally, a few words about you, Dr. Janaki Ram Garu. You are very
Janaki told us one more thing.
Sir?
He said, "Ye to abhi trailer hai."
Sir,
Picture puri baki hai.
what was your age, sir, at the start of your skull-based surgery? Because we are nearing to 50. Can we start? Is it the time to starting from at what age you have started the skull-based surgeries?
Here, Janaki, for a second.
There is no age for starting anything, sir.
Yashwant, you see,
Mario Sana started at 55.
Sir.
His first acoustic at 55. At 75, he was ruling the world.
Sir.
He himself told me.
the writer Khushwant Singh wrote his first novel at 55.
50.
Boman Irani got his first film at 48. And Modi got into parliament at a much later age than Rahul Gandhi.
There is no age. There is no
Yes.
age. The only you should have the mindset. Mindset to learn, mindset to expand your knowledge, mindset to be receptive.
Sir,
Receptive.
we
The main problem is two things. One is ego. Second is laziness. If these two are not there, anybody can learn at any age. There is nothing. Even a junior can teach, senior can teach, nothing.
No, and I think the third one I would like to add,
Sir.
fear of failure.
Fear of failure, yes, sir.
So always drink Mountain Dew because dar ki aage jeet hai.
Lovely. Lovely.
Sir, thank you very much, sir. You have shown the entire endoscope world to the entire world. These 2 days, especially this evening case. Wonderful workshop. We are very much appreciated. And I thank your team, especially my Avinash and Madam and Lakshmi Madam and other teams. And thank you, sir. And we wish you all the best for the future workshops like this. At least once in 2 months, like this workshop in Hyderabad, all the people can all come over here. So all the best, sir, for the future.
I have already told Dr. Deepak Haldipur ji, and he has promised hereafter he will definitely do it in Hyderabad. He has already promised he will definitely do it.
Wherever you go, you please take me with your team, sir. I will come and do it.
You have to put the application to him.
Sir. Thank you very much, sir.
Congratulations once again for a splendid show, sir.
Vote of thanks, Dr. Purva.
Yes, sir. It's my privilege to thank all the surgeons who demonstrated surgeries in the past 2 days, where especially we young ENT surgeons, got to learn from few of the best minds in ENT. I would like to thank even the keynote speakers, delegates, and participants for joining us for this 2-day live surgical workshop and making it a successful grand event. We would like to specially thank Milan Kirtane sir and Janakiram sir, who are the mind behind this workshop. I would like to present a special thanks to AOI Hyderabad and Sun Pharma for supporting us. I would like to invite Mr. Amit Shukla sir to give his vote of thanks. Thank you.
Good evening, all the respected doctors. I am Amit Shukla from Sun Pharma. And believe me, sir, I am speechless. There is a very old saying, God cannot be everywhere, so he created doctors. And today we can feel the way Dr. Janki Ram has done this surgery, and the top of it free of cost. So the power of saving lives, which God has given to each one of you, is something which is valuable and priceless. One of the biggest example which the Indian doctors has shown in front of the rest of the world during the COVID. The way all of you, your colleagues, paramedical staff have handled COVID and saved the life of many millions of Indians. This is something which is really remarkable, commendable, and all of us are really honored and privileged to be a part of the country like India. So thank you all. So to start with, I would like to give my very sincere thanks to all the faculty, especially Dr. Kirtane sir, Dr. Deepak Haldipur sir, Dr. Pratmesh Pai sir, Madam Nupur, and Madam Madhuri Mehta. A very special thanks to a person who is full of energy, Dr. Janki Ram sir. Dr. Janki Ram sir is a combination of not only skills, attitude, lot of energy, lot of positivity.
But he never tells the secret of his energy. Every time he is escaping, but he never tells the secret of
I
his
always say, sir, secret of energy comes, the highest energy comes only when you give, not when you take.
Yes, sir.
If you give without expectation, energy will flow.
So from last 2 days, what I learned from sir is lot of positivity. And if we have, all of us have a lot of positivity, then positive things are bound to happen. So my thanks, special thanks to sir, not only for performing such a wonderful live surgery, but also helping Sun Pharma to make this event successful. So a special thanks to Kirtane sir, Janki Raman sir, for conceptualizing this and make it happen. So thank you, sir. Thank you very much. A few feedbacks about the last 2 sessions. There are many medical colleges, AIIMS Gorakhpur, where they have not started their OPD yesterday. They were so happy to see the live surgery workshops yesterday that only a few members could able to see the OPDs. And a lot of feedbacks we got from various medical colleges and various centers, and a lot of appreciation we got, though we should not take the credit for those appreciation. All the appreciations are gone to the faculty because of the wonderful surgical procedures and techniques performed by each one of you. So thank you very much. We at Sun Pharma is really proud to be associated, privileged to be associated, honored to be associated with this type of workshop, and we would love to carry it forward every year with much better, we can say, arrangement, involvements, and whatsoever we could not able to do this time, we would definitely like to do next time. We thanks to Dr. Deen Dayal sir for accepting.
Amit sir,
yes,
I think you should conduct it every year, Elite ENT Club.
Yes, sir. Yes, sir.
And I request you to do it in Hyderabad itself.
Okay, sir. Okay, sir. Yesterday midnight, we tentatively decided the dates, 7th, 8th, 9th, 10th September. In the morning, we discussed with Kirtane sir, just waiting for your approval.
I am always there.
So I would like to thank all the participants who are not only here, but also connected from last 2 days in more than 90 medical colleges and web centers across the country. my very sincere thanks to each one of them for sparing their valuable time and coming to the platforms wherever we have requested for. A very, very special thanks to the team of Dr. Janki Raman, Dr. Avinash, Dr. Majid, Dr. Purva, and many more. I could miss the name, but without their support also, it was really difficult to make it happen. I would like to request and I would like to appreciate the efforts done by Team Sun Pharma. My colleagues, not only who are here, like Dr. Ganesh, Dipankar, Ranveer, Mahesh, but also all the colleagues who are there in the various centers and medical colleges. So once again, thank you very much, sir.
Sir, I want to
giving us
thank two
opportunity.
people. I want to thank two people who are the backbone of this workshop. Number one is Avinash Nalluri. He has actually, let us give a big clap because he was actually traveling pillar to post for all the cases. And because of him only, we got all the cases. So, final thanks to Avinash Nalluri, fantastic person who is the regional admin of Hyderabad. The second thanks goes to Dr. Nazim Majid. And she also has done a lot of groundwork to make this workshop a grand success apart from the arrangements made by Sun Pharma. Thank you, Ms. Amit ji and Mohan ji, everybody. Thank you very much.
Thank you, sir. And on behalf of Sun Pharma, our heartfelt thanks to AOI Hyderabad for really giving us opportunity to conduct it the way it was. Thank you very, very much to each one of you. Just one moment, sir. Just one moment. Dr. Purva. We'll take just one more minute, sir.
I would request Mr. Amit sir to felicitate Deen Dayal sir. Thank you, sir. Thank you, everyone. Thank you, Janaki Ram sir. We are closing the session. Thank you. Thank you, everyone.
Madam, thank you very much. Really big thanks. Whole India has seen.